Phyllis Arthur, good morning.
Good morning, everyone. I'm Mina Zadeh. Can everyone hear me? We'll get started. Good morning. I'm Mina Zadeh, serving as the designated federal officer for the Advisory Committee on Immunization Practices. Welcome to the December 4th and 5th, 2025 meeting of the Advisory Committee on Immunization Practices. I will now go over a few logistical items for this meeting. All presentation slides are available or will shortly be available on the ACIP website. For participants joining via Zoom, a few quick reminders. Please keep your line muted unless you're recognized to speak. When the discussion period opens, use the raised hand function in Zoom if you would like to be recognized. Questions will first be taken from the voting ACIP members and ex officio members, followed by dedicated time on the agenda for questions and comments from the liaison representatives. The Advisory Committee on Immunization Practices is a public body, and transparency and engagement are central to our work. This meeting includes a verbal public comment session today at around 2 p.m. Eastern Time. Requests to provide oral comments must be submitted online in advance. Priority is given to advanced requests, and when demand exceeds available time, speakers are selected through a blinded lottery. 10 speakers are selected for this meeting and have been notified. We thank all who expressed interest in sharing comments. Members of the public were also invited to submit written comments through regulations.gov. The docket number for this meeting is CDC 2025-0783. More details on the public comment process are available on the ACIP meeting site. In accordance with ACIP policies and procedures, members agree to forego certain vaccine-related activities during their tenure. For activities that may enhance expertise, the CDC may issue limited conflict of interest waivers. For example, members conducting vaccine clinical trials or serving on data safety monitoring boards may present on those vaccines but may not vote or on related matters. For other vaccines from the same company, members may join discussions but must abstain from voting. At the beginning of each meeting, ACIP members disclose any relevant conflicts of interest. We'll now proceed with roll call, beginning with ACIP members, followed by ex officio members and liaison representatives. For ex officio members and liaisons, I will call your organization. Please respond with your full name to confirm your presence. As you also know, Dr. Martin Koldorf has taken a position as a Chief Science Officer within the Department of Health and Human Services and therefore has had to step down from ACIP as a member and chairman. We would like to express our sincere gratitude for his significant role and commitment to ACIP and look forward to continuing to work with him in his new role. We would like to welcome the new ACIP chair, Dr. Kirk Melhone. Because he's joining us remotely, the ACIP vice chair, Dr. Robert Malone, will be facilitating this ACIP meeting. And now we'll turn it over for introductions to our members. If you would please state your name and if you have any conflicts.
So we're going to begin with Jim Pagano.
Hi, James Pagano, retired emergency physician. I have no conflicts.
Hillary.
Hillary Blackburn, and I am the Director for Medication Access and Affordability at Ascension RX. Views expressed in this capacity are my own and not of my employer or any other group. No conflicts.
Evelyn.
Evelyn Griffin, OBGYN, no conflicts of interest.
Robert Malone, physician and scientist, recently appointed adjunct professor at LSU, and I have no conflicts of interest. Mina, you're already here. Do you need an introduction? Vicki?
Vicki Pebsworth. I am the Director of Research and Patient Safety for the National Vaccine Information Center and the Pacific Region Director for the National Association of Catholic Nurses. I have no conflicts of interest.
Retzif?
I'm Rezef Levy. I'm a professor at MIT, and I have no conflicts of interest.
Catherine Stein is currently in transit and is expected to be here soon, and we will acknowledge her upon arrival. Is that, and ask her whether she has any new conflicts of interest. Dr. Pollock.
Raymond Pollock, retired transplant surgeon, NIH-funded immunobiologist in transplantation. I have no conflicts of interest.
And then we have three members dialing in remotely through Zoom. The first is Cody Meissner. Cody, are you there?
Thank you. Yes, thank you, Robert. My name is Cody Meissner. I am an independent contractor supporting BARDA as a senior vaccine and biological development analyst. I'm a board-certified pediatrician and certified in pediatric infectious diseases. I have no conflicts, and I appreciate the opportunity to participate in the meeting this morning. Thank you.
Next is our new chair, remotely, Kirk Milham.
Thank you very much. It's a true honor to be named chair following Dr. Koldorf's promotion to his position in HHS. I am first a scientist with a PhD in physiology and pharmacology. I'm board certified pediatrician in pediatrics and pediatric cardiology, and I have no conflicts of interest. Thank you.
And Dr. Joseph Hibling.
Good morning. I'm also pleased to be here and participate. I'm a distinguished professor at the University of Bristol in the UK. I'm a board-certified practicing psychiatrist, and I have 30 years of experience as a scientist, the intramural program of the National Institutes of Health, looking at the role of food in brain health and specifically neuroimmunology and their impacts on child development and on psychiatric disorders. I have no conflicts of interest.
And Mina is going to now review our ex officio members and affiliates.
Thank you. CMS?
Good morning. Andrew Johnson, Senior Advisor, Centers for Medicare and Medicaid Services.
Thank you. FDA?
Good morning. Tracy Beth Hogue, recently appointed last night to Acting Director of CDER at the FDA. Thanks.
HRSA?
Reed Grimes, representing HRSA.
IHS? We'll come back. NIH?
Michael Carilla, NIH.
Great, thank you. And now we'll move on to our liaisons. American Academy of Family Physicians.
Good morning, Dr. Laura Morris, representing American Academy of Family Physicians.
American Academy of Pediatrics. American Academy of Physician Associates.
Good morning, Marie-Michelle Léger, representing AAPA.
Thank you. American College Health Association.
Hi, Ashley Halberter, representing the American College Health Association.
Thank you. American College of Nurse Midwives.
Yes, Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Naima Joseph, present.
Thank you. American College of Physicians.
Good morning, Dr. Jason Goldman, President of the American College of Physicians, Affiliate Professor of General Internal Medicine at Florida Atlantic University. No conflicts.
Thank you. American Geriatric Society.
Dr. Ken Schmader here for AGS.
Thank you. America's Health Insurance Plans.
Good morning, Lori Kaloya, representing America's Health Insurance Plans.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle and Tisha Lucas, representing ERA.
Thank you. American Medical Association.
Dr. Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Barbara Resnick, representing the ANA.
American Osteopathic Association.
Masood Mahmoudi, present. Good morning.
Thank you. American Pharmacists Association.
Good morning, Dr. Kelly Good, representing the American Pharmacists Association.
Association of Immunization Managers.
Robert Schechter, AIM. Good morning. Thank you.
Thank you. Association for Prevention, Teaching, and Research.
Dr. Catherine Williams for APTR, present.
Association of State and Territorial Health Officials.
Dr. Susan Consagra for ASTO.
Thank you. Biotechnology Innovation Organization.
Good morning, Phyllis Arthur representing Bio.
Thank you. Council of State and Territorial Epidemiologists.
For Christine Hahn for CSTE.
Thank you. National Association of County and City Health Officials.
Hi, this is Dr. Judith Schley from the Public Health Institute at Denver Health Family Physician, representing NACHA.
Canadian National Advisory Committee on Immunization.
Matthew Tunis, present.
Thank you. Infectious Diseases Society of America.
Dr. Flor Munoz representing IDSA.
International Society for Travel Medicine. National Association of Pediatric Nurses Practitioners. National Foundation to Infectious Diseases.
Dr. Bob Hopkins and Dr. Jeff Goad for an FID.
Thank you. National Medicine Association. Pharmaceutical Research and Manufacturers.
Yes, Michael Ibarra, Chief Medical Officer at Pharma, present.
Thank you. Pediatric Infectious Diseases Society.
Good morning, Dr. Grant Paulson, representing Pediatric Infectious Diseases Society.
Thank you. Society for Adolescent Health and Medicine.
Good morning, it's Amy Middleman representing SAM.
Thank you. Society of Healthcare Epidemiology of America.
Dr. Preeti Mehrotra here for SHE.
Thank you very much.
This is Stacy Buchanan. I'm representing the National Association of Pediatric Nurse Practitioners. I was muted and unable to respond.
Thank you.
Good morning, it's Tanya Hutchins.
Clark representing the Indian Health Service.
Thank you.
Good morning, this is Dr. Sonia Hutchins. I'm representing the National Medical Association.
Thank you. Okay, I'll turn it over to our Vice Chair.
Thank you, Mina. So I'd like to read an opening statement today. Good morning. My name is Dr. Robert Malone. I'll be serving as your meeting chairperson over the next 2 days. I want to start by thanking all ACIP members, working group members, and support staff for being here and for the work you've been doing in preparation for this week's meeting. I know it's not been trivial. This is my third meeting since beginning service as an ACIP member, and it's an honor to open this meeting today. We have a full schedule over the next 2 days, and before we start, I wish to highlight and specifically thank the members of the Hepatitis B Vaccine and Childhood Vaccine Schedule working groups operating under the leadership of Dr. Vicki Pebsworth, particularly those that freely shared expertise and advice relating to hepatitis B vaccines, adjuvants, and related clinical and public health policies. The work we have done to prepare for today relies upon internal work group discussions, but form the basis for what will be discussed and the recommendations we will make to the CDC Acting Director. Dr. Martin Koldorf, our guide for the previous 2 meetings, has now moved up from the ACIP to serve inside the HHS as a key advisor to the Secretary, and Dr. Kirk Milhound, who was first introduced at the last meeting, will now serve as chairperson. Speaking personally, I have known Kirk, as well as his amazing wife, Dr. Kim Milhound, for a few years now, and when asked, I endorsed his appointment without reservation. So please join me in welcoming Dr. Kirk Milhound as the next chairperson of the ACIP. He is eminently qualified. I'll be serving as chairperson for this initial meeting under his guidance, as Kirk is attending virtually, as you know. According to the ACIP charter, the main duty of the vice chair is to serve as interim chairperson when the appointed chair is not able to attend the meeting in person. I can assure you that Kirk has been very active in providing leadership since his appointment while maintaining his busy clinical practice as a pediatrician and pediatric cardiologist. I want to formally open this meeting by acknowledging the principles that must guide ACIP's work. These are key: evidence, transparency, and a willingness to look critically at the data before us to ensure that the recommendations we make are grounded in evidence-based science and best medical practices. The primary mission of the ACIP committee is to provide independent advice, I underscore independent, to the CDC director. Our responsibility when developing advice is to evaluate the totality of the evidence as it exists today, with scientific rigor, intellectual honesty, and courage to ask and answer the hard questions. Once we reach a majority opinion, we're also tasked with clearly communicating our advice and reasoning to both of our key clients, two key clients, I want to emphasize, the CDC director and the American public. Many of you will recall that in September, ACIP deferred a vote on proposed changes to the hepatitis B vaccination schedule. That decision was not about hesitation or reluctance. It was about standards. Several data elements the committee requested were incomplete, and the evidence did not yet meet the level of clarity required for a confident, evidence-based recommendation. When gaps in the evidence emerge, the responsible action is not to push forward. It's to pause, review, ensure that we fully understand what the data can and cannot support, and then formulate independent advice to the CDC director. This is our charter. Since that meeting, CDC formed a dedicated hepatitis B work group to examine the outstanding issues in greater depth. That group has been working diligently, I can attest to that. Many hours have been invested since then in preparation for this meeting. By the way, I'm not able to disclose the nuance of that work group, but it is quite diverse in membership and represents a full spectrum of opinion regarding hepatitis B vaccination. Their work has helped sharpen the questions we need to answer and improve the quality of the discussion we will have today. I want to emphasize this is exactly how the scientific process is supposed to function. When data are complete, we say so. When additional analysis is needed, we conduct it. When assumptions need to be revisited, we revisit them. We're not here to reach quick conclusions. We're here to reach accurate ones and to provide independent assessment and advice to the director and to the public. Today's agenda reflects the complexity of the issues before us. My hope is that we approach each discussion the same way we approached the COVID-19 vaccine issues in September, with seriousness, clarity, and a willingness to challenge our own prior assumptions. ACIP's credibility depends on our commitment to a deliberative, transparent, evidence-based process. You'll see that in play during the discussions today and tomorrow. Finally, I want to acknowledge in particular the CDC staff and external experts who support this committee. Their technical work, from surveillance to modeling to implementation research, is essential. The ACIP depends on their diligence, and all of the appointed members are grateful for their contributions and for all the contributions of the career staff across HHS, including in our affiliate organizations at FDA and NIH. Thank you again for the work that you do and for the integrity you bring to this process. We have a full agenda today, and I look forward to a thoughtful and productive discussion. Thank you for your time. Now, with that, I now call to the floor Dr. Vicki Pebsworth, who is representing the ACIP Childhood and Adolescent Immunization Schedule Work Group, to discuss the policy context and schedule comparison relating to hepatitis B. Do we have those slides? Take it away.
Good morning. Thank you, everyone. And I'd like to respond to what Dr. Malone said about thanking the CDC staff because they have been very helpful. We could not have done the work we did without their assistance. So I'd like to begin by just also acknowledging that the Childhood Adolescent Schedule Work Group is the umbrella work group, and there was then a hepatitis B sub-work group formed to deal with the question that was asked of us. And there are 4 of the work group members here present, Dr. Evelyn Griffin, Dr. Kirk Milhone, and Dr. Tracy Beth Hogue were members and served on the work group. So they'll be stepping in and helping to answer the questions that will be coming up. So we were asked to focus on one group, newborn infants born to mothers who test negative for hepatitis B surface antigen during pregnancy, not newborn infants born to mothers who test positive. Thus, we primarily focused on a vaccination dose given at a specific time, the birth dose, the dose given to all newborns within hours of birth. The literature we reviewed mainly involved the 2 U.S. licensed single antigen hepatitis B virus vaccines, not the combination vaccines containing hepatitis B antigen that are given later in infancy. Next slide. This morning's presentation is divided into 3 sections. I will cover the introduction and policy context, and then Dr. Cynthia Neveson will cover the burden of disease and efficacy, followed by Mark Blaxell, who will address the safety portion of the presentation. Next slide. According to the ACIP's charter, vaccines are supposed to be reviewed on a periodic basis. The ACIP Childhood Adolescent Schedule Work Group was tasked with assessing the current recommended schedule, including the use of a universal birth dose of hepatitis B vaccine in children whose mothers test negative for hepatitis B surface antigen at delivery. So why are we here? In addition to needing to review hepatitis B because it had been so long since we had reviewed it, we're doing this because of concerns that have been raised by some groups. The current policy is misaligned relative to existing recommendations in most other developed countries. And again, the prolonged time since the last review per ACIP's charter. Next slide, please. So how did we get to where we are now? Several key events shaped the current landscape. A rapid rise in reported acute U.S. cases of hepatitis B, which is a source of very serious liver disease. Licensure of a plasma-based vaccine in 1981 that targeted high-risk groups. Emergence of new technologies and changes in vaccine-related liability. Evolution of ACIP recommendations during the 1980s. Dissatisfaction with the high-risk groups targeting strategy, which had led to an ambitious new hepatitis B eradication strategy. And lastly, the leap in 1991 to adopt the universal birth dose recommendation. Next slide. This slide shows what was going on with hepatitis B. It shows that over a 25-year period, reported cases jumped from a few thousand to well over 25,000. This happened for 2 main reasons. First, rising transmission of acute hepatitis B due to bloodborne exposures in high-risk groups. In the 1960s, there was unscreened, blood-infected patients with frequent transfusions, followed by a rise in the 1970s of dialysis-based transmission, and then into the 1980s, there were expanding sexual networks of men having sex with men and higher female-to-male partner counts, along with rising IV drug use and heroin usage expanding outward from urban pockets. Second, at the same time, there was a surge of immigration from high endemicity areas in Southeast Asia after the end of the Vietnam War. 1.5 million refugees from Indochina, which significantly increased the reservoir of chronic disease carriers. Next slide, please. Factors that affected the policy shifts. In response to the hepatitis B crisis in 1981, the FDA approved a new plasma-based vaccine for hepatitis B virus, the first vaccine against hepatitis, and it was judged as highly effective. Concerns emerged about the safety of the donor source material. Only 6 years later, a new vaccine based on a recombinant technology platform, rather than donor plasma, was licensed by the FDA. It was a hepatitis B antigen-based product manufactured in yeast. Concerns about liability for pediatricians and manufacturers about the new recombinant vaccine were removed following the passage of the 1986 National Childhood Vaccine Injury Act. Next slide. So this was the context when an important editorial titled "Worldwide Elimination of Hepatitis B Transmission, We Have the Way, We Have the Will," was published in JAMA in April 1989 by Dr. Hal Morgan and Dr. Donald Francis from the CDC, both of whom are public health leaders. They reasoned that if vaccinations were given universally at birth to infants in populations that have a high rate of perinatal hepatitis B virus transmission, and with childhood immunizations to infants in other parts of the world, a worldwide cohort of persons protected from this long-term infection would be established. And in the United States, selective immunization of groups at risk of infection has not been effective in lowering the overall incidence of the disease, and immunization strategies targeted at both infants and adolescents should be considered if we are to control this disease. This statement typified and created a rationale for opening the door to vaccinating infants who were not at high risk of infection. Next slide, please. This chart shows the evolution of ACIP recommendations. In 1982, only infants of hepatitis B positive mothers were recommended to receive HBIG, the hepatitis B immunoglobulin, at birth and then be vaccinated at 3 months. In 1984, 3 months was changed to 7 days. In 1985, both HBIG and the vaccine were to be given within 12 hours of birth. In 1987, the first recombinant hepatitis B vaccine was licensed. And finally, in 1991, ACIP recommended that all infants, even those born to hepatitis B surface antigen negative mothers, be vaccinated before hospital discharge or no later than 2 months. But 14 years later, in 2005, the 2-month option was removed, and all infants were to be vaccinated within 12 to 24 hours of birth. Next slide, please. So what are we trying to accomplish today? First, we need to address stakeholder and parent dissatisfaction that we have become aware of. Second, we need to report on the work group's review. More on that later today. Third, we need to consider whether there are immunization policies that are better aligned with other countries similar to ours, are based on evidence, and support the need of high-risk persons and populations without treating everyone as if they were genetically the same, and explicitly consider public health and vaccination ethics. Next slide. The work group was asked to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers are hepatitis B surface antigen negative. As noted in the work group's terms of reference document, basically our scope of work, which states that the work group will review the efficacy and safety of the immunization schedule for children and adolescents, identify efficacy and safety problems, and address stakeholder concerns. To that end, in our TOR, 2 Institute of Medicine reports are cited. First, the 2002 report, Multiple Immunizations and Immune Dysfunction, where over 20 years ago, 1/4 of parents expressed concern about the number of immunizations children were receiving and concluded that concern about multiple immunizations has been and continued to be of societal significance in terms of parental worries, potential health burdens, and future challenges for immunization policymaking. Second, in the 2013 report, the Childhood Immunization Schedule and Safety, Stakeholder Concerns, Scientific Evidence, and Future Studies, directs DHHS to incorporate study of the safety of the overall childhood immunization schedule into its processes for setting priorities for research, recognizing stakeholder concerns, and establishing the priorities on basis of epidemiological evidence, biological plausibility, and feasibility. Next slide, please. As it relates to stakeholder concerns, the work group reviewed the literature and identified 2 relevant surveys that we'd like to comment on now. First, there was a 2014 survey of Oregon parents, and this is a survey of hospitalized just after birth newborns. 5% of parents in that survey refused the hepatitis B birth dose. 8% wanted to wait. 6% were undecided. The reasons why they gave for these preferences were that 78.1% thought that the baby was too young, 70% discussed vaccine safety concerns, 43.8% said the baby was at low risk of infection. Another more recent survey conducted by the Kaiser Family Foundation and the Washington Post of parental attitudes about vaccines found, this was just in October, found that 13% had skipped or delayed the hepatitis B vaccine. 16% had skipped or delayed other vaccines, and the reasons for doing so were they were concerned about side effects. 53% had doubts about safety. 51% said that vaccines were not necessary. 42% were not wanting multiple shots. 35% said safety testing was lacking. And 26% said CDC recommends too many vaccines. 41% wanted to space out the shots. And 58% said little or no confidence in the federal agencies. Next slide, please. This graph shows on the x-axis the prevalence rate for chronic hepatitis B for a country. On the far left, on the lowest bars, the U.S. is the one in the red box, and it shows that the prevalence rate for chronic hepatitis B is about 0.5%, one of the lower countries. On the far right, also in the red bars, are South Korea, Bulgaria, Romania, with 3 to 4.5% prevalence rates. The color in the bars matter. The red bars are those that recommend a universal birth dose. All babies are vaccinated at birth. The purple, there is no universal birth dose used. The blue, they have a flexible policy. Many start at 2 months. The green from Canada shows that different provinces in Canada have different policies. This graph shows that the U.S. is an outlier. We are vaccinating infants that no other extremely low endemicity country vaccinates. Next slide. And I would just like to point out that we do pay attention to ethical issues, and there are, the Markman study discusses the need for public health policymakers to consider the expected health benefits for target populations, the potential for harms and burdens for all of the stakeholders, consider policies as they relate to the ability to exercise autonomy, its impact on equity, and experience of efficiency. And we also noticed that another new framework where the author argues that we should also aim to preserve health and consider both the benefits to the individual from vaccination and herd immunity, as well as the harms to the individual from disease and vaccine adverse effects. That there should be means-end proportionality to the intervention in that vaccines should be efficacious and tailored only to prevent illness and undesired health outcomes. That discretion should be exercised in how evidence is weighed to account for validity and generalizability and what is known, unknown, and the possibility of unknown unknowns. Lastly, parsimony should be exercised when the smallest necessary dose, the least amount of adjuvant, and consider the number of vaccines given simultaneously. Next slide. So the situation that we find ourselves in reflects persistent, if not growing, stakeholder dissatisfaction with vaccination policy in general and with hepatitis B policy in particular. This level of dissatisfaction is of societal significance and poses challenges for vaccination policymaking, just as the Institute of Medicine warned us 25 years ago. The belief that universal vaccination, along with new technologies, could eradicate hepatitis B was endorsed by public health leaders, and it shaped public policy. Reflecting that vision, between 1983 and 1991, ACIP recommendations shifted from targeting only high-risk infants to targeting all infants. Next slide. So it's been 35 years since the universal birth dose policy was implemented. The work group was asked to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers are hepatitis B surface antigen negative. What follows describes our work and findings. Causes of hepatitis B, increases in the 1970s and 80s, diminished with targeted measures. Universal birth dose set out to eliminate worldwide transmission. Other countries with similar incidence and prevalence of hepatitis B use a selective vaccination practice and not a universal birth dose. Some parent stakeholder groups would like greater flexibility and the ability to decide what is best for their child. Stakeholder dissatisfaction has been documented for 25 years, is of societal significance, and creates challenges for immunization policymaking. The belief that universal vaccination can eradicate hepatitis B was endorsed by leaders, and it shaped public policy. In response, between 1983 and 1991, ACIP recommendations shifted from an approach that only targeted high-risk infants to one that targets all infants. The context included the emergence of advanced vaccine technologies and fewer liability concerns. So I would like to, at this point, turn the presentation over to Dr. Nevison.
Yes, hello, can you hear me if I speak from here? Okay. Okay, yes, my name is Cynthia Nevison. I'm a CDC contractor with Vortex LLC, and it's really an honor to be addressing you at ACIP on this important topic. So I've been tasked with walking you through the burden of disease data, and for each of my 3 topics, I posed a question which examines the rationale for universally vaccinating all newborns in the U.S. against hepatitis B. And so I'm going to try to give you a short answer up front for each of these questions, and then we'll dive into the data and you can judge for yourself. So first we'll look at the morbidity trends, and I'm going to ask, what has the universal birth dose accomplished compared to more targeted measures, which could include selective vaccination of at-risk populations or non-pharmaceutical public health programs? And the answer there, surprisingly, is that it's the more targeted measures that have had the biggest effect in bringing down cases of hepatitis B. Second, I will look at vertical, otherwise known as perinatal or mother-to-child transmission. And the question here is, should we be trying to target the vaccination of the approximately 0.5% of American newborns who are truly at risk for perinatal transmission, or should we be universally vaccinating all newborns? And the answer to that question really depends on whether you have more confidence in the surveillance data or in the models, which the models suggest that more babies are falling through the cracks, whereas the surveillance data provide a more reassuring picture that targeted measures are working. And then finally, I'll look at horizontal transmission in childhood and ask, what really is the evidence for this, and has the risk to the average American child been overstated? The answer is there's very little evidence that horizontal transmission has ever been a significant threat to the average American child, and the risk probably has been overstated. And in these last 2 topics, we'll see a theme emerging in which we have the surveillance data, which provide a more reassuring picture of relatively low cases of hepatitis B, and then we have the models, which portray a perhaps more alarming or worrisome picture. So we'll look at the data, and then we'll examine critically these models for vertical and horizontal transmission. But I want to start by looking at the morbidity trends. And again, I'm going to be asking what has been the role of the universal birth dose versus more targeted measures. Let's see if I can advance this. Okay, so these are acute cases of hepatitis B from 1983 to present. And these are data from the National Notifiable Diseases Surveillance System. That's the last time I'll say that. I'm going to call it the NNDSS from now on. I want to thank the CDC staff and the Hepatitis Division for providing these data going back to 1983 in an age-stratified format, because on the public CDC website, you can only go back to 2016, and you don't get the full scope of what the trend has been over time. So what we can see here, and I'm not sure if this is going to work. No, okay. Well, what we can see here is that the cases have come down quite a bit from the peak in 1985 to only about 2,000 to 3,000 acute cases of hepatitis B per year over the last decade. We can see that the decline in cases has been mainly among young adults, aged 20 to 39. Those are the blue colors on the graph. And then we can also see that the cases had started to decline well before the universal birth dose was implemented. And that's notable because the MMWR 1991, the policy document that Vicki just described that introduced the universal birth dose, said that, quote, selective vaccination of persons with identified risk factors has not lowered the incidence of hepatitis B. But that is not true according to this graph, because the cases were already down 33% by 1991 from their peak in 1985. And if we let's look at some of the age groups in which the biggest declines in cases have occurred. Take, for example, the 20 to 24-year-olds in light blue. So universal vaccination of newborns starting in 1991, it was really late 91, 92, would not have shown up, the effect of it would not have shown up in this age group until 2011, 2012. And yet one can see that the cases had declined sharply well before then. Or take the 15 to 19-year-olds, these are the orange colors, universal newborn vaccination starting in 1991-92 would not have shown up in this age group until 2006, 2007. And yet we can see that the cases had already declined sharply well before that date. So the answer to the question of which has had the more effect, the universal birth dose or other more targeted measures, logically, when you look at the age range in which the biggest declines have occurred, it had to be other measures. And so let's look at what some of those might have been. There was better blood screening for the hepatitis B surface antigen, which led to sharp declines in hepatitis B transmitted through transfusion and also through dialysis. And then this was the 1980s with concern about AIDS, so there was an widespread adoption of safe sex practices. And then there was needle exchange programs, which helped curtail transmission through IV drug use. And also the 1980s saw the beginning of screening and case management for surface antigen positive mothers and targeted vaccination of their infants. So all these factors helped bring down cases both before the universal birth dose was implemented and after. And just again, logically, when you look at the age range in which the decline in hepatitis B cases has occurred, the universal birth dose contribution to the acute case decline is likely very small. So now I want to move from acute cases to chronic case data. And so in contrast to the steep decline we just discussed in the acute cases, the chronic cases paint a more puzzling picture. First of all, they were only reported to the NNDSS starting in 2003, so that first steep curve is probably a spin-up as reporting became more of a routine practice. And by the way, the NNDSS is taking reports from doctors, from healthcare providers who report to their local public health department, who then in turn report to the CDC. So that's where the NNDSS case numbers come from. So in any case, with the new chronic cases in orange on this graph, you have more of a flat trend from about 2015 to 2020, and then there's actually an uptick in cases after 2020. And I was curious about where that uptick was coming from and traced it back to older adults. And it's especially noticeable in the adults over age 60. You can see those numbers in orange increasing after 2020. You can also see upticks to a lesser extent in adults starting from age 30. So it's not clear what's causing this, but what is clear is that universal birth dose is doing nothing to help these older adults who are experiencing disease now and need help. And let's now go to the infant morbidity. And so in the blue curve, we have the acute cases, which have declined sharply to almost zero today, acute cases of hepatitis B. The decline has happened after the universal birth dose, but it also, there was also a steep decline before the universal birth dose, likely reflecting targeted vaccination of at-risk infants. New chronic cases in orange are low. And then we have perinatal cases in the green dotted line. And I have a couple of numbers there. In 2015, there were 36 perinatal chronic infections reported to NNDSS. In 2023, there were only 7. And this is in contrast to the CDC model of perinatal infections, which in 2015 predicted 952 perinatal infections versus the reported 36. And in 2023, and the CDC staff kindly updated the published estimate of Coe et al. 2016 for 2023 conditions, they came up with 601, which is nearly 100 times more than the 7 that was reported to NNDSS. So why this discrepancy? Could NNDSS really be missing that many perinatal cases, or is the Coe model overestimating cases? So we'll address that in my next section, but I just wanted to first summarize the hepatitis B morbidity trends. First, we saw that acute cases have declined sharply from their peak in 1985 for multiple reasons, most of which likely had little to do with the universal birth dose. We've seen that new chronic cases have been more flat and actually increasing among older adults after 2020. And I should have mentioned that the chronic cases are really of greatest concern because that is what chronic hepatitis B infection is what leads to long-term liver damage. And then finally, we saw that perinatal cases, according to the surveillance data, are down to only 36 and 7 in 2015, 2023, but that the CDC model predicts many more cases than that. So that's a segue to my next topic, my second topic, which is modeling perinatal infections. So we have the surveillance data, which is sort of a top-down way of reporting the perinatal infections, but then the CDC has more of a, what I'd call a bottom-up model for estimating how many perinatal infections are occurring. And that model estimate begins by tabulating how many mothers giving birth in the US are surface antigen positive, meaning they're chronic carriers. So we have a paper, recent paper by Konaru et al., and that estimates the number of surface antigen positive women giving birth. There are about, in the upper right, there are about 21,000 women in the US, and this is geared toward 2015, these estimates. For context, there were about 4 million births in 2015. So 21,000 carrier mothers represents about 0.5% of all US births, 0.5%. And of the 21,000 positive women, more than half, about 12,000, are non-US born immigrants. And then of those immigrants, nearly 6,000 are from East Asia, over 2,000 are from Southeast Asia, and over 2,000 are from Africa. And so how many of these 21,000 women are likely transmitting hepatitis B to their baby? Well, from there, let's go to the structure of the co-model to understand the CDC's model for estimating perinatal infections. So without intervention, which is the red bar, the PEP, post-exposure prophylaxis, prior to those interventions, all of the infants of these carrier moms were susceptible. And then it was only a matter of distinguishing between the mothers with a high viral load, the so-called E antigen positive mothers. They have a 90% chance of transmitting hepatitis B to their baby. And then, but about 70% of women are E antigen negative, and so they only have a 5 to 20% chance of transmitting to their baby. So once the baby is infected, he or she has a 90% chance of becoming a chronic carrier. And that's in contrast, so if an adult or an older child over age 5 were to contract hepatitis B, they would only have about a 5% chance of becoming a chronic carrier. So the infants are particularly vulnerable to becoming chronic carriers. Fortunately, we have PEP that interrupts that first transmission step. So let's talk about that. So PEP includes hepatitis B vaccine and hepatitis B immune globulin administered within 12 hours of birth. And so screening mothers to see if they are surface antigen positive during pregnancy is a key part of PEP. And again, thanks to the CDC staff for providing updated estimates to the COEDAL model. The recent estimate they provided is that 88% of women are screened during pregnancy. And when they're screened and identified as a carrier, almost all of their infants get timely PEP at birth, and which is effective at preventing transmission. But then we have about 12% of mothers who are not screened, and according to the CDC model, only a little under 80% of their infants get PEP at birth, and the remaining 20% do not. So all those 20% in this model go into the susceptible pool. And so working through the model, again, the CDC calculated 601 chronically infected infants in 2023. But recall that the surveillance data only reported 7. So why this discrepancy? Well, some of the doctors on the working group have suggested that the assumed failure rate of PEP of 8% is way too high. Maybe it should be only 2%. Others have expressed doubts that only 88% of women are screened. And I think it's also worth looking at the 20% of infants of unscreened mothers who are assumed to be susceptible. That number comes from a recent survey that found that 79.5% of infants were getting the newborn dose in the US, and then the assumption was the remaining 20% are susceptible. But what that assumption fails to account for is informed parental decision-making, because it's very likely that many of the 20.5% who are not getting PEP, that was a decision by the mother who knew she was not a carrier, and she made an informed choice to decline the birth dose. So in any case, there may be a number of worst case or inappropriate assumptions in the co-model that could be leading it to overestimate the number of perinatal infections. And so just to summarize perinatal infection, we saw that the risk is isolated to about 0.5% of pregnancies, mainly from immigrants from high endemicity countries. It's possible that we could add hepatitis B screening to an immigrant medical examination and provide more targeted efforts to better identify this minority of at-risk infants. Improved screening in prenatal care and delivery in general could be implemented to put the burden more on the healthcare system rather than on the newborn to make up for any deficiencies in our current screening practices. And finally, we've seen that the models may be overestimating perinatal cases due to a number of worst case assumptions. Okay, I want to move to horizontal transmission, my third topic in childhood. And the first thing to note about this is that there is very little documented evidence for horizontal transmission in the U.S. And that's illustrated by the fact that when the working group asked CDC staff for evidence of horizontal transmission, we were provided essentially a single paper, and it was a modeling study by Armstrong et al. And I want to take some time to examine this study because it raised concerns that all young children in the U.S. are at significant risk for horizontal transmission of hepatitis B. And the number they came up with in this model in the pre-vaccine era was that there were 16,000 cases per year in children aged 0 to 9 of horizontal transmission. Half were in Asian immigrants populations and half were in the general U.S. population. So where did these numbers come from, the 16,000 cases? Well, Armstrong et al. Used a serocatalytic modeling approach. And I have a much longer presentation on this, but I'm just going to try to focus on the bare essentials to understand this model or this approach. So a serocatalytic model is a serosurvey where you look for blood markers of past or present infection, and that's what's plotted on the y-axis as a function of age. So we're moving from 0 to, I believe, 15 on the x-axis. And the question of whether horizontal transmission is occurring among these young children boils down to this. Is there a significant linear increase with age in seropositivity? Because that, in the serocatalytic model, is evidence of horizontal transmission. And so Armstrong, it's hard for me to read, but Armstrong looked at 4 different populations. On the upper left, we have the N. Haynes population, and that's sort of the general U.S. population. The maximum Y value on that y-axis is less than 1%. And then the other 3 panels are specific Asian American models, often with high communities of immigrants. And the maximum Y value, for example, on the lower left, which is the Southeast Asian model, is 30%. So very different y-axes. And then another issue that we need to point out is that Armstrong et al. Assumed a perinatal infection rate and anchored the linear fit at that rate at time 0, which is birth. And for the N. Haynes model, they assumed a perinatal infection rate of 0.07%. Where did that come from? It's hard to evaluate because it was based on unpublished data. So what happens, though, if the circles on this graph are actual serosurvey data. What happens if you digitize those circles and plot them without anchoring them to an assumed and undocumented perinatal infection rate? Well, that's what I've done here. And basically what you see is that 3 out of 4 of these models do not show a significant linear increase in seropositivity with age. And the N. Haynes model in particular, which again represents the typical American child, has a slope that is statistically indistinguishable from a flat line. So those 5 dots in the upper left. In other words, there is no significant evidence for horizontal transmission in the N. Haynes data. The only one of these models that shows a statistically significant increase with age is the Southeast Asian model on the lower left. And there, by the time the children are 9 years old, about 16% of them are seropositive. So they've had some evidence of Hep B infection. Unfortunately, the Southeast Asian model is based on 2 published papers, very nice papers that we can go in and independently read and verify. And these papers showed convincing evidence for horizontal transmission in these communities. They even went so far as to trace the horizontal transmission from older siblings to US-born children. And these were Vietnamese or Hmong refugees who had resettled in the US. And what I've highlighted in yellow is just to point out that in the Asian-born adults and older siblings in this group, there was an extraordinarily high prevalence of hepatitis B. In fact, the majority of the population showed some sign of infection. So this is an exceptional circumstance where horizontal transmission is occurring, but it is unlikely to apply to the average American child. And so I will just summarize horizontal transmission. Yes, it can occur among certain high-risk immigrant communities, but the evidence for horizontal transmission among most U.S. children is very, very sparse, and really all these years has been based on a fit to seropositivity data that really wasn't statistically significant. And a final point is that the 16,000 cases per year predicted by Armstrong et al. Are not supported by the surveillance data. I'm showing here children aged 0 to 9. Before the universal birth dose, which is the vertical red line, there were about 400 acute cases per year reported, 400 compared to the 16,000. And keep in mind also that of the 400, many are probably resulting from perinatal infection. So just a final note on horizontal transmission in childhood. The Informed Consent Action Network, ICANN, asked the CDC through their lawyers, and I believe one of them is testifying tomorrow here, for documentation sufficient to reflect a case of transmission of hepatitis B in a school setting. The CDC's response, a search of our records failed to reveal any documents pertaining to your request. So I'll just, to summarize now the burden of disease, we've seen mixed trends in hepatitis B morbidity 34 years after the universal birth dose was implemented. Acute cases have declined sharply for multiple reasons, most of which have logically, when you look at the age range in which they occurred, little to do with the universal birth dose. Then we saw that new chronic cases are increasing, somewhat worrisome findings since 2020 in older adults over age 30, especially over age 60, and what public health resources are being dedicated to help those individuals who are experiencing disease. And then we saw that reported perinatal cases are in the single to low double digits, according to the surveillance data, thanks to PEP, which has been quite effective. And then we had the theme of models yielding larger estimates than surveillance data, and I think cross-checks between the two can be quite useful in trying to constrain and compare differences. We saw how the Coe et al. Model of perinatal transmission may be overstating cases, and we saw that the horizontal transmission among younger children predicted by the Armstrong model is almost certainly strongly overstating cases. And that's what I have on the burden of disease. I don't know if I have time to cover, show 5 slides on a separate topic of efficacy and waning immunity. I can either stop here or go on to this topic.
Dr. Pebsworth, you want to weigh in on that?
Go ahead.
Okay, there was some confusion whether I should be presenting the. Okay, well, I have just a short segment on sort of a separate topic which involves efficacy and waning immunity. And basically, I'm going to be showing several studies which show reduced antibody levels over time following hepatitis B vaccination, and that seems to be a function of when the primary series is initiated. So the earlier the primary series is initiated, the more quickly the antibodies wane. And I'll just show three studies briefly. The first is among Native Alaskans. They were vaccinated when the first plasma-based vaccine was available. There was a high rate of hepatitis B in this Alaskan community. And then they went back and checked them 30 years after the primary series. And what I've highlighted in yellow is that for those whose primary series was initiated when they were between about 5 and 19 years old, 30 years later, over 60% of them still had titers above 10 units per mil. In contrast, those who were vaccinated when they were less than 5 years old, only 32% of them still had the high titers. And by the way, none of those under 5 were vaccinated as newborns. They were all started at a later age. Now, all of the groups did respond well to a booster dose, showing so-called anamnestic memory, although what I've highlighted on the far right is that while 83% of those vaccinated prior to age 5 responded to the booster dose, about 17% had titers that did not rise above 10, even after the booster dose. That doesn't necessarily mean they're not protected, but it's a point to note. The second study is among U.S. children vaccinated now as infants. Group 1 started their series with the birth dose, and Group 2, the third column, started a little bit later at age 4 weeks or older, but both Group 1 and Group 2 completed their primary series before they were 1 year old. So when they were tested at age 16 to 19 years, less than 17% of Group 1, those vaccinated as newborns, still had titers against Hep B above 10, and about double, 34% of those in Group 2 who were vaccinated starting at 4 weeks or later had titers. Again, both groups responded well to a booster dose, but again, I'm just going to point out on the lower left that nearly 10% of those vaccinated first as newborns, the booster dose was not enough to boost their titers over 10. And then finally, this whole phenomenon of waning immunity shows up in NHANES data. And let's just focus on the cluster of columns on the far right. This is a time series of NHANES. In the earlier rounds of NHANES in the 90s and 2000s, these were kids who were probably vaccinated as older children, not as newborns. And about more than 50% of them still have titers. Whereas the green and red bars on the far right, they were likely vaccinated as newborns, and only 22 to 24% of them still had detectable vaccine-derived immunity or titers in their blood. So just to end, yeah, I wanted to thank the CDC division, hepatitis division, for compiling those NHANES data. And just so finally, to summarize waning immunity, we've seen 3 studies, and there are more, where the antibodies against the Hep B surface antigen wane the most rapidly in children who begin their primary series as infants, especially as newborns. And although most vaccinees responded well to a booster dose, some of those vaccinated as infants may lack protection because they did not respond to the booster dose when they enter their years of highest risk for acquiring hepatitis B. And that is the end of my presentation, although I do have a slide of references if anyone is interested, and thank you for your attention.
Thank you very much. Now we just need a quick break. We've now been joined by Dr. Catherine Stein. Introduce yourself and indicate whether you have any conflicts of interest to report.
I'm Dr. Catherine Stein. I'm a professor of epidemiology at Case Western Reserve, and I have no conflicts.
Thank you very much. Raymond, I noticed that you have a question, sir.
I do have a question, and thank you for that very insightful and informative presentation. As discussed with you perhaps a little earlier, is there any data in 2025 on the seroprevalence rate of hepatitis B antibody in women of childbearing years? Because the reason I ask the question is, if these women are positive with anti-hepatitis B antibody, that antibody is transferred passively to the infant. And these children who we are considering going forward in the next 2 or 3 decades would be protected by that antibody. And so giving some reassurance to those mothers who are hesitant about giving the vaccine at birth. So the last data I saw was up to 2017, when up to 50% of the US population had antibodies to hepatitis B. So from your data, does the CDC have any information on the prevalence of anti-hepatitis B antibody in women of childbearing years or at-risk women, for Dr. Griffin?
Yeah, thank you for the question. I have mainly seen data on the surface antigen positivity of the women, not whether they have anti-HBs, although I couldn't say that the data don't exist. The that last segment I presented on waning immunity might suggest that many of those vaccinated at birth might not have detectable anti-HBS titers anymore. But again, that is not to say that they don't still have protection, because there could be B memory cells that are lying dormant and would respond in case of infection. But yeah, I can't answer though.
Now, I acknowledge that we have additional questions pending here, but I notice on the schedule that we have a indication for discussions after the hepatitis B vaccine safety. And so if you would please take note of your questions and hold them for the appropriate section. I'm really trying to keep us on track. So that's supposedly my job. Vicki, do you wish to introduce the next section?
Yes. Mr. Mark Blaxell will speak to us on safety findings.
Can you all hear me? Very good. Good morning. I'm Mark Blaxell. I've been working with the working group and Dr. Pebsworth and Nevison on this analysis of the birth dose. I've also been a critic of the CDC for many years, so it's been an honor and a privilege to work on the inside and to address some of these issues. I want to focus in on safety and the evidence around safety. There we go. And I can't read the screen this far away, so I'm going to multitask here on my own screen so I can see it. I want to review data quickly in 4 areas on the safety of the infant hepatitis B birth dose. There's some clinical trial evidence, post-licensure safety studies, perspectives from the Institute of Medicine and the Vaccine Injury Compensation Program on vaccine-related injuries, and then a quick note on some animal models, because you can do some things with animals that you can't do with human infants. To give you an overview of the key themes, the safety evidence is limited, and it's often concerning, and it varies across the different sources. In terms of the clinical trials that were, and if you take the 3 trials that were cited by the ACIP members that were used in the birth dose recommendation, there were basically no randomized or placebo-controlled trials, meaning an inert placebo applied to infants and in comparison to the vaccine. And the cited trials were basically had very short follow-up periods with no ability to assess chronic or late onset conditions, and for the large part discounted safety concerns. As we can see, there might be some safety signals in there. I also want to thank the CDC's Immunization Safety Office, because they did a rapid systematic review on the post-licensure literature that they shared in the September meeting, and that's a very valuable resource, and I just returned to that to review the safety studies there. And there is some evidence of concern, particularly of some chronic and late onset effects that was not presented, so I wanted to share that briefly. In addition, if you just step back and look at the policy landscape on vaccine injury and what it relates, how it relates the injuries that might occur from hepatitis B vaccine, there's basically, and it's been highlighted by the Institute of Medicine's vaccine safety reports, that there's an absence of evidence to assess virtually all endpoints, over 30 in the 3 reports of the IOM, 26 out of 27 in the most recent report. So there's really not sufficient evidence to evaluate whether or not there are safety risks or injury risks. In the meantime, the Vaccine Injury Compensation Program has processed large numbers of Hep B vaccine-related claims, compensating many. And then if you go deeper into the animal mechanistic biological mechanism literature, it's relatively sparse, but there is evidence of supporting the mechanisms of injury, particularly immune activation, that are reported in some animal models, especially rodent models. So let me start with the clinical trial evidence, and these are the three studies that, if you go back to the 1991 ACIP recommendation on the universal birth dose, that were used to support the safety of the birth dose vaccine. As you can see, the three of those were all published in the 80s, and most of them, in terms of controls, two of them had no control group. One of them used another vaccine as the control group. The sample sizes were small, and in some cases they were specifically targeted at Asian American surface antigen positive mothers who were at high risk of transmitting the virus, per Cindy's presentation. And the follow-up period in all of these cases was very short, 7 days at the most. And so they were basically not equipped to measure whether or not there were chronic or late onset conditions. They generally found that the vaccine was safe and well tolerated, although I'll go into one that reported that 18% of the infants, the infants that were vaccinated had systemic complaints, and there was one death in one of the other studies that was judged not to be related to the vaccine. But let me go quickly into the Zajac study, and this is a table. This was the most extensive evidence provided in any of the clinical trials on safety results. It was actually not the birth dose, it was infants under a year of age, but it was the closest that we could get. And that study reported an 18% risk of systemic complaints, and those were defined in the trial, the publication, as fatigue or weakness, diarrhea, or irritability. Those were dismissed as, well, the baby's just fussy. If you do compare those descriptions to definitions of encephalitis, those are possibly connected. So the National Institute of Neurological Disorders and Stroke defines encephalitis in infants as, or suggests watching for fever, lethargy, weakness, or drowsiness, and unexplained unusual irritability or crying. So it's not conclusive, but it is, there is some evidence of concern in that one clinical trial. So moving on to post-licensure studies, I'm just showing here the slide from the September Immunization Safety Office. They did a very useful and thorough what they called a rapid systematic review of the literature on the post-licensure literature on hepatitis B vaccine safety administered in the first 30 days of life, and they reviewed close to 2,000 potential publications to include, and they extracted from that review 20 publications that they judged to bear on the safety of the infant birth dose. They described and they analyzed those 20 publications. In the September presentation, their focus was on presenting 9 of those. Those 9 were selected based on this chart, I believe, that they covered the birth dose specifically. They were restricted to the birth dose within the first day of life or within 8 days of birth. But there were also another 11 studies in that rapid systematic review that included the birth dose or early exposure, but they included all vaccination within the first month of life. So those are relevant and germane as well. I've taken the liberty to just write all those down. These are the 20, and I've taken the ISO's segmentation by the inclusion of the time in the first month. Those are the rows, and those are the 3 categories, the 5, the 4, and the 11. I also went through their analysis, and they did break out studies that used vaccines as a control, which arguably is less relevant to the assessment of safety because both infants are, the case and the control groups are being exposed. So I have chosen to focus here on the studies that used an unvaccinated or no vaccine exposure group as a control. And as you can see, there are 4 in the two categories that the ISO went through, and I'm going to go through those four studies first. One of those, the Linder et al. Study, was published in 1999, and it made an observation of concern, which is that pre and post introduction of the Hep B vaccine in a hospital in Israel, there was an increase in unexplained fever. As you can see here, the 1991 group of infants, there were about 5,000 total infants, and there were relatively few cases, 14 cases of unexplained fever. In the year after the introduction of the birth dose, there was a substantial rise in unexplained fevers, an odds ratio of 2.2. And the authors here observed in conclusion, we found that an increase of unexplained neonatal fever, which resulted in evaluations for sepsis, administration of IV antibiotics, and prolonged hospital stays, they may be associated with vaccination on the first day of life. So that study prompted some follow-ups. The other three studies in that upper left corner are here. The Lewis study was specifically designed to follow up on the fever and sepsis concerns. Their finding was there were no differences between the vaccinated group and the unvaccinated group. But in that study, there are, and they explicitly acknowledged the issue of the healthy vaccinee problem, and they did their best to control for it, but there was evidence that there might be residual confounding effects. A study by Erickson in 2004 looked at death. Again, both the Lewis and the Erickson study were based on the VSD data resources, and they found a lower death rate in the vaccinated infants. There were some issues that I'll go through in a second on that study. And then a more recent study from Australia looked at a specific adverse event in preterm infants, and they found that the vaccinated infants had a lower rate of risk, although, again, they noted the possibility of a healthy vaccinee effect. I want to take a minute, though, to go through the Erickson study. As you can see here, they looked at a range of vaccinated infants and unvaccinated infants. The difference between their two sample groups was very stark. The vaccinated infants were generally healthy and born with reasonable birth weights and at term. The unvaccinated infants were generally unvaccinated for a reason, which is that they were considered unhealthy. They were very low birth weight. They even had to exclude from this study infants with extremely low birth weight, so this is already a restricted sample. And they were generally born the median gestational age was 11 weeks shorter. And so they went through and compared the deaths in the vaccinated infants with the unvaccinated infants. But again, the problem was there were very many deaths in the unvaccinated group, many of them in the first couple of days of life, and they had a relatively small number of deaths in the vaccinated group, 72, and they used that 72 and they matched them to unvaccinated cases. Generally about 3 unvaccinated infants were matched to the deaths in the vaccinated group. There was an interesting potential signal there. This was the method in the Erickson study, and they identified all the deaths in these 2 HMOs in California, determined the cases that had been vaccinated, and that's the 72 number. Then they matched that number with unvaccinated infants, and that matching was kind of a complex process because it was difficult to do because the unvaccinated infants were not very comparable. They were generally sicker and premature. And then they went through an analysis of the pre-existing illness. Why would these infants have died? What were the causes of death? They categorized the deaths as expected or unexpected. and then assessed the clinical plausibility of Hep B vaccine contributing to the deaths. And they assessed SIDS rates, and I want to highlight one of the outcomes from that assessment. As you can see, the 72 vaccinated infants, they judged a little over 2/3 of those cases were expected. They could explain it from a clinical perspective. That was a similar expected death rate in the unvaccinated group. But then the unexpected cases, they did a very detailed investigation, and they published descriptions of each of these cases in the paper. There were 8 cases of SIDS, and that was the single largest cause of death in the vaccinated group. In the unvaccinated group, there were a number of deaths, but most of those were, the leading cause was necrotizing enterocolitis, or NEC, and there were 0 cases of SIDS in the unvaccinated group. That was a potential signal that the authors discounted, because they went to the remaining deaths in the unvaccinated group. There were about 1,000 remaining deaths that they, because these children were generally dying at quite high rates, or higher rates, and they were able to identify 4 additional cases of SIDS out of that 1,000. They didn't review that in the same depth as those 8 cases out of the 72, but they judged that the rate of SIDS in the unvaccinated group, when you included those four cases of death, was the same as the rate of death in the vaccinated group. So they dismissed any concerns over SIDS. But again, this is an example of one of the challenges in post-marketing surveillance. The healthy vaccinee effect does have create confounding issues in any analysis of unvaccinated children when they are in fact not healthy. So that's the evidence that was reviewed in the September meeting. I wanted to add a quick review of the 11 cases that were not presented, or some of the 11 cases, those that used unvaccinated controls. Some of these are VAERS studies. Those are studies that often are criticized. There's the Verstraeten study from 2003 that I won't go through. And then there were a number of studies that suggested, that addressed chronic late onset conditions. This is the list of that lower left box. Oops. Multitasking here. This is the list in the lower left box, and as you can see, some of them discounted any safety concern. The VAERS studies looked at deaths and severe adverse events and concluded in their findings that those issues were unexpected. The Verstraeten study that was published showed reported no significant associations, but there were several of the remaining studies did show an increase in chronic late onset conditions based on their follow-up times, which were again much longer than the 3, 5, or 7 days in the clinical trials. There are some issues with these studies as well. None of them are perfect, but I did want to summarize 4 of those that were based on the VSD data, one on tics, one on developmental delay, one on emotional disturbances in childhood, and another on premature puberty. They broke out male and female risk groups and the total, so T, M, and F are total male and female. And as you can see, in each of these studies, there was, based on the 1-month exposure to vaccines, a statistically significant effect. Moving on, so the safety evidence is quite limited, and there is more concern than often is acknowledged. The IOM has done an analysis of causal connections between chronic and late onset conditions and the hepatitis B vaccine, and generally have found in the range of studies that they've done, over 3 of them over the last 20, 30 years, that there is insufficient evidence to accept or reject causality in the vast majority of conditions that are considered. 26 out of 27 endpoints are yellow, where there's insufficient evidence in their 2012 report. Injuries are often compensated. The Vaccine Injury Compensation Program does frequently compensate vaccine injuries that are chronic and late onset. Adult compensation is for Hep B vaccine injuries has totaled $92 million. Infant payouts are $18 million, often for chronic and late onset conditions. And that occurs in an environment where most of the claims are that make their way through the VICP are rejected. So, but you do see some claims in there for SIDS, for seizures, encephalopathy, and other forms of death. I want to go quickly. There is a relatively sparse literature on animals, rodents, and primates, and it's mixed. The evidence is mixed, but particularly in the rodent models, there's evidence for immune activation, brain development effects that are reflected in behavior, and that evidence is most, there's a group in China that's been looking at rodents for over a decade. They find a range of immunological changes in Hep B birth dose vaccines. Those immunological changes affect the brain. There are specific brain anatomical findings and cellular level findings. Those brain changes are often connected to behavioral changes, and anxiety and cognitive shifts in the animals are noted as well. So to conclude, from the standpoint of the clinical trials, the safety was not studied in pre-licensure in randomized, inert, placebo-controlled, extended follow-up trials. So that raises a gap. Safety has continued to be evaluated in post-licensure studies, and those have been confounded, as we saw, by the healthy vaccinee effect. But there are others that have found evidence of chronic late-onset adverse effects. The IOM highlights that we don't know very much about safety for a whole range, for the vast majority of possible endpoints. And there is concern, again, on the animal model that establishes at least a theoretical mechanistic basis for injury that should be noted. Thanks very much.
Okay, and before we get to questions, thank you, both of you, for your balance, integrity, rigor, and work ethic. Much appreciated. And I know it's all been done in a fairly short timeline in conjunction with the working group. And I have a comment regarding that. There was a bit of a misstatement earlier that I am obligated to correct regarding the working group. There was not two working groups. There is not a hepatitis B working group. There is only the child adolescent scheduling working group. 100% of the work group members within that childhood adolescent schedule work group worked on hepatitis B, in addition to other experts that were brought in. Have I reflected that correction accurately? So for those that are concerned about this inadvertent misstatement, I just wanted to make sure that we're all aligned that this was in full compliance with the terms and conditions of the Federal Advisory Committee Act, FACA, that guides the ACIP structure. Now with that, it's question time, and I note that the time right now is formally, it's 9:45 by my clock, and we have until 10:40. We have no structure in terms of how that time is to be spaced between, I'm sorry, I have an amended schedule. 30 minutes for ACIP members and ex officios, and then 20 minutes for liaisons. So over the next half an hour, and I'm going to be a little bit insistent on timelines, forgive me, in order to keep us on schedule. Let's have a discussion among the ACIP members and ex officios, beginning with Dr. Meissner.
Okay. Thank you, Robert. And let me begin by saying that I take strong positions against each of the three presentations that have been made. And I realize time is a constraint. We were not able to comment after each presentation, but there are, I think, issues that people need to be aware of in regard to these presentations. So, and I'd like to make comments about each of the three. Robert, if you'll allow me time to do that.
Just try to be parsimonious, please, sir.
Yes, sir. I will do my very best, but there were so many statements that I don't agree with that it's hard to be succinct. But let me begin with Dr. Cynthia Nevison. First of all, I think you conflated serology, that is antibodies, with protection against infection. And you are correct that some people who receive 3 or 4 doses of a hepatitis B vaccine have waning immunity and antibodies disappear. That's not a novel observation. We've known this for a long time. But what's more important is that there's a very strong cellular component, which we don't know how to measure right now. The correlative protection for right now, the best we know, is antibodies, but we don't know how to evaluate cellular immunity. So the way I would answer your last series of slides, and perhaps someone from the CDC can correct me if I'm wrong, but I don't think there has been a single case of hepatitis B that has occurred in a person who was otherwise healthy, or a neonate who was otherwise healthy, who received the recommended schedule. There have been instances of seroconversion in people who were fully vaccinated, but I don't think there has ever been a report of anyone who developed disease, or that is symptomatic hepatitis B, or chronic disease. And the CDC may want to correct me on that, but I think the evidence is very strong that there is lifelong immunity to hepatitis B after completing the series. The next point I want to say in regard to Dr. Nevison is, remember, on a global basis, more people have a chronic infection from hepatitis B than they do from tuberculosis, from HIV, from malaria. Almost a third of the world's population is chronic hepatitis B carrier. So this disease has gone down in the United States thanks to the effectiveness of our current immunization program.
In your opinion, is that fair?
In my opinion, well, okay. These are facts, Robert. In the United States, if we want to acknowledge that 5% of the population is chronically infected with hepatitis B, that may be a little low. My understanding, it's 0.5 to 1%. But if we say it's 0.5%, that's 1.5 million people out of 330 million population. That's a lot of people. So whereas the rate may be low, it's important to remember that the number is high. The way I look at a neonatal birth dose is that it is a safety net. And it's really for chronically infected mothers who, for one reason or another, do not get tested. I think it's a very compelling argument that if we know a mother is hepatitis B surface antigen is negative, that we can wait a little bit to administer the dose to the newborn. But the problem is that in real life, and those of you who are physicians or healthcare providers know how complicated
But
this
Cody,
story.
Cody, you're opining rather than asking questions. And right now, our time frame is supposed to be for questions and follow-up, if you don't mind, because we have a time in the schedule for debating the question. And right now, I believe the time we have in our schedule, and remember, there are others other than yourself, is dedicated to follow up specific questions that need to be clarified from the presentation, if you don't mind.
Okay, thank you for that reminder, Robert. I appreciate it. I do want to make some statements during the discussion about the risk of horizontal, non-sexual transmission of children. But I think the point I want to make here is that when we administer any vaccine, whether it's hepatitis B or something, we are weighing the benefits of that vaccine against any risk.
Is there? I'm still
Yes.
waining for your question.
There's a question.
Thank you.
I am asking you, what is the risk of a hepatitis B vaccine in neonates? And the data that has been presented in terms of irritability, fatigue, weakness, diarrhea, that is absolutely not encephalitis. That's not a statement that a physician would make. They are not related to encephalitis, and you can't say that.
Okay, so the question, can you phrase it as a question, my friend?
Yeah, the question is there any evidence of harm? There is clearly evidence of benefit. Is there any evidence of harm to giving the neonatal hepatitis B?
Okay, good. So stop. So we have a presenter who was responsible for presenting vaccine safety. My sense is that he answered your question already, but I think we need to give him an opportunity again to address your specific question. Is there any evidence of harm associated with this product?
And I don't want to hear about VSD or that, because that
Cody, we've framed the question. Let's allow the presenter to respond.
Understood.
My basic answer would be that the safety evidence is very limited, and I wouldn't want to speculate on safety or harm. That the IOM has concluded that we don't know we have any reason to reject or claim causality on a wide range of conditions. There is concern for something that is as profound as, a universal immunization of every American infant at the moment of birth to address a condition that many of them will not be at risk for. The safety evidence should be rock solid. And
well, I haven't had a chance to go through non-sexual transmission in adolescence yet. So I can't, but there is no evidence of harm. And unless you can give me some examples, I won't accept that statement. And I'll stop there, Robert, in deference to your request.
Okay, I appreciate that. Retz, if your comment specifically addresses this discussion of evidence of harm, can you speak to that?
Yeah, absolutely. I think, with all due respect, I don't think that that's the right question, and I want to phrase another relevant question, which is, I think if we want to understand the quality of the evidence, then you need to ask hypothetically, suppose that there was a harm of that rate, of a certain rate, would we be able to detect it with the level of monitoring and surveillance that we applied to the issue? And I think that given the data that was presented here, very, very low numbers, very low, very short follow-up time, and not really comparing to placebo, the answer is that could be major signals out there that our surveillance and the way we monitor and measured would not have detected them. So I think that the question, is there evidence to harm, cannot be untangled from what was actually measured. And I think that that's something we tend to do not only in this particular question, we tend to do that more broadly when we think about safety. So the first order question is, what do we believe, given our monitoring system, given what we actually monitored and checked, we would be able to detect? And I think that the answer is basically nothing.
Well, but I would say, if I may, Robert, that there is evidence of benefit, and we've seen that from the following rates.
Okay,
there is
but
no
that's,
evidence of harm.
Okay. You've asked a question. Presenter has responded to the question, focusing predominantly on the IOM reports that indicate that the evidence is ambiguous or non-existent. We've had a follow-up question.
I have one just also on the benefits, so, and it's going to be short. So I think that if we want to claim that there is a demonstrable benefit, then my simple question, and I'm looking forward to hear if there is an answer, what is the number needed to vaccinated related to babies born to mothers tested negative to prevent one case of chronic hepatitis B? And I think that, I suspect that there is no answer to that question. And the reason why there is no answer to that question is that the risk is so small that the numbers is probably in the millions, which means, going back to the question about safety, that in order to be able to feel that it's worthwhile to recommend and take a vaccine, we will need to have a vaccine that has a number needed to harm that is bigger than millions. And I honestly don't believe that we have vaccines like that.
If we're going to follow the structure of the agenda, and I asked Cody to phrase his query as a question rather than as an opinion. Also, you're sharing with us your opinions.
I'm asking, what is the number needed to vaccinate? This is a concrete question.
Okay, which is a perfect segue because Dr. Meissner referred indirectly to CDC subject matter experts, many of which we have here. So Dr. Meissner's query, if I can rephrase it, was, tell me if you agree, Cody, the specific question was, what are the data or evidence concerning risks associated with what is really a diverse range of products? Let's acknowledge that there's not a vaccine, there are multiple vaccines. So a question to our CDC colleagues, subject matter experts, can you address from your standpoint, rather than IOM, what are the known risks associated with these products based on currently available information? Over.
The evidence is limited. There's
okay, that's you, but we have and you are it's true, you are internal CDC.
Fair enough.
But there's an SME room here. Any of you there at the subject matter expert room here at the CDC care to weigh in on Dr. Meissner's question? Over.
Hi there, this is John Su, Acting Director for the Immunization Safety Office in the SME room. Can you hear me okay?
Yes, sir.
Okay, thanks for the opportunity. I just wanted to provide some additional context on the rapid systematic reviews that were mentioned. We presented those data back in September in response to a specific ask from the CDC ACIP chair. And one of the asks was for vaccine safety data within the first, or for hepatitis B vaccine administered within the first 24 hours of birth. So that was one of our inclusion criteria, which led to the exclusion of a number of different studies which were mentioned today. The other thing I would add is as part of that review, we followed a standardized, reproducible methodology that included grade criteria. That stands for grading, assessment, development, evaluation. And that grade criteria establishes levels of confidence. And I would add that a number of the studies which were excluded, not only because of the time frame in which vaccines were given, but also because they were of low confidence. And then one other thing I would mention is that some of those excluded studies were also included the use of vaccines. They're not currently in use today, in particular because they actually contain thimerosal, which has not been included in these vaccines since 1999-2000. So I just wanted to provide that additional context in terms of what the systematic reviews or the rapid systematic reviews showed. Of those data that met inclusion criteria, many of the adverse events noted were consistent with what we're seeing in the pre-licensure trials. So I just wanted to provide that additional context. Thank you.
Follow up to that. Thank you for that comment. I heard you share with us the further information and context around your prior presentation, but I did not hear you specifically address Dr. Meissner's question. Has the CDC detected any adverse events? Cody, am I saying this properly? Has the CDC detected any adverse events associated with any one of these products that are considered to be reproducible? Is that a fair summation?
Robert, can I just add to that? No, my real question is, has there been a reported documented case of active hepatitis or chronic hepatitis in anyone who was healthy at the time of their immunization series for hepatitis B? I'm not aware of that.
Okay, so that's Cody's, that's a specific question from Cody to the SMEs. Can you address that, sir?
That's a question that pertains more to breakthrough infection and not necessarily an adverse event per se. So I think that we would need to go back and review the data to answer that question. To my knowledge, no, but we have not had opportunity to dig in deeper. So we can get back to you on that.
Cody, is that acceptable?
Yes, sir.
Okay, thank you very much. Dr. Langer, did you have comments that you wish to share regarding these specific questions, sir?
Yes, I did want to go ahead and address Dr. Meissner's question because it's not so much an adverse event issue, but we do have data that indicates that the only instances where there have been breakthrough infections have been with persons that have a comorbidity such as an immunocompromising condition. We are not aware of any instances where someone who is properly vaccinated for hepatitis B and is healthy with no significant comorbidities subsequently developing hepatitis B.
Okay, we're now at 10:04, and the session for Q&A extends until quarter after, and we have Dr. Griffin as the next person that in the queue to ask follow-up questions, please.
Thank you. And thank you, Dr. Nevison and Mr. Blaxall, for your exhaustive work and your clear presentations. Regarding the opportunity to identify infants at risk, in obstetrics, our American College of OBGYN gives us guidance for hepatitis B screening early in pregnancy. And so I find it very concerning to see the statistics that we have reviewed in our work group. Anywhere between 84 to 87% of women being tested or results being issued before delivery, which is even more concerning knowing that in 2002, the MMWR Morbidity and Mortality Weekly Report reported that we were very good at testing women at a rate of 96.5%. So between 2002 and now, what happened? You know, how did this screening gap widen? And so this speaks to an opportunity for us to close the gap in prenatal care. And should we be pushing this off to the babies? That is my concern. You know, the term safety net that is being applied to this program that's being put on the babies, I mean, is it fair, you know, is it incumbent on the babies to save us from this when this really may be more of an adult problem? Should resources be allotted to programs? To Cody, your point, you're saying that there is, you know, a big screening gap here. Should we be focusing on guidelines there? For example, ACOG, American College of OBGYN, already has reaffirmed guidance for syphilis testing at time of delivery, as well as HIV testing, end of third trimester or rescreening at birth. Is there an opportunity there for us to capture these, this testing at the time of delivery? You know, the March of Dimes data says that 97% of women are delivering in a labor and delivery unit, or more than that, 98%. And nearly all U.S. hospitals that have a labor and delivery unit have routine serology testing. So we have hepatitis B surface antigen testing that is available that has a runtime of 30 to 90 minutes. So there's an opportunity there. There's also point of care testing that is also coming down the pike for rapid testing. So we have opportunities there that we could implement universal screening in pregnancy rather than asking the babies to kind of close that gap.
But what were your
thank you. So my question is then, do we know of these, of this type of guidance? Is there this type of guidance that is coming forward so that, to Dr. Nevison's point in her presentation, we could improve testing and then targeted treatment for infants?
So you were asking about the
SMEs?
gap in testing, and now you're asking whether there are programmatic efforts designed to address that gap. Do I understand that correctly?
Yes.
And that was directed at Nevison, is that correct?
Yeah, I think I would have to defer that to.
Subject matter experts? Okay, so then are subject matter experts online? Can you address those questions of why the gap in testing between the prior time point and the more recent one, and programmatic efforts that may exist to address that gap? Over.
Hi, this is John Sue again. I would like to point out that we have safety or vaccine safety people and other experts here. What we don't have are experts in standard of care for obstetrics and gynecology. So we would defer that particular question to experts within those fields.
Okay, so the question cannot be addressed at this point in time. Is that accurate?
Dr. Malone, I'm happy to chime in on that.
Please do, Dr. Langer. Thank you so much.
Dr. Griffin, would you mind just restating the question? I just want to make sure I'm answering the correct question.
Well, I was concerned regarding the screening gap that we've had that back in 2002 was reported that 96.5% of hepatitis, of women delivering were screened for hepatitis B surface antigen, and now that rate is reported to be much lower. And so I'm wondering, well, first of all, is there, where does that change come from? Why are we thinking that there was this widened screening gap? And perhaps the better way of phrasing that question is, where would our opportunities be to close that gap?
So I'll start with the second part of the question. We actually now have a CDC strategic priority to close that gap and to prioritize testing of pregnant women for hepatitis B. So this has actually been determined to be a major agency priority, and we're putting a lot of resources into trying to close the gap. As far as where that gap comes from, I think that as with so many things in epidemiology and public health, it's multifactorial. There are certainly issues with healthcare access. I don't know whether or not that's something that necessarily would have changed from the prior measurement period. There's also issues with availability of the testing. I actually, after we met in September, spoke with multiple OBGYNs who work here at CDC, and they indicated that in lower resource settings, in particular in the United States, it oftentimes can be very difficult to get the hepatitis B testing done in a timely way. And so that may not be the case everywhere, that some higher resource hospitals may have more effective laboratories. But it is something that is a significant problem, which really gets back to why the birth dose is such an important safety net while we are trying to improve the screening.
Evelyn, has your question been answered?
Yes, I'll bring it back up in discussion. Thank you.
Next is Dr. Hiblin. You've been waiting very patiently. I thank you for that, and you have the floor. Please structure as questions.
You're welcome. I will structure this as a question with a brief context of prior. First of all, Dr. Malone, I want to reinstate your importance of identifying that we need to have clear data without speculation in order to make our decisions, and that it should be reproducible and incontrovertible. And I heartily agree with that, especially in the context of the identification of the virtual elimination of hepatitis B as being cited as one of the 10 most great accomplishments in biology and medical science in this country. So we have a high burden of proof to change this system or change our recommendations. You mentioned that we need to carefully and quantitatively assess risks and benefits. It has previously in this discussion been asked twice if there are any documents or documentation of rates of risks and rates of harm. I have not heard any. I would like, first, my question is there any evidence? Secondly, the specific question we are to answer is to whether or not the vaccination should be given before or after 30 days. Question 2 is there any specific evidence of harm of giving this vaccination before 30 days, or is this speculation?
Okay, so your questions are directed at who in particular?
Anyone in the presenter, any of the presenters, or anyone on the ACIP is welcome to present any solid and reproducible evidence of harm.
Okay, and we have 1 minute left. Looks like Dr. Pebsworth wishes to address your question.
Mark, could you talk about the Linder study a little bit?
Sure, there was concern in that observational study about unexplained fever in infants after the birth dose. That was published and documented. There is limited evidence about the long-term risk of that.
So this was a
speculation and limited evidence. Okay.
May I just
Got
say
it.
something? Did Dr. Nevison wish to comment?
Yeah, I just wanted to read a couple of numbers that Mark showed in his slides from the Vaccine Injury Compensation Program. So this is Secretary Kennedy has described this as an adversarial program where it's very difficult to get a claim funded. So if a claim is managed, if you do manage to get a claim funded, that's probably the tip of the iceberg, or you had very convincing evidence to show the special masters. And so for children, nearly $5 million has been paid for Guillain-Barré syndrome, nearly $4 million for transverse myelitis, $2.5 million nearly for rheumatoid arthritis, and $1.5 million for neurological demyelinating disorders. For adults who are generally more successful in getting their claims funded, we have $35 million has been funded for multiple sclerosis, $12 million for transverse myelitis, $10 million for Guillain-Barré syndrome, about $8 million for various neuropathies, et cetera. So these conditions appear on the post-licensure document in the package inserts for Recombivax HB and Endurex B. So these conditions have occurred, and they, even if a small risk, they are a risk, so that needs to be weighed against the benefit that a newborn, especially to a surface antigen negative mother who is not at risk for perinatal transmission, I think that risk and benefit needs to be weighed.
Okay, so in sum, we
will weigh that risk and benefit.
We have documented through the compensation program, and we also have it documented
It's
as
not documented.
on the package insert.
Dr. Meisner?
No. Robert, I was chair of the Vaccine Injury Compensation Program for 2 years, and I can absolutely tell you that these are not confirmed associations. In fact, if you look at the website, it states that settlements were not based on an agreement that the vaccine caused those reactions. They reached an agreement during the trial to settle a case, but there was no agreement that, and I hate to say, Dr. Nevison, that's incorrect what you said about documentation of an association, because that's not the case.
Okay, now, my one job here is to try to keep us on time, and I'm failing miserably on that because it's now 10:18 and we need to allow time for our liaison members. And so I ask the forgiveness of our ACIP members, including Dr. Blackburn, who's been patiently waiting, and requests that we have an opportunity for both the CDC subject matter experts and Reed Grimes from HRSA to address the question at hand, which relates to specifically documented adverse events associated with any of these products labeled for hepatitis B vaccination purposes. Over.
Hi, this is John Sue from the SME room again. I just want to make mention that the hepatitis B vaccines, at least for birth dose, have been in use for decades. And during that time, we've had a number of vaccine safety surveillance systems, the most sensitive being the Vaccine Adverse Event Reporting System. The reports received pertaining to vaccines administered to children have largely reflected adverse events observed during pre-licensure trials. And we've published reviews of the safety profile of these vaccines over the years to that effect. And we would be happy to share that data with the work group or with the full committee at a later time. But it's out there in the peer-reviewed literature. But I would add that, as well as to the reviews performed by institutes of medicine, that there has been that the safety or that the adverse events reported after hepatitis B birth dose have largely reflected what was seen in the pre-licensure trials. Thank you.
Roger. I hope, Dr. Blackburn, you will forgive me. We can take this up when we have the discussion on the questions, if you don't mind. Is that okay? And so that we have time for our liaisons, which is a kind of a segue. Our representative from HRSA is an ex officio member and perhaps he can kick off the discussion among ex officios and then transition to the liaisons. Over.
Yes, thank you, sir, for the opportunity to speak. My name is Reed Grimes, and I'm the director for the Division of Injury Compensation Programs within the Health Resources and Services Administration, where we administer the National Vaccine Injury Compensation Program. Just wanted to piggyback off of the discussion on compensable cases. I'll just note that compensable cases can be offered from a concession for a table injury or causation in fact. So that would be where HHS has conceded an injury from a vaccine. Can also be from a court decision decided upon by a special master within the U.S. Court of Federal Claims Office of Special Masters. Then also there is a negotiated settlement that can occur where there is not a determination of whether there was a causal association, but a settlement is generated through the court proceeding and agreement on both parties. I'll say that from compensation rates, generally speaking, over the life of the program, since 1988, there have been just short of 50% overall as a compensable rate. But over the last about 5 fiscal year period, about 77 to 78% of claims are compensated. Over. Thank you for the opportunity to speak.
And thank you, sir, for that clarification. We now, by agenda, need to transition to questions from the various ACIP liaison membership. Do we have any questions from that group?
There are some hands raised.
Okay. Dr. Middleman.
Thank you so much. I just want to say that Dr. Koldorf started the last meeting stating that only trust scientists who are willing to engage with and publicly debate the scientists with other views. So I really appreciate the opportunity to make just one comment and then ask 2 questions. First, I want to talk a little bit about the interpretation of my study data, the Middleman et al. This is where a really experienced understanding of immunization comes into play and sort of speaks to Dr. Meisner's explanation of the importance of not misunderstanding antibody presence versus protection. The entire point of our study is that for most vaccines, the anamnestic response is really their superpower. So this study showed that memory cells exist such that when they see something that looks like the hepatitis B disease, they actually attack. The presence of a robust anamnestic response, regardless of circulating antibody years later, shows true protection. And there was no difference in response based on when the dose was given. The p-value for the presence of a robust anamnestic response was 0.2. Meaning there was no difference between the groups based on when they received their first dose. So I just want to make sure again that people understand that the level of antibodies before exposure to an antigen is not always nearly as important as the robust response after exposure. That's what an anamnestic response represents, and that is considered more of a gold standard. In fact, 99% of those with any detectable antibody and 82% of those with zero antibody displayed persistent immunity to a challenge. That study wasn't noted, but it was a follow-up study to that one.
So, Dr. Middleman.
My 2 questions are.
Okay, go ahead.
Yes.
Go ahead.
My 2 questions are, historical knowledge obviously is critically important when we're making policies. Risk-based strategies have a long history of not working, and when the most vulnerable of us acquire disease, all of us are truly at risk. So I'm wondering, question number 1, if the committee could please show us the existing data on the history of trying to use risk-based approaches to versus universal vaccination to address disease.
But that,
And my
isn't that,
second question-
Dr. Middleman, I strongly endorse your comments regarding recall responses and memory cell populations. But you've introduced a question now that my sense is off topic. That was talking about fundamentals of risk or other based strategies is not what's on the table right now. Did you have another question regarding the data that was provided by the presenters today?
I do.
Thank you.
I do. Thanks so much. I just want to make sure that we, again, use a very organized methodology of reviewing all of the data. It's really important to see the entire picture of vaccine policy and its implications using an evidence-based strategy, such as the evidence to recommendation framework. This is the only way to see the whole picture that's created by the puzzle versus potentially misleading single or single pieces of the puzzle. And this includes
cherry picking.
looking at those. So I want to make sure that the CDC experts who live and breathe this science, who have a historical understanding of what's happened in the past and how not to repeat these errors, and who have a nuanced understanding, for whom this is their day job, I think it's really imperative that we hear from them in an organized presentation, such as the evidence to recommendation framework, because this is really critical when making life-altering policy decisions. To that end, the question is, I would like to hear what the day jobs are for our presenters, because I haven't heard anything about them, but I know that I do still want to hear more from the CDC experts. Thanks so much.
Yeah, I think I can step in right on that. Both Nevison and Blacksill are now CDC staff in one position or another, so they actually are a CDC. I'm getting a correction here. Nevison is a CDC contractor. So I think that was disclosed. Regarding, let's see, so you asked that question, I was able to knock that one off right away. You've raised an important question or point concerning recall responses and duly noted, and you've raised another question about overall process. Can I know the answer to this, so I'm playing can you guess the answer yourself. Dr. Middleman, was grade used in determining the policy of the birth dose?
That policy was created before I joined. I've had 21 years as a liaison, but I don't believe grade was. But of course, as
you're correct. You're correct.
Evolved, as the ACIP evolved, we'd love to see it now.
Yeah, fair enough.
Thanks so much.
Fair enough, but it was not the basis for the recommendations that are present currently.
Love to see it. It was so great.
We're now at past, and I'm under the whip. We have to complete this by 10:40, and I have 13 more folks. The next one on the queue is Dr. Goldman.
Thank you so much. I'll try and be brief, and the agenda says discussion, not just Q&A. Once again, this committee fails to use the evidence to recommend framework and shows absolutely no understanding of the process or the gravity of the moment of the recommendations that you make. We need to look at all the evidence and data and not cherry pick them. Dr. Nevison, I believe, is a climate researcher, not a vaccinologist, and Mr. Blacksill is not a doctor or a PhD. You have not been transparent. You have not disclosed the members of the work group. You do not have physicians.
But just to be clear, we're constrained. We're constrained.
Have a discussion. This meeting is completely inappropriate for an administration that wants to avoid fraud, waste, and abuse. You are wasting taxpayer dollars by not having scientific, rigorous discussion on issues that truly matter. The best thing you can do is adjourn the meeting and discuss vaccine issues that actually need to be taken up. You are basing this whole presentation on the concerns of individuals who want to refuse the vaccine. And your voting language that you have proposed, as every physician knows, all medical decisions are individual based on the physician and the patient. The recommendations are not mandates. Just like I recommend a colonoscopy to a patient, they can still refuse. Your job as a committee is to look at the totality of the risks and benefits, the harms, the equity, which you have not done because your presentations focus solely on immigrants and not on a broad-based swath of the population. The waning immunity study was looking at the plasma-based, not the current vaccine. Passive immunity is temporary. You are not accurately reflecting the data to the American public, and that is a disservice. As physicians, your ethical obligation is primum non nocere, first do no harm, and you are failing in that by promoting this anti-vaccine agenda without the data and evidence necessary to make those informed decisions. So I urge this committee to make sure that you do your job appropriately so that we can take care of our patients and not political theater, which what this has become. Your data is questionable. You do not present things in an honest, fair, equitable manner. You are not using evidence to recommend framework, and you are creating confusion, and you are not looking at the effects of these votes on implementation and how we will actually take care of our patients. So with respect, please have respect for the American public and the science and do what is right by making sure you use a process that we can depend on and stop cherry picking the data by individuals who do not have the scientific evidence and data-driven background to make those presentations. Respectfully, sir.
Thank you for that informational commentary. One small point early on in your comments when I was attempting to interrupt you was regarding the you made comments regarding transparency concerning the work group. And you may not be aware that we have to operate in compliance with the Federal Advisory Committee Act, which specifically requires that work group proceedings are confidential. So I appreciate your commentary regarding transparency at the work group level. As a ACIP member, I'm familiar with what transpired at the work group and what the members are, but I am constrained from disclosing, as is the chair.
Mr. Chair, I have been a liaison for almost a decade, served on work groups, and at every ACIP meeting, they at least had the courtesy to present the names of the individuals who served on those. My name was on there for COVID and pneumonia work groups. All of the other liaisons' names were there. At least have the courtesy to show us the names of the individuals, their conflicts of interest, and who they represent in making these decisions. The work group discussions, yes, are confidential. I didn't ask for that. I asked for disclosure of who the individuals are, since you have removed all the subject matter expert physician liaisons from the work group under Secretary Kennedy. So who are the individuals that are making these decisions and making these recommendations on the work group? That's the transparency you failed to disclose, sir.
Thank you, sir, for that comment. And I'm understanding that we need to move on, and the specific request you have is included in a slide deck yet to be presented. So I ask your forbearance. The next person on the queue is Dr. Fryhofer.
Thank you, Dr. Malone, for giving me the opportunity to speak. And let me give you the context of my question. I take care of patients 100% of the time. I'm a liaison for the American Medical Association, and previous ACIP committees have felt that this dose of hepatitis vaccine at birth was crucial to protecting infants from perinatal and early postnatal transmission. I will just tell you, I see patients every day When I was a medical student, I rotated through a hepatitis ward, and those were the sickest patients I had ever seen in my life. I have treated patients that have liver disease from Hep B, cirrhosis from Hep B, liver cancer from Hep B, and death from Hep B. We know that maternal infant transmission of hepatitis B can result in chronic infection for 90% of infected babies. And we've established during the data that was presented today that our detection of these hepatitis B positive moms is not 100%. So we've got a gap there that certainly needs to be tightened up. We have a duty to protect these little babies. And I am particularly concerned about the time, this early postnatal transmission. And Dr. Meisner wanted to make some comments about horizontal, not sexual hepatitis B transmission. You know, in little baby, hepatitis B is extremely contagious. And when these little babies are born, you know, between the time they're born and when they might we might delay a hepatitis B dose, we don't know who's going to be taking care of them. Are we going to test every patient that has access to or touches that baby? I mean, that's not something that's really doable. So I would really like for Dr. Meisner's question about the non-horizontal, non-sexual hepatitis B transmission, I would like to hear his questions about that. And the American Medical Association strongly urges ACIP to maintain its recommendation for a dose of hepatitis B vaccine at birth.
Thank you. The opportunity for further follow-up by Dr. Meister will come a little bit later, and I'm sure he'll be glad to comply with your requirements. I now face a very short timeline and a very long list of questioners. So I need to ask each of you now to be very succinct, because as the more you talk, the less your colleagues are going to be able to get their points made. So the next person on the queue is Dr. Munoz.
Yes, good morning. Thank you so much for the opportunity to speak. I will be brief and have a question at the end. I am speaking as an infectious diseases specialist on behalf of IDSA, which includes pediatric and adult providers. And I have to say it is very challenging to hear this discussion today, where there is concern regarding the presenters and the data interpretation for information that has been already been well established. I would like to ask, how can this committee justify removing a well-established, successful, and safe prevention strategy that is going to protect the most vulnerable infants when the proper measures to identify those infants who are at risk are not in place? If anything, the data that we have heard today shows that the system is not perfect in being able to address the antenatal care and testing needs, and that not just a safety net, this is really a responsibility, a duty for all of us to protect these infants when we cannot guarantee that they will be properly identified. So if anything, I'm very concerned about a removal of the hepatitis B dose as an irresponsible, disrespectful, and very damaging point to the healthcare community and also to the most vulnerable patients who are at risk.
Roger, so your question was?
How can you justify removing something that is already a well-established, safe, and successful prevention strategy from a population at risk when you do not have a well-established and way and proper measures to identify those infants who are at risk?
Robert, can I try to answer this very quickly?
But we're tight, but go for it.
I think that one of the slides that we saw earlier today suggests that the policy in the U.S. is completely misaligned with many countries that I want to assume care about their children just as much as we do. And they are potentially not convinced by the very confident arguments that you and others are making, both about the safety and the need and the benefits of having a birth dose for babies that were born to mothers that are tested negative for Hep B. And just about the confidence, I think that, and I'm going to connect it to something else, but I think that the same speakers that we heard today and the same organizations were very, very adamant that the mRNA vaccines are very, very safe for children and young people. So safe and so effective. And I guess that we heard recently some evidence that maybe that confidence was not necessarily correct. So I just suggest that maybe we'll be a little bit more humble and less confident, and also look on what other people are doing, and not present the discussion as just a mere discussion, or the having different opinions as something that has to do with being evil or being irresponsible, because I don't think that that's the basis for a scientific discussion. Thank you.
Can I add something too? I'm sorry, I have no way of raising my hand over here. This is Tracy.
Hi, Tracy.
Betho from the FDA.
So this is Dr. Hoag, now acting director of the Center for Drug Evaluation and Research. Over.
Yes, that's right. Thank you, Robert. I just want to add to what Retzef, Dr. Levy just said, that it's really important to keep in mind that the U.S. is an outlier in recommending a universal birth dose of the hepatitis B vaccine compared to other high-income nations. And the data that we used to approve the hepatitis B vaccines, there's two, Engerix and Recombivax vaccines for infants, were based on studies that had very short-term follow-up and no control group. It wasn't like it wasn't like it was a randomized control trial against another vaccine. No, there was not even a control group. It was just an observational study. We would never approve a vaccine based on data like those today. So that's important to keep in mind. And then we have these 5 randomized control trials that were identified by the CDC at the last ACIP meeting that we discussed. And these are short-term randomized control trials where the hepatitis B vaccine Recombivax was given compared to other vaccines, so not compared to placebo. So we are working with very low-level evidence here, and we have very limited confidence in what we say when we say these vaccines are safe. And so, we have established that it does cause anaphylaxis, rarely fever, reactogenicity, and so there. I think that I agree with Retzef that we need to be humble, and when we're saying that we have the evidence that the benefits outweigh the harms here of giving this vaccine. And again, I think that there's a reason that peer nations to the United States do not recommend this vaccine routinely at birth when the mother is Hep B surface antigen negative. And so I just wanted to make those statements from a regulatory perspective, that we have a very low level of confidence in saying that, we can say that these vaccines, that the benefits outweigh the risks with the amount of data that we currently have. Thanks.
Dr. Hoag, you're an expert in regulatory affairs and clinical research and epidemiology.
That's correct, yes. I'm a physician and I have a PhD in epidemiology and public health, yes.
If one was to design a trial to detect an adverse event that would occur at a rate of 1 in 1,000, what would have to be the size of the treated group with the experimental product to reliably detect an adverse event at 1 in 1,000?
At 1 in 1,000, I mean, we're talking, you'd need to have at least tens of thousands. It depends on,
so the rule of thumb, as a vaccinologist, I've been taught the rule of thumb is we have to have at least 3,000 in the treated group to reliably detect an AE at 1 in 1,000. So do we have any of these, any trial data of that size that would detect an AE of 1 in 1,000?
No, we don't.
Okay, good. Do we have any trial data of sufficient size to detect an AE that would occur at, let's say, 1 in 100?
Well, so we don't have any placebo-controlled randomized trials.
So we don't have any trial data that would allow us to reliably detect an adverse event that would occur at the rate of even 1 in 100.
Well, if we're comparing to other vaccines, that's the problem here. We really need a placebo-controlled randomized randomized clinical trial.
One that would be fairly substantial if we're to detect, because
exactly right, because this is a very, I mean, if we're talking about giving a universal, birth dose, a universal recommendation, and we're talking about an extremely low-risk situation for most babies, so babies who are born without high risk factors, without a mother who's surface antigen positive, without a family member who has hepatitis B, for these babies, the potential for benefit is so low, and then you're trying to, and then you need to detect a signal, a safety signal, a serious safety signal at that rate that is so tiny. You would need an enormous trial, and we don't even have any randomized placebo-controlled trials. So, we're really in a situation where we should have more humility and say, why are we stating that it is absolutely necessary to give this dose at birth, especially when high-income nations throughout the world are not giving this hepatitis B vaccine at birth?
Thank you very much. Now, I have a comment that's required regarding the FACA rules from Dr. Pebsworth. Over.
No, I wanted to remark about one of the published studies that CDC identified that I would like to draw your attention to, and that's the Linder study from 1999. And it's an Israeli study that evaluated the diagnosis of unexplained neonatal fever in the year before and after the introduction of the birth dose vaccine. And it identified 100% increase in unexplained neonatal fever, which resulted in sepsis workups, the babies going on antibiotics, and longer stays in the hospital. So that is one example of a study of harm.
Okay, clarification, a comment that I made earlier regarding the query concerning working group membership. The Federal Advisory Committee Office has alerted me that under FACA rules, disclosing working group names is optional, but nevertheless, there's been a decision to go ahead and do that in a later slide. Over. Now, there has been a request by program to add additional time to our discussion now so that we can get through some of our other liaison member comments, and so we will continue until 10:50. It's now 10:48. So Stacy Buchanan, Dr. Buchanan.
Good morning, everyone. Thank you for allowing me to make a brief comment question. So, there hasn't been evidence of widespread safety signals or issues or adverse events widespread. And so my question is, why now are we bringing hepatitis B forward for review? And I understand what you're saying about being humble. However, without the clear evidence to show that this is a problem, with the might of this ACIP committee, I'm just trying to figure out why this is an issue. And I did raise this question the last meeting, and I'm still trying to understand why we are bringing this issue forward without evidence of harm to infants, when we know that the risk of harm without them getting protection is great.
I believe that was explicitly addressed in the presentations right at the beginning. Dr. Griffin, do you wish to respond briefly?
Yes, briefly. First, Dr. Hogue, thank you for bringing up the preclinical trials. These two products for birth dose were set for 4 and 5 days of testing and without a placebo trial. So with 5 days, would you be able to pick up any safety signals when there are there safety concerns and signals? There indeed are. Are we presenting those studies? No, because they are underpowered, they are underfunded. There are signals of autoimmune conditions. Multiple sclerosis, for example, is a large signal, but these researchers do not have large grants to study these issues. So this is the crux that we're in, that there is a signal that is may take decades to show up. And so the concern is we're trying to evaluate in a low-risk population. We are respectfully wanting to continue the program for hepatitis B positive mothers, but for those that are negative, for the babies that are low risk, we are trying to evaluate what is their risk. If the risk is something that is not, that we have to look beyond just seroconverting these babies within 5 days. We have to look what is happening now that this program has been in place for decades. Well, sometimes autoimmune conditions take decades to develop. So there are a large number of studies that have an association, not causation, with multiple sclerosis and other autoimmune conditions. And so if those signals are not being studied properly, and we are currently continuing to onboard these, the hepatitis birth dose, we're trying to evaluate, is there a concern? Is there a risk for these babies? Should this be paused in the meantime so that we don't continue autoimmune risks? One specific example, researcher Romain Girardi, for example, to give something more concrete, macrophagic myofasciitis, where he had sampled, he and his researchers had sampled injection sites, granulomas called MMF lesions at site of injection, where they were able to identify aluminum adjuvant in those granulomas. And this correlated very high with the vaccination that was received at that vaccination site. These patients, myofasciitis patients, had conditions of autoimmune condition, brain fog, generalized weakness, to the degree of debilitating disease, where they were not able to work, function, their normal daily activities. So these types of conditions are characterized and with close association with a vaccine. Is this causation? No, it is not. But there's a bigger problem here in the fact that these studies are wholly underfunded. There's few opportunities for these researchers to be able to evaluate this properly, and this is where we should seek this opportunity rather than perhaps looking at risking low-risk infants.
Okay, so we're now out of time because we have to respect the three manufacturers who have time to comment. And so I'm sorry to say that we need to close this down. I would just leave with one closing comment. We've heard from our colleagues in the press and various recent publications about what they anticipate the voting language to be. But the voting language now, I think, is available. And so I suggest that rather than speaking to hypotheticals of what may take place, all of us would benefit from actually reading the proposed language, which may be quite different from what may have been anticipated based on various uninformed commentary. Now, with that, I need to adjourn this section. I apologize to Dr. Mohamedy, Paulson, Hutchins, Joseph, Scheffler, et cetera. I thank you for your patience and apologize that we don't have time to capture your important comment and input, but now must turn to calling on our hepatitis B vaccine manufacturer representatives, beginning with Dr. Candace Robinson from GlaxoSmithKline.
Good morning. Is my audio clear?
Yes, ma'am.
Thank you very much. My name is Dr. Candace Robinson. I am the Medical Director of Scientific Affairs and Public Health at GSK Vaccines. GSK values the opportunity to make a comment today. We've submitted a letter to the docket in preparation for this meeting. Within it, you'll find important information on the hepatitis B birth dose, some of which I will share now. Data consistently show that hepatitis B birth dose vaccination is critical in preventing chronic hepatitis B virus infections, which disproportionately impacts infants. Without vaccination, 80 to 90% of babies infected at birth develop chronic hepatitis B, increasing their risk of liver-related complications, cirrhosis, or liver cancer later in life. A recent peer-reviewed analysis by Pham and colleagues published in the July 2023 issue of the American Journal of Preventive Medicine found that during 2015 to 2020, up to 500,000 women given birth in the United States each year were not tested for hepatitis B during pregnancy, despite current guidelines. GSK's Engerix-B recombinant hepatitis B vaccine has been approved by the FDA since 1989. 1.4 billion doses have been administered worldwide, with data from dozens of studies establishing that it is effective with an acceptable safety profile, including when given at birth. More than 35 years of post-marketing safety data has been collected, continuously reviewed, and appropriately submitted by GSK, in addition to established safety monitoring conducted by U.S. regulatory authorities. GSK also manufactures Pediarix, a combination of diphtheria, tetanus, pertussis, hepatitis B, and poliomyelitis vaccines for children 6 weeks through 6 years of age. This vaccine has been similarly well studied, approved based on rigorous regulatory review, and monitored by both GSK and the appropriate authorities. The data supporting the safety and efficacy profile of GSK's hepatitis B containing vaccines is copious and cannot be adequately summarized in a short statement. We welcome the opportunity to appear before the panel at a future date where a dedicated session can facilitate a thorough scientific exchange and discussion. Thank you for allowing us the opportunity to make a comment today, and we return the presentation back to the panel.
And I thank you, Dr. Robinson, for your clarity and succinct nature of your presentation. We now have the pleasure of listening to the position from Merck Vaccines and Dr. Michelle Govea. Forgive me if I've mispronounced your name.
Thank you. Can you hear me okay?
Yes, ma'am.
My name is Dr. Michelle Govea, a pediatrician who is in the Global Medical and Scientific Affairs Department at Merck. Based on nearly 40 years of data and evidence, Merck supports the current hepatitis B vaccine birth dose recommendation. Newborn vaccination against hepatitis B is a crucial public health strategy to prevent chronic viral hepatitis and its long-term consequences. The risk of developing chronic hepatitis B infection is strongly age-dependent, with up to 90% of infants infected at birth progressing to chronic infection. This transmission may occur from an infected mother, as well as close contacts from an infected family member who may not know that they have hepatitis B. Exposure can come from others the child interacts with, including parents, caregivers, and even strangers, as the virus can live on a surface for up to a week. Thus, vaccination of infants is essential to interrupt this cycle of transmission. Recombivac's HB, first approved by the U.S. Food and Drug Administration in 1986, has been the foundation of hepatitis B prevention in the U.S. and globally, with over 330 million doses distributed. Limiting hepatitis B vaccination in the U.S. to only newborns of infected mothers would fail to potentially prevent transmission, disease, cancer, and death. Countries with at-risk recommendations typically have much smaller populations, often a fraction of the U.S. population, and have healthcare systems that support constant screening, testing, and care coordination. In contrast, U.S. health systems face significant challenges in identifying people living with hepatitis B, making the diagnosis of maternal infection and subsequent vaccination of newborns systematically more difficult and likely to lead to congenital infections. Also, a negative test result during pregnancy does not guarantee the child will not be infected with hepatitis B virus. There is a potential for false negative test results, and the mother could acquire hepatitis B infection after testing and transmit it to the infant. Thus, a birth dose recommendation in the U.S. that only applies to at-risk mothers would fail to account for these complicated transmission and screening dynamics. Removing, delaying, or weakening the birth dose hepatitis B vaccine recommendation could also impact the administration of other vaccines on the pediatric and adolescent schedule. If an infant does not receive timely hepatitis B vaccination, there could be disruption in the administration of hepatitis B containing combination vaccines. These vaccines help ensure series completion for full protection against hepatitis B, as well as protect against polio, tetanus, diphtheria, pertussis, and Hib. These vaccines are developed to provide doses that most healthcare providers and caregivers choose for their patients and children. If there are large shifts in availability and health system demand, there could potentially be supply constraints and limited access for children and adolescents. This would further limit parental choice, erode vaccine coverage rates, and diminish disease protection. Thank you.
And once again, thank you for making your points clearly and succinctly. I look forward now to the presentation from Sanofi, from Dr. Ayman Chit.
Good morning. My name is Ayman Sheet. I head up the Medical Affairs Department at Sanofi Vaccines here in North America. And on behalf of Sanofi, I appreciate the opportunity to provide comments and share our perspective. We share a commitment to public health, transparency, and evidence-based medicine. Our priority remains ensuring access to and the availability of safe and effective immunizations. Sanofi immunizations approved by FDA and recommended by CDC benefit the health of children, families, communities, and health systems by helping reduce the burden and severity of vaccine-preventable diseases. We here adhere to high scientific values and uphold rigorous standards under which our immunizations have and continue to be developed, tested, evaluated, approved, and monitored. Sanofi immunizations aim to maximize protection with the fewest doses to meet the medical need of all Americans. Across all of our products, we monitor their life cycle from pre-licensure through post-licensure to ensure safety and efficacy. Each ingredient in our immunizations play a specific and necessary role in protection, either by stabilizing the formulation, enhancing immune response, or ensuring safety during storage and administration. These components are carefully selected and used in the lowest effective quantity, based on decades of evidence and regulatory oversight by FDA to maximize benefits while minimizing risks. The current U.S. childhood immunization schedule is based on robust data that demonstrates safety and optimizes protection for infants when they are most at risk. Delaying vaccination increases the time that a child is susceptible to vaccine-preventable diseases, as most infants immunized required a second and third dose to reach full protection. Combination vaccines are given to approximately 80% of U.S. infants and reduce the number of injections, minimize discomfort for children, and improve workflow for healthcare providers so they can administer vaccines safely and effectively. Parents generally prefer combination vaccines to reduce the number of injections a child receives in a visit and the overall number of office visits. Changes to recommendations for any component within a combination vaccine risks reducing options for families and could disrupt vaccine supply and limit access for years. These supply challenges would extend beyond combination vaccines to include standalone vaccines that prevent diphtheria, tetanus, pertussis, Haemophilus influenza B, and polio. If high-quality evidence were to show a safety concern with any of our immunizations, we would act immediately to address it and develop safe alternatives. At present, there is no credible evidence indicating a safety risk with today's immunizations. Making changes to these immunizations would require extensive research, testing, and regulatory review, and there are long lead times required for manufacturing and production. This would leave patients without access to the protection from today's vaccines. In conclusion, Sanofi values informed consent and supporting families in making decisions based on the best available data regarding the risks and benefits of various vaccines. We are proud to play a role in making those choices available, which aligns with the HHS Secretary's strong support for families to have access to immunizations. Removing options limits parents' ability to decide what is best for their families. We look forward to our continued partnership to maintain recommendations that protect infants early in life when they are most vulnerable and to preserve access. Together, we can continue to prevent serious disease and safeguard public health. Thank you very much.
Thank you again for being succinct, on point, and for the nature of your language, emphasizing partnership and long-term commitment on the part of Sanofi and the other manufacturers that have been here presenting. Now, with that, we have reached the end of the morning session. I thank all concerned and regret that we don't have more time for these very active discussions. I know that I recognize you, Dr. Griffin. But that brings us to the close of this morning, and we will take this up again, the same topic area, hepatitis B vaccines, at 11:35 Eastern. I am being actively solicited by a fellow peer at the ACIP membership level, Dr. Griffin.
Appreciate it, Robert. Thank you. Just because we have the manufacturers online, I have a quick clarification and comment and question. For each one of the manufacturers, the production of I get from the package insert, the production of the antigen, is it still made from fermentation cultures of recombinant strain of Saccharomyces cerevisiae, number one, and how long has that been going on for? If you could briefly respond, each one of you.
Okay, so host agent for production of antigen is the question.
Yes.
GSK. Can you comment?
Basically, are you all still using the Saccharomyces cerevisiae? And I read it was since 1986, each one of the manufacturers. Is that correct?
So are we still using yeast? Are we still using yeast-based fermentation? Dr. Robinson? Dr. Robinson appears to have signed off. Merck, can you clarify the host used to manufacture the antigen?
This is Dr. Govey. Yes, that is correct.
Dr. Chit, host for manufacturing antigen.
We use the Merck manufactured component.
Okay, super. Thank you for answering that. I just wanted to double check that because regarding the anti-Saccharomyces cerevisiae antibody, that is now a recognized serology that we need to test, speaking specifically from functional medicine. This is something that has been identified as an important marker for us to check in inflammatory bowel disease. Lin et al. In 2024 in that paper reviewed the global trends in rise in inflammatory bowel disease, and interestingly, it was from years 1990 to 2021 that there was an 88% rise in IBD. And the anti-Saccharomyces cerevisiae antibody has been noted to be positive in Crohn's disease, 46 to 70% of Crohn's disease are positive for that antibody. Ulcerative colitis a little bit less, 6 to 15%. But nonetheless, this is an alarming rise, 88%.
So your question, can I paraphrase? Your question, I think, is there evidence for vaccine for Cerevisiae antigen antibodies associated with administration of these Cerevisiae-derived products? Is that the question?
It is, but with one commentary, this yeast is very common in consumer products, so it is very environmentally available. This is from my awareness, one of the few products that are actually injected, if not the only one, where it is injected. So basically it is circumventing natural barrier immune systems. So to my earlier comment, when it takes, sometimes decades for immune disorders to develop, are we seeing this in this context?
So are you,
disease?
because we're out of time.
Okay, so my question is to the manufacturers, since we have them online, what studies have they performed or are they aware of to check for associations or causality?
Of eliciting a adaptive antibody response to yeast antigens post-vaccination with the hepatitis B product. Is that accurate?
Then lead to inflammatory bowel disease.
But that's the
Yes.
first let's get to, do we have studies about generating antibodies to yeast antigens like you do with influenza to egg antigens? Over. Dr. Govin? Is this a?
Yes, this is Dr. Gervais from Merck. The safety profile has been well established for decades and is closely monitored on a continuation basis. Yeast is a common bowel flora, so finding that in the bowel is not unexpected.
Yes, but we're injecting it, so we're bypassing.
Okay, but I'm being remanded that I need to get you back on track. So, but you've asked a specific question. Dr. Cheat, with your pharmacovigilance, is the risk of acquired adaptive immune response against antigens present in the vaccine product from the manufacturing process something that's being evaluated?
Yes, so all serious adverse events are really critical to monitor very closely. That's why we have very robust processes to monitor safety post-licensure, and we haven't seen anything that would cause us to have a concern in this space. Thank you.
Okay, so with that, will you allow me to adjourn? Okay, and I will see you all back here at 11:35 a.m. Eastern. Thank you. This meeting of the Advisory Committee on Immunization Practices, or the ACIP. The first item on the afternoon schedule is a continuation on the topic of hepatitis B vaccines, beginning with a summary of information a summary of information from Dr. Pebsworth. I will read the proposed question language after I summarize my understanding of what we have as agreements and disagreements, and then we will proceed with the VFC presentation, CMS comments, and downstream agenda items. So with that, Dr. Pebsworth, please proceed.
Good afternoon. I'd like to describe what the Childhood and Adolescent Schedule Work Group did to prepare for today. We had a process and we had findings, and we developed some proposed voting language, which Dr. Malone will be discussing. Next slide, please. As I mentioned this morning, 4 of the members of the work group were or are still ACIP members. We had outside experts, Dr. Brian Morse and Dr. Christine Staubel-Ben, and an ex officio participated also in the work group meetings. Next slide, please. The policy request made to the work group was to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers were antigen negative. And by nature of discussing the birth dose, it's unavoidable to also then talk about subsequent doses too. So even though the request was to focus on just the birth dose, we also touched on topics that are relevant to future doses as well. In this particular population of children, those whose mothers are hepatitis B surface antigen negative. And as I mentioned earlier this morning, The terms of reference document for this work group includes the following language: review the efficacy and safety of the immunization schedule for children and adolescents, identify efficacy and safety problems, and address stakeholder concerns. I mentioned this morning some of the stakeholder concerns that have been raised in survey research, and I shared those. Next slide, please. So again, the reason this topic came to us and we're working on it is because there was information from shareholders, feedback, primarily parents. There's also the perception that there is a misalignment of the U.S. recommendation as it relates to other similarly situated countries, as shown in the bar chart that was at the tail end of my presentation this morning. And it's been a long time since the last comprehensive review of hepatitis B vaccine was done by the work groups. Next slide, please. The finding of the work groups, hold on a second. Yes, process. So we picked up what we worked on following the September meeting. So at the September meeting, there was a request made for some additional information. We took that back to the work group. We prepared a request to CDC for additional information and data. We gave CDC 16 questions that they worked on and provided answers back to us in our work group meetings. Between October the 17th and November 24th, the work group met 7 times. We had 12 presentations by CDC staff, work group members, and invited ad hoc experts, and they covered the topics of clinical ethics, non-specific vaccination effects, aluminum adjuvant exposures, clinical practice challenges and solutions, and the Alaska hepatitis B vaccine trials. Next slide, please. Through a series of polls that were disseminated amongst the work group members, there are some themes and findings. Areas of full or nearly full agreement include the following items: that hepatitis B virus can be transmitted vertically and horizontally to infants, is a serious disease, and can be prevented by vaccination and the hepatitis B vaccine, and also immune globulin in certain populations. There is uncertainty about the true rates of incidence, prevalence, and horizontal transmission rates in the U.S. population, as Dr. Nevison described. The third point is that there is uncertainty about whether all 3 doses are needed to produce and acquire protection. Fourth point is there are gaps in evidence and limitations, as Mark described, and the evidence of safety per the grade system of evaluating the quality of scientific evidence found that the safety evidence available to us was characterized as poor. Next slide, please. Infants born to mothers who test positive for hepatitis B surface antigen should continue to be vaccinated with hepatitis B vaccine and receive hepatitis B immunoglobulin soon after birth. There was full or nearly full agreement that any gaps in screening pregnant women for the hepatitis B surface antigen should be eliminated so that all infants receive appropriate care. Rescreening of pregnant mothers upon admission for delivery should be considered so that there are no mothers whose hepatitis B surface antigen status is unknown. We regard that as a quality of care problem, and a serious one at that, if not a medical error, and something that should be characterized as a never event. It has implications for the care that the baby receives and follow-up in the community. Lastly, infants born to mothers who test negative for hepatitis B surface antigen have extremely low risk of horizontal infection during childhood and particularly in the first month of life, and therefore do not need to be routinely vaccinated with the hepatitis B vaccine at birth. Next slide, please. There were some central themes related to the type of preventive care needed for hepatitis B situations. The first being that there is a need to improve the quality and appropriateness of hepatitis B preventive care. Again, screen all pregnant mothers. There should be no unknowns, and appropriately treat all newborns based on the mother's actual status. The second item is to minimize adverse events in vulnerable infants, avoid unnecessary life exposures. The third item is fostering individual-based decision-making and respect for parental autonomy, permit clinical flexibility and individual risk assessments. The fourth item is to improve safety monitoring and research. The gaps between what we think we know about safety and what we truly know about safety need to be closed. Fifth item is that the U.S. policy may need to be modified, considered in light of the situation that is in other countries. We discussed return to a targeted and successful strategy, more in line with other developed countries with low endemicity. Next slide, please. The work group evaluated 3 different voting options in large categories. There was an option to consider continuing universal vaccination of all infants, and there was 2 of the work group members preferred that option. There was also an option for no recommendation whatsoever for this group of babies. One work group member preferred that. The remainder of the work group members, which was the majority, preferred an individual-based decision-making option. But I want to point out that the second choice for half of the work group was the no recommendation option. The primary reason that that was not preferred was because of concern about acceptability. Next slide, please. The rationale for preferring an individual-based decision-making option is that the overwhelming majority of infants born to mothers who test negative for hepatitis B surface antigen are not at risk of being infected with the hepatitis B virus, especially in the first few months of life, or the threats of infection are very low. Vaccine safety risks are not well understood and were never assessed properly. An individual risk-based approach is needed, with recommendations tailored to risk-benefit profiles and preferences involving informed consent. Next slide, please. Additional reasons for preferring an individual-based option is that the potential to allow the parent to choose a point in time closer to the onset of risky behaviors, sometimes encountered in adolescence, and for those who prefer to wait, use the catch-up schedule options as are noted in the CDC schedule beginning at age 11. It also provides options for avoiding early infancy vaccination risk associated with early infancy and adolescence when there are biological windows of vulnerability. It also creates an opportunity to use serology testing to determine whether additional doses of vaccine are needed for protection. Next slide, please. It creates an opportunity to use serology testing, that was repeated. Provides for return of decision-making to parents in concert with the healthcare provider who wants flexible schedules and the ability to tailor care to individual patient needs. Also discussed was a 2-month age of starting the series. The additional 2 months of maturation as it relates to the blood-brain barrier, liver, and kidney function is desirable. It is in line with the policy of other comparable countries, would then permit the use of combination vaccines and limit the number of injections as well as make lower aluminum-containing products more available. Next slide, please. There were a number of reasons why that an individual-based option was not preferred. There were concerns about rare exposures to the hepatitis B virus that could cause an infection and a chronic infection with hepatitis B virus. Concerns about acceptability to the medical and public health communities. The system that's in place will be difficult to change. It will take too much time to counsel parents about the risk and benefits, and access to educational materials isn't obvious. Concerns about liability, payments, and additional paperwork were raised. The safety concern may be more theoretical than real risk. Next slide, please. Implementation considerations involve the ability to successfully use PEP in births and hepatitis B antigen-positive mothers, the need to strengthen maternal screening programs, immigrant medical examination screening. Delaying the time of the first dose will allow choice of using different vaccines, both monovalent and polyvalent options. Next slide, please. Implementation considerations. Even under the existing universal dose policy, not all babies are vaccinated at birth, and there are no detectable increase in the incidence of hepatitis B infections. There's data from the 2016 to 2021 CMS of newborn infants. Next slide. Pregnancies and live births were coded and evaluated. Next slide. Total births, infants receiving the first hepatitis B dose by 2 years of age was 90%. Infants receiving hepatitis B birth dose was 70%. So there is some delay in uptake of hepatitis B vaccine in this population. Next slide. The age at first dose of hepatitis B vaccine, 100% of these patients had received a vaccine by the time that they were 2 years of age. And you can see a distribution of vaccine uptake according to different intervals and segments. But at present, 76% were getting a birth dose, and many were not getting a birth dose. And again, like I said, there's no observable uptake in incidence of hepatitis B infections. Next slide, please. And lastly, this is the same slide as before. The work group felt that it was very important for us to consider a variety of ethical challenges and components, and that involves potential harms and burdens on both sides of the equation, both from the disease and the vaccine. We thought it was also important to understand the impact of various policies on the autonomy of parents, the impact on equity, and expected efficiency. I explained the other ones earlier. So at this point, I'd like to turn the discussion over to Dr. Malone to talk about the voting language.
Thank you, Vicki. I think you've really nicely covered these three key points. I think if I understood your presentation, there's broad agreement that hepatitis B is a serious health threat with serious outcomes. That's not up for debate. Babies that with moms that are Hep B positive, antigen positive, should be vaccinated and treated with immunoglobulin. I think that's not up for debate. That's not a discussion point. There is broad consensus on that. Number three, that there's broad consensus on the need to improve screening in general and specifically in pregnancy, ideally to retest upon admission. I think that's also not up for debate, and I hear informally from our friends and colleagues at the CDC that there are active programs in progress to augment those capabilities and strengthen those capabilities within the United States healthcare system. So I think we can park those topics. Everyone, there's broad agreement on those topics. There does seem to be some disagreement that the evidence that birth dose interval and population benefits are compelling. What is the risk of horizontal infection? That seems to be a topic of some considerable discussion, and there's a diversity of opinion in that. There's also a diversity of opinion regarding the population level benefits of the existing safety net and its adequacy and penetration. I think that's another thing that is an open discussion. And I think that what I've heard, if I can summarize, hopefully this is accurate from this morning's discussion and your presentation, is that there is discussion, there is a diversity of opinion regarding the existence of evidence of harm and the confidence level that we have around that incidence of harm evidence or lack thereof. So those are topics that seem to be at the center of a lot of the discussion and are largely unresolved. I think we to be honest, we all acknowledge that there's diversity of opinion there and that there is a need for considerable additional data before we can have clear decisions. But as my friends that routinely practice medicine, I'm only licensed to practice medicine, I'm a researcher, but those that do tell me that we often in medical practice have to make decisions based on imperfect data. And we are now in a position regarding hepatitis B where we have less than perfect data. Is that fair? Okay, so with those things in mind, the work group and the broader ACIP have, with input, for instance, from CMS and those that are making decisions regarding compensation practices within CMS, which is a key determinant here of accessibility and equity. These are key criteria under the grade system. It's absolutely essential that whatever recommendations that are offered to the director. Remember, this ACIP does not set vaccine policy. Sorry, I apologize to various senators who seem to think otherwise, but in fact, the ACIP only advises the director of the CDC or the acting director about their independent review of policy issues, and it is up to the director or designated director to set policy. ACIP does not set policy. I want to be clear on that. The votes, the language of the votes that is currently under discussion includes 3 different votes, and I'm going to read that language right now for all of us. I don't think we have a slide for that. Is that true? We do not have a slide for this current language. I'm hoping that we do. Okay, so failing to see that slide, I'm going to read it. For vote number 1, this is the draft language. It's absolutely not approved. It's up for discussion. ACIP recommends a birth dose of hepatitis B virus vaccine and hepatitis B immunoglobulin for infants born to women who test HB surface antigen positive. ACIP recommends individual-based decision-making in consultation with a healthcare provider for parents deciding whether to give the hepatitis B vaccine birth dose to infants born to women who are hepatitis B surface antigen negative. Okay, so for those that are women who are documented as antigen negative, the language would recommend individual-based decision-making in consultation with healthcare promoter for parents. Parents should consult with healthcare providers and decide when or if their child will begin the hepatitis B vaccine series. And we have a footnote associated with that. Parents and healthcare providers should consider vaccine benefits, vaccine risks, and infection risks. For those not receiving the hepatitis B vaccine birth dose, it is suggested that the initial dose is administered no earlier than 2 months of age, Now I'm going to read the footnote, if I can find it here, that was added. The footnote for vote number 1 that I mentioned earlier reads, parents and healthcare providers should also consider whether there are risks, for example, such as a household member who is hepatitis B surface antigen positive, or when there is frequent contact with persons who have immigrated from areas where hepatitis B is common. So that explicitly acknowledges the high-risk population in which there is a social context which increases risk for horizontal transmission. For vote number 2, up for consideration, ACIP reaffirms the current standard of care that a birth dose of hepatitis B vaccine and hepatitis B immunoglobulin is administered for infants born to women whose hepatitis B surface antigen status is unknown. So those that do not have a known positive or negative test for hepatitis B surface antigen, we have this vote number 2 language that ACIP reaffirms current standard of care that a birth dose of hepatitis B vaccine and hepatitis B immunoglobulin is administered to infants that from mothers whose antigen status is unknown. For vote number 3, when evaluating the need for subsequent HBV vaccine dose in children, parents should consult with healthcare providers to determine if a post-vaccination anti-HB surface antigen serology testing should be offered prior to subsequent hepatitis B vaccine dose administration. Serology results should determine whether the established protective anti-hepatitis B surface titer threshold of greater than or equal to 10 milli-IU per mil has been achieved. This is the well-established threshold titer levels that is widely accepted in clinical practice. The cost of this testing should be covered by insurance. So that's the language for the 3 votes that are currently up for consideration. And with that, I transition to the Vaccines for Children presentation from Dr. Santoli of CDC. Dr. Santoli.
Hello. Yes, sir.
Yeah, I can hear you.
Okay, I just sent an updated slide deck to make sure that what I'm going to present aligns with what you have just shared. So it may take just a second, and I apologize for that. But yeah.
Thank you for your agility and willingness to adapt to the situation.
Sure.
So a moment of quiet while Dr. Santoli's slides get loaded.
Robert, this is Cody Meissner. Are those the only 3 options that we can vote on?
So Cody, I'll give you a read ahead. As you know, based on the rules of order here, ACIP members have the right to make a motion for change or alterations in the scheduling regarding whether or not we're even going to hold a vote. So as happened in the last session. So that is the language that is currently in front of us. And that language is subject to amendment by ACIP members using the proper rules of order. Have I answered your question?
Okay, so I will wait. Thank you. Thank you. That's very helpful.
Yep. So absolutely, it's open to amendments and recommendations following proper rules of order when we get to that part of the agenda, if you're okay with that.
That's perfect, yeah. So that'll be after Dr. Santoli's presentation.
And after CMS comments from Mr. Johnson.
Okay.
That's the current schedule. And then if we do choose to proceed to a vote, there will be, after Johnson, there will be discussion. First, ACIP members and ex officios, and I have a list of those that wished to comment in the prior discussion section. And so I will be working down that list in this upcoming discussion, and then discussion once again from our respected liaison members. And then we get to whether or not we have perspectives from people with lived experiences. And then we have a potential motion as to whether to proceed to a vote, because public comments must immediately precede any vote that we take by ACIP charter. Roger?
I hope the coffee pot is full.
You're missing out on the chocolate-covered coffee beans that were circulated earlier. Dr. Santoli, are we good to go live?
I am checking.
Okay.
In the meantime, I'd like to note that this is the third version of the questions that most of the ACIP have received in 72 hours. And we're trying to evaluate a moving target, and we don't even have a slide explicitly describing what questions we're supposed to answer. We only have a verbal report from the chair. So I rather protest the description that the ACIP members have been consulted in developing these questions, and hope that we can have a more timely presentation to figure out what we're voting on, rather than, what is it now, 2-3 hours before the vote? I request that we have more information, more time to evaluate these important questions.
So thank you for that. I acknowledge your point as having merit, and the appropriate time I suggest for making a motion to that effect will be after we have the perspectives from people with lived experiences, if you will tolerate that. Thank you. Are we live yet? Dr. Santoli?
I don't know.
Okay.
Dr. Malone, I'd like to ask you a question to make sure I'm asking people to pull up the right slide deck. So may this is not the slide deck. So first, would you be willing to repeat the 3 statements that you made? Because I want to make sure, I had a couple of presentations to try to be flexible. I don't want to pull the wrong one up and confuse people. So I'm wondering if you'd be willing to repeat.
Okay. So this is, forgive the audience and the public. What we're dealing with is a little audio-visual challenge. and we're just ensuring that we have harmonization in the slide deck. So the slide deck that we all hope that you have would indicate 3 votes. That would be the first thing that you can cross-check. And one of the items, the language for vote 2, to ensure that we're aligned. To ensure that we're aligned with your presentation, language for vote 2 would say ACIP reaffirms the current standard of care is the first few sentences. Is that, you got that one?
Yeah. Yes, I did it a little bit differently, as you'll see, because it fits into the resolution. But what you just said about vote 2 is reaffirming the recommendations for status unknown. And that was actually my primary question for you, sir.
Is that breathe? You want me to call a break?
We really need to know what we're voting on.
I concur. So suggested is that, do I have a motion that we take a brief respite to ensure harmonization with the slide deck that the next presenter will be providing? Do I have a motion from the floor? So moved. Do we have a second? Any opposed to taking a brief break right now for audiovisual harmonization? Okay, so moved, approved, and we'll reconvene hopefully within 5 minutes.
Thank you.
From people with lived experiences, and only after there is consensus on the we've cleared any motions to amend the language. Only after we have cleared that will we have the presentation from Dr. Santoli. So with that, the next item on our agenda today, having reconvened, is to hear from CMS and its representative, Dr. Andrew Johnson.
Thank you, Dr. Malone. So I'll provide comment from a CMS perspective on the coverage implications with regard to the hepatitis B vaccine as we've discussed today. So having reviewed the new language as covered by Dr. Malone a short time ago, we have reviewed the language and it's the CMS position that regardless of testing status and with the inclusion of the individual-based decision-making language for mothers who fall in the negative category, that there are no coverage implications, and that for both positive, negative, and unknown, that there would be access to the vaccine for coverage without cost sharing at any time that the parent would prefer to get that. So regardless of the timeline for their preference.
So if I can summarize that, I think what I heard was this language will have no impact on availability of covered vaccines for parents and children. Is that true? Did I get that correctly?
Yes, sir, that's correct. That as long as made in consultation with their provider.
Thank you, sir. So with that, I I open the discussion first to, so we're back in discussion section time now until approximately, let's see, 1:50. So we have quite a bit of time now for discussion. And we begin with ACIP members and ex officios. And at this point, I want to acknowledge and call first on Dr. Blackburn, who unfortunately I had to cut off previously, but she now has the floor.
Okay, thanks. A couple of questions, and I'll just ask them all. Do we have a risk rate for a low-risk baby? I did see in the presentation materials perinatal transmission was 0.5%, but was that overall? Do we have a rate for low-risk babies? Do we have a rate for false negative screenings? And then do we have any insight into the safety profile difference between administering at birth versus later or a delayed dose, or any difference in rate of adverse events by age of dose? I know a lot of the studies that we've seen are all shorter term, 3 days for the Linder and Andre study, 29 days for Erickson, and we do have some other safety means to gather that information, VAERS, et cetera. I did note that most of the symptoms the symptoms have to be reported by parents. And do the parents know what to look for? And are we talking to parents about what that might look like?
Okay, so I'm confused. Can you walk me through, what was question number one and who should we direct that to?
Maybe this would be for Dr. Nevson or Pebsworth. Do we have a rate of risk for a low-risk baby?
What is the risk?
If I understood correctly, I think that you ask, are there risk factors for a woman to test positive or to have infection while she's pregnant, right? Is that kind of the underlying question?
No. More, I guess my question is more if the mother is negative and there is a decision to delay, what would that risk be for a low-risk baby?
So are you asking about horizontal transmission? Like we know that from the testimony from Dr. Pebsworth's committee, working group, we know that risk of horizontal transmission is social context dependent. Is that true, Dr. Pebsworth?
Yes.
Mic on. So it's variable. Do we have any numbers, Dr. Pebsworth, around the horizontal transmission risk? And if you're not aware of them, I next need to call on the CDC subject matter experts. Over.
No, I believe that those data were not available. It's a very rare occurrence in the U.S. You're talking about the hepatitis B negative mothers, children's. There is increased risk in certain situations, certain ethnic groups, and I think there are, risk with household contacts of sorts that not necessarily the mother. But that was finding data and case studies to support the concern was difficult.
So let's toss that question to our subject matter expert panel at the CDC. What data can you cite for us regarding horizontal transmission risk in the United States in the current time frame?
This is Dr. Langer from the Hepatitis Center. Thank you very much for the question.
I think the challenge you run into is how are you defining a low-risk baby? And that probably gets into a little bit of what Dr. Pezworth was mentioning about social context. But I don't know that there is any way at the time that the child is born to categorize them as low risk or medium risk or high risk, other than knowing if you know the mother's test result. To the best of my knowledge, we don't have any recent data with regard to exactly how frequently horizontal transmission happens, but we do certainly have historical data that demonstrates that horizontal transmission has happened in the United States. And one thing I just want to sort of encourage everybody to be cautious about is, if you look at contemporary data, you're looking at data in the context of a high amount of birth dose vaccination coverage. So looking at recent data and saying, well, there's not very much horizontal transmission doesn't mean that it can't happen. It means that the vaccine is preventing it. So you have to look at data from prior to 1991 to see how common it was at the time before we introduced the universal birth dose vaccine. And we do have publications and individual studies and analyses that have looked at that, but we don't necessarily have like a population level surveillance result to answer that question.
So, Roger that. My understanding from practicing pediatricians is that it's expected that the history taken by the primary care physician would identify the higher risk social context. I see Dr. Griffin concurring with that. So with that discussion.
Can I respond to? Yeah, so I think that we tend to sometimes confuse when we talk about this risk between our beliefs and our assumptions and what data do we really have. And I think that even today, as we mentioned already, there are many countries in which the birth dose does not exist. Some of these countries, like Canada, has immigration from Asian countries like ourselves. I think in Europe you have immigration from other countries that could be also with the high prevalence of hepatitis B. And even when we look on earlier data from the US, there was never a rigorous quantification at the population level that this is a real phenomena that is happening beyond anecdotal stories. And I think that these are the facts. Now, you know, at this point, you can have two hypotheses to explain these facts. Either we were completely negligent and we never bothered to document these things, or that this is not a truly common scenario in most settings. And I think that it's much more plausible that the latter is the explanation. And, you know, in the absence of data, what we often do in order to actually create kind of a sense of urgency, we rely on models. And some of the models that we currently rely to justify this phenomena are models that are not even able to explain the observed data, which is maybe the most minimal thing that you want to require from a model, unless you want to stay in what you created in your imagination. So when I look on the totality of the evidence, the very anecdotal, at best, anecdotal and very, very sparse documentation of even single cases, right? Other countries that don't have the universal birth dose and don't seem to have this kind of problem more or less than what we have here in the US. But also the slides that we saw from Dr. Nevison earlier, where you basically look on the population level incidence rates, and you see where did the major decrease happen. Most of the decrease happened in the older ages, 20 and above, not among children, and it happens with populations that were not subject to the universal population dose. So I have to say that I find it very hard to convince myself that there is a true evidence that this is more of a very, very low risk, that, you know, freak accidents can happen, these scenarios can happen. In some settings, maybe it's more likely to happen, slightly more likely. But I think that to make the argument that this is a real scenario is more of a speculation rather than something that is being supported by data at the moment.
Okay, so
Robert, can I make a comment to about Dr. Blackburn's question? You know, that is in terms of detecting mothers based on their history as to whether or not they might be hepatitis B surface antigen positive or a chronic carrier. It's very unlikely that people will be adequately identified. And we learned that with the HIV story. You could ask a patient if they might have HIV, and they would say no. But when they were tested, we found out that was indeed not the case.
Cody, I think you didn't understand the question. As I understood her question, it was about horizontal transmission risk when they're not from mom, but rather from the broader social context, family members. My understanding from what I have learned from the working group is that practicing pediatricians in high-risk communities, such as economically disadvantaged Asian immigrant populations that may be clustered in certain regions, is that their normal practice is to elicit a history around the issue of whether or not there is risk to newborn of horizontal transmission from other social contexts other than mom. Did I understand that correctly in your question? Yes. Okay, so Cody, has that clarified your query?
Yeah, I thought I thought the question was if a mother is inadvertently classified as hepatitis B surface antigen positive, and the child does not get identified, can the vaccine be administered later? And I was going to ask Dr. Langer, after 1 month of age, the vaccine probably has very little impact on transmission to the baby. Is that correct?
Yes, that's correct. The vaccine efficacy as post-exposure prophylaxis rapidly drops off by hours. That's why the current recommendation says for a positive, for a baby that's born to a mother who's positive or a mother who's unknown, and that's actually something that we wanted to ask about, why unknown in the new vote language has been separated from positive, that baby should be vaccinated within 12 hours of birth. And for a known negative mother, then we allow for, okay, you can wait till 24 hours of birth. So literally with every hour that goes by, the likelihood that you will successfully prevent the infection decreases.
Roger,
And certainly waiting to 30 days would be a definite disadvantage for the baby.
But Cody, we already established that there's consensus on that. And in answer to the query, why vote 2, the answer is because there are members of the committee that were not comfortable having the topic in vote 2 incorporated within vote 1. And so it was broken out so that there's an opportunity for the membership to determine whether or not they are aligned with both clauses or just one of those two clauses. Have I answered your question, sir?
I guess so. I'm still not entirely clear what the question's going to be, Robert, but
right.
Yeah.
But I gently request, in the interest of time, that we proceed to exactly that topic of the language associated with these questions, whether or not it requires amendment or is merits proceeding to vote.
Just before that, I want to make an important point. And that is that you have said that we have reached consensus, and that is incorrect. The work group reached consensus on some of these points, And the ACIP itself as a whole body has not reached consensus. That is why we're debating this, and
I
that
think
is
that's
why we're having a
self-evident.
vote.
I think that's self-evident in the fact
No,
that we're
you
now
said-
in
you said-
discussion.
No, it is the work group that has reached consensus.
We are,
It is not the ACIP that has
we
reached
absolutely
consensus.
have not reached consense.
You have said we have reached consensus.
Then I either misspoke or you misheard. I apologize.
Yes, you misspoke.
Then I apologize for my limitations in communication. Regardless.
I appreciate that.
Yeah, you did say it, Robert.
Okay, then duly noted, and I accept responsibility for my misspeaking and overgeneralization by using the term "we" when I was referring to, or hopefully intending to refer to the subgroup or the working group. Regardless, before you now in this slide is a language for consideration for vote. And right now, I suggest that we focus on whether or not there are motions to amend that language. That's separate from whether or not there's a motion to approve it. And those motions to amend, I believe, must be restricted to ACIP members. Can you confirm? Yes, so I have that confirmation from Mina. So open for discussion right now, prerogative of the chair, is whether or not there is a motion to amend this language.
I have a question, because I there's something different up there on my paper versus someone mentioned, and I didn't catch whose voice it was, about mothers of unknown status. That is not it. All this language does is if you're hepatitis B positive, vaccinate. If you're hepatitis B unknown, established, then this is the language. I don't see anything about, I hope I said that right. I don't see anything about unknown status moms. Am I correct?
That language is in vote number 2.
Okay. I just wanted to.
Hence the confusion. I apologize. I'm sure this is my fault also. Up for discussion is language for vote number 1.
So I'd like to make a
Can
motion.
you read it, Robert?
Yeah, and Dr. Pollack is asking to
I'd
speak.
like to make a motion to amend vote number 1.
Okay, and you should describe the nature of that proposed amendment so that we can get a second.
Okay, so in reading vote number 1, sentence 3 actually is redundant. I think that should be struck because you've already said what you have to say in sentence 2. Sentence 5 is a problem because it's not based on any data that I've seen presented today or read in the literature why we are recommending or providing guidance to our pediatricians and others who administer this dose. Why is it?
Understood. So is there a motion?
Yes. So the motion would be to strike sentence 3 and to strike sentence 5.
Okay, so sentence 3 would begin with the word parents should consult. Sure. And sentence 5 would begin with the words for those not receiving. Is that
Correct.
true?
Correct.
Okay, so we have a motion to strike those 2 sentences. Do we have a second? I'm respecting that all members, including our virtual members, are seeking an opportunity to read this and consider whether to second. I'm not hearing a second.
Well, if you have a second, then we can debate it. If you have no second, then you have to drop it.
That's kind of what I'm saying. So I have not heard a second. I thank you, Dr. Pollack, for the motion. Do we have other motions for amendment of vote number 1?
Robert, it's very,
I apologize that it's taken me a while to thoroughly read this question for vote number one.
I'm glad you're doing it. Please take your time and ensure that you have been able to process the language.
Yeah, this is Cody. I'm having a hard time too. I need to, if you could put it up once again, and maybe Dr. Pollack, how would you like to see it read?
Shall I respond to that, Mr. Chair? Sentence 3, in essence, is redundant because you've got what you need to say in sentence 2. So I'm not sure why we've included sentence 3. Sentence 5, I believe, unfairly, first of all, there's no data to support this 2-month of age suggestion. No one has presented any data as to why 1 month, 2 months, 3 months, or 4 months is a preferred time to administer the first dose. So that if we're here as a science-based committee, there is no data to support this 2-month recommendation. Secondly, if you go ahead and hamstring our colleagues in pediatrics and elsewhere to this 2-month time frame, you're providing what may be a guideline, if it's adopted by HHS, which can then be used by plaintiff attorneys if, in fact, pediatricians and others who administer this dose don't provide it as described in this sentence number 5. So those are the reasons why I suggested these friendly amendments to strike sentence 3 and to strike sentence 5, and I was looking for a second.
Yes, and in sentence 4, I mean, that's true for every vaccine. I'm not sure it needs to be stated here.
Are you referring to the sentence, parents and healthcare providers should consider vaccine risks, benefits risks, and infection risks?
Yes.
Well, that's already said in sentence 2. It's also redundant.
So it's, perhaps this was written by the Department of Redundancy Department. It does indeed say this 3 times. The only differentiation is whether to begin the HBV series rather than just the birth dose. I concur with that, and I concur that I concur with your suggestion to eliminate the 5th sentence as there is no data.
So let me state the motion again for the chair. The chair is looking for a motion and a second. So the motion is to strike sentence 3 and to strike sentence 5, and we're looking for a second. Is there a second to the motion? Dr. Hibbelin, just say yes, and then we can discuss.
No.
I mean, there are several statements that need to, I mean, no, I agree with you in deleting those, but there are other statements that should be deleted also. So, I mean, it would be much easier if we could have a hard copy of this and think about it a little bit. If we could defer this vote, Robert, I don't know if that's an option.
It is, right now, it is open discussion. If you want to make a motion that we defer the vote, that's your right to do so.
Okay, there is a motion on the floor. Does that have to be acted on first?
It does.
What's the motion on the floor?
Yours.
Okay, it needs a second.
Okay, so I don't hear a second. This is a second round of seeking a second. And I'm trying to just facilitate this. Dr. Meissner, so the discussion is now open for additional motions.
Okay, thank you. I would like to make a motion that we have an opportunity to look at a hard copy of the votes and hopefully defer until tomorrow if that's possible.
Okay, make it a little more affirmative. What is it you propose, Dr. Meissner?
I am proposing that we defer voting on question 1 and question 2, and if there is I'm still not sure, is there a question 3?
There is.
Or, and 4?
No,
I would like
just
to
3.
see, Yep, I would like to see all questions under consideration and have the opportunity to think a little bit more about the wording.
Okay, can I rephrase that, sir? See if you concur. A motion has been made by Dr. Meissner to defer voting on all 3 until tomorrow's session. Have I accurately captured your motion?
Yes, you have. Thank you.
Thank you, sir. Do we have a second on that motion? I second. Okay, that
I
second.
that motion. This is Dr. Hibbelin. I second that motion.
So we have seconds from both Dr. Levy and from yourself. Shall we, then we proceed to discussion. Discussion is now open about whether we shall defer voting until tomorrow morning. I'm going to begin that discussion by noting that our chairperson is about to jump on a plane to go to Asia and would not be available, I believe, for voting tomorrow. But that's just a FYI. Do we have other discussion concerning the proposed amendment to our agenda? Oh, and I noticed that Dr. Hoag is asking to comment. Please do.
Yes, so this is actually regarding adding language about the hepatitis B immunoglobulin in both votes 1 and 2. I actually think that that's unnecessary, and looking at vote 2, it might create a problem just because there's actually different, if I'm understanding this correctly, and now I'm not a pediatrician, and I don't know if Dr. Meissner would want to weigh in on this, but my understanding is that the recommendations differ in terms of giving the immune globulin depending on the weight of the baby if the hepatitis B surface antigen test is not done or the status is not known in the mother, and waiting until you get that information.
Got it. So can you park that for just now,
Yeah.
if you don't mind, because we have a motion on the floor, a live motion, and it's been seconded. So right now the discussion has to do with deferring the vote until tomorrow morning.
Got it. I was just adding
good.
a little additional information in case that
I'm
assisted with the
I'm
decision
grateful,
about
but
the
I'm
vote.
trying to,
Sorry.
I'm trying to herd the cats here. So,
Thanks, Robert.
Do we have
Might I
additional
propose
discussion?
that you- Might I propose that you eliminate the term tomorrow morning and just say tomorrow?
Okay, that can't happen. So,
Okay.
just structurally. And that's, so Cody, I had attempted to capture Cody's motion, which has been twice seconded. Up for discussion is further points about the utility and appropriateness of the motion in terms of our agenda. So are there further discussions regarding that, or shall we proceed to vote? Okay, I'm not sure about Robert's rules here, but I suggest we proceed to vote. So I'm going to call the vote for the motion, which if I can, Cody, please correct me if I get it wrong. The motion at hand is to delay all 3 votes until presumably early tomorrow, but any votes I've just noting have to occur after the public comments. That's just the rules. So I'm going to call the vote on the motion to delay, beginning with Dr. Pollack. And remember that we need to say whether or not you have a COI.
Vote yes, no COI.
Stein.
No conflict of interest, vote yes.
So that's yes, yes. Dr. Levy?
No conflict of interest, yes.
Dr. Pebsworth?
No conflict of interest, no.
Dr. Malone, no COI, and no. Dr. Griffin?
No conflict of interest, yes.
Dr. Blackburn?
No conflict, yes.
Dr. Pagano?
James Pagano, no conflicts, no.
Dr. Meissner?
Meissner, no conflicts, yes.
Milhound? Dr. Milhound, are you available? I think he's maybe boarding the airplane. Dr. Hiblin?
This is Dr. Hiblin, no conflicts of interest, yes to delay the vote.
3, 4, 5, 6. So that's 6-3. Therefore, the motion passes. Do you concur? Okay, so the motion has been made and passed that the vote shall be delayed until it can be rescheduled tomorrow morning to provide adequate time for members to review the vote language. So with that, moving on to the next.
And may I request that we get that vote language sent to us, please? For all three votes.
I concur that is a necessity, and I believe it's in progress from our liaison to the from the CDC, ergo Mina. So then, proceeding with the schedule for today, we now have eliminated the line item public comments, which was scheduled for 2, and we've eliminated the line item for today, which was votes, scheduled for 2:30. The line item coverage implications, I believe, I asked Dr. Peacock and Dr. Johnson, I believe coverage implications has, that both of those are going to have to be deferred until after there's any amendments. Do you concur?
So with regard to my afternoon presentation for coverage implications, it was not specific to the vote, but rather how it functions with ACIP recommendations at large. So I defer to the chair.
Roger, so I'm just trying to figure out what our schedule is now and adapt to the changing conditions. My sense is that we now reinitiate open discussions on the topic areas with the ACIP members and then move to discussions with the liaisons. We had commentary from Dr. Blackburn. Is there additional discussions from discussion items from ACIP members that we should hear from now? Let's see, I see Dr. I'm trying to order the things here. I see Dr. Griffin, Dr. Stein, and Dr. Levy. Who wishes to proceed? Stein.
Yeah, I'll go ahead next because one of the other questions that I think Dr. Blackburn asked was about the false negative rate of the hepatitis B test for pregnant mothers. And I don't know if someone at CDC has, or any of the other experts has that data, because I was able to find it somewhat, in a paper in JAMA showing that the false negative rate's about 2%. Okay. But it's not I guess it's if there's a question there, could someone confirm that? Because I'm just trying to search quickly and find a reputable reference, which is challenging sometimes. But this one, this comes from a U.S. Preventative Services Task Force paper, and so it sounds good. But is that correct? Is the 2% false negative rate, so a 98% specificity, is that correct?
My sense is that the question is directed to the CDC experts regarding specificity of commonly available hepatitis B serology testing. Is that true? Yes. Our colleagues at CDC, can you opine on that?
Yeah, absolutely. This is Adam Langer, again from the Hepatitis Center. So I don't have the exact numbers in front of me, but it is a very low false negative rate. 2% certainly seems reasonable. I think the key thing to keep in mind is that the areas where the safety net would come in handy are cumulative. So if you have 2% of your negative results are incorrect, then however many cases that is, those are babies that would have benefited from getting the birth dose as a safety net measure. And then you have the babies that would be exposed through horizontal transmission in the community or in the household. And when you add all those things up, the number of babies that are actually at risk is greater than you would think.
Not sure how to interpret that. So I think I heard the answer, a soft response is 98% appears to be a reasonable target in answer to your question. Do you have further?
I have a separate comment, and I will be quick. One of the pharmaceutical company, the manufacturer liaisons made a good point about informed consent. And I don't see how a universal policy is informed consent. And I will, I'll speak on behalf of mothers who have spoken to me to say that it was violated for them. And yes, I think in September, that discussion was had, and like, no, that shouldn't happen, but it does. And so I just want to throw that out there, that I think this new language, whatever ends up becoming, does point more to informed consent compared to the universal policy. At least that's my belief.
Okay, who wants to go next? I think Griffin and Levy were the two. Evelyn?
If I may, because I can speak to what Dr. Stein is talking about with respect to informed consent. So birth dose is expected to be given between 12 and 24 hours after birth. And often how logistically this ends up happening is woman comes to labor and delivery, is in the throes of contractions and pain, is given a stack of papers to sign. And this may ideally happen where informed consent occurs in the prenatal visits before, but often it is not discussed. It's, I'm speaking very loosely here, seen as the purview of pediatricians to discuss hepatitis B risks, et cetera. So there is an opportunity here to discuss hepatitis B. We do have guidance, of course, to test for hepatitis B in prenatal care, but often what ends up happening is a woman comes into labor and delivery, she is signing papers at the moment, and often whether she has had informed consent or not, signed consents or not, the birth dose is given in rapid succession of a lot of events right after delivery. A lot has to get accomplished within the first few hours after birth. And so I have spoken with many parents, they're just unaware. I'm aware of this, so I speak with my patients. So I likewise was blindsided that when I see other people's patients coming in and now serving as a physician that works unassigned cases for other physicians, et cetera, patients are unaware that their babies are getting a lot of different interventions in the first few hours of life. There's other interventions other than hepatitis B. And often, and I will challenge the media, I'll challenge the public, to ask themselves, do you know what your baby got within the first few hours of delivery? And most people are shocked to hear what happened. They just say, well, I trust. The baby gets rolled off, and they're surprised that there's been, an intervention that has been an injection for their baby. Okay, next is also concerns that, so this is universal dose. So the next thing is we have sets of parents who want to opt out, that have explicitly said, I do not want this, but because it's universal, then unfortunately there's misses there as well, where parents' wishes are not seen, and babies end up getting vaccinated against parents' wishes. So parental rights are violated. So yes, more informed consent is needed. I think that's perhaps why there is redundancy in this language, because that is an answer to these parents. The public is not stupid. They want to be involved. Parents want to be involved in the care and raising of their children. So this is in response to that ask, to our stakeholders to which we are beholden. So perhaps that's why it may look like it's redundant, but it's really kind of, forcing the point that we are missing this. This is a gap between the handoff of obstetricians to pediatricians with respect to this counseling. So we have opportunities. We have opportunities to test more during pregnancy, test at the time of arriving for delivery, for counseling the patients during pregnancy to say in advance, this is what you'll expect, for your baby to receive. Perhaps with a pediatrician you don't even know in the first few hours of life. That aside, I wanted to mention something about grade. This universal recommendation was made without grade. This was pre-grade recommendations. But in looking at September's meeting, the safety studies that were reviewed, presumably in the context of grade, whether or not it was, grade has domains to which you use to move the evidence up or down in your assessment, and you should downgrade your level of evidence for your studies if there is conflict of interest. You should also downgrade if there is no comparator group. Those studies that we were presented on September, none of them had comparator groups. And I understand it is unethical to have a randomized controlled trial that has a placebo as your comparator, but that doesn't mean we can't mention that in grade assessment and say it is what it is. We have to disclose the fact that there's no comparator group and downgrade the level of evidence, and secondarily disclose that each one of those studies had significant conflicts of interest. There were huge grants that were a lot of, quite frankly, confirmation bias in those studies. So this conflates the whole problem of safety studies. We have, smaller studies that we don't have perhaps the strength in numbers and statistical significance in observational studies. So what ends up happening is after decades of this program, you are stuck in a crux where you cannot perform a randomized controlled trial because of the supposed efficacy of this program, but no one's performing any other studies. So we have to push forward for safety in the sense of we are putting babies, millions of babies that are born to hepatitis negative B mothers that are low risk, and we are charging those babies with this program, the safety net, and expecting them to save us out of this problem when you see that it was 60-year-olds that are coming up with chronic hepatitis that was presented to us. And we have another issue that elephant in the room that I'll mention is immigration. We have had years of illegal immigration, undocumented people coming from higher endemicity countries. And I say this as an immigrant. My parents defected communist Poland, immigrated to Canada, second immigration to the United States. I've been through the legal immigration process. And even that is very voluntary in terms of documenting your hepatitis B status, in terms of being tested for it, in terms of even if you want to document it, no one's asking if you are hepatitis B positive or negative. I hope those programs are better now, but even in the CDC language, which I have here, is very voluntary, this program. So that is another concern. So we have other problems that adults need to solve with our resources there, rather than asking babies to solve this problem for us.
Thank you. Dr. Levy.
Thanks. So a few things. So first, just to relate to the experience, I had 4 out of my 6 babies born here in the U.S. Neither me or my spouse were ever discussed whether this vaccine should be given to our kids. I can personally testify that I don't think informed consent doesn't happen, at least in some frequency that is quite significant. I personally decided to take this vaccine, the Hep B vaccine, as an adult when I considered that I'm supposed to go to countries where the risk is higher and that I may end up in healthcare facilities that I'm not sure their quality. So it was obvious to me that I need to take it. But I think, and I know that we have maybe some lack of clarity about the specific language, but I want to step back from the specific choice of word and really talk about some of the fundamental issues that I think are in conflict here. I think we heard some narrative or some assertion that risk-based policies are public health policies that are risk-based are usually failing, and we need to go for these uniform statements that we need to eradicate a disease, that we need to vaccinate everybody as a safety net. I think that the data actually suggests quite the opposite. And specifically, I think it suggests the opposite in the context of Hep B. And again, I want to go back to the second slide of Dr. Nevison's presentation that really shows the temporal incidence rates of acute hepatitis B cases in the U.S. What you see from that slide, and I don't think it's much debatable, is you see that once you started to address the high-risk populations, the populations that are most active in spreading the disease and are most active in actually experiencing the serious outcomes, you see rapid decrease well before the uniform dose birth that was initially instituted in 1999, but was finalized actually in 2005. What you also see that after that policy was in place, the decrease is not happening among the babies that were subject to that policy. The decrease is happening in the older ages. These are people that were not vaccinated at birth. In fact, when these kids, if you look on these kids that were vaccinated in 1991 and beyond, when they become 15, 2005 and then 2008, you actually see a plateau in the trends of the cases. So I think when you look on that data, there is a very compelling evidence that actually what works are risk-based policies that are addressing a very important public health problem in specific populations, which is in this case the babies that are born to Hep B positive moms, and all of these adult populations that are at high risk. I don't think that we have the narrative that we have a very successful policy that we should not touch. I don't think it's being supported by data. And more so, the narrative that we have a very well-thought policy, a vaccination policy that are based on ETR and grade, and now we are coming up with some ad hoc idea to undo them, is also doesn't stand the factual reality. The factual reality is that these were approved based on outrageous criteria. And specifically when you think about the safety, it's outrageous criteria. As a father and as a scientist, I don't know how we have the courage based on such slim evidence, to come to parents and tell them that that's okay to give to your zero-day baby, especially when the risk is so low. I honestly don't understand where the courage is. Where does this courage come from? And the question is, if you have a safety culture, is not if there is evidence of harm, but is whether you know you're quite sure that there is no harm. And that's a fundamentally different question that we are not asking in the context of vaccines, and specifically in the context of that vaccine. Now, this is even worse, and I don't think we mentioned this so far, but this particular vaccine is a fundamental part of many of the mandates that we currently have in this country. And these mandates can prevent kids from going to kindergarten, and sometimes, I heard personally stories, can prevent kids from getting care in a practice just because they didn't get the Hep B vaccine. So to say that we are giving options and we are having an informed consent is a far-reaching statement that I don't think stands the factual situation. What we're trying to do here is to go back to basic good public health policy that is based on risk, and that is based on informed consent and informed individual decision-making, when parents can think about the assessment of the risk and the benefits and make a decision. And every one of us has a different tolerance to risk. Like if I put myself as a father, I was in that situation 6 times. Some parents will be very anxious, even at the age of 3 or 4 or 5 or 6 months, that their baby might be at risk, and they would feel that they want to vaccinate them. That's okay. That's the right to do that. Some other parents can feel, and I don't think that they're going to be entirely wrong, that you can wait until age of 12 or maybe until they're adult. I think that trying to present an approach like this as something outrageous, immoral, reckless, is absolutely not consistent with personalized medicine, is absolutely not consistent with giving empowerment to patients and their physicians to make decisions. And I don't think that this criticism is very valid. And I'm actually proud that this group of people is actually taking a very different approach. The last thing that I want to say is that when you think about the safety net idea, that's another what I would perceive a highly problematic idea in the sense that we basically legitimize bad healthcare practices. And that doesn't say that if we recommend that all babies that are not born to moms that were tested positive, that those babies should not get a birth dose. It does not mean that if there is a unique situation when there is some uncertainty about the baby and the physician feels that that's the best, for the best benefit of the baby to take the dose at that time, that this policy is going to exclude that, because that's why we have individual decision making, and that's why we always leave to the physicians in the field the judgment call, together in consultation with their patients, to make the right decision for that patient. So I think some of the questions that we heard earlier this morning were not really questions, but were more emotional statements that I appreciate the emotions here. But when you actually clean it up and you look on the facts, and when you look on other countries, I don't think that you can argue that this is not at least a legitimate discussion. And in fact, I think that most countries accept approaches that are much more similar to what I just described than to what we currently have in the U.S.
Thank you, Dr. Levy. So as chair, I want to make the announcement that we will now transition from the discussion of the ACIP members and ex officios to a discussion among the liaisons, and I will call the roll on those that have been queued up. And then that'll be followed. I've just been informed by CDC management that we've had adequate discussion to go ahead and proceed with, at 150, perspectives from people with lived experiences. So the liaisons, please be concise, because I'm going to have to cut you off at 150 no matter what. That'll be followed at 2 p.m. with public comments. So we will proceed with public comments today, and they will begin at 2 p.m. With that stated, I call Masur Mahmoudi as the first a member of our liaisons counselors and ask for him to briefly, so that he doesn't run into all your other time, share with us your perspective. Dr. Mahmoudi.
Hello, I'm Dr. Mahmoudi, American Osteopathic Association. My question is, if this vote passes by the committee, what body or organization, is it ACIP or work group or others, to go back and, later on, to see the outcome of this, the harm and benefit, and coming back with some number? And are we revisiting this if we, let's say, we vote and there is no, not vaccinating the infants? So coming back with the data.
I understand your question. Dr. Pebsworth, you have informed us about the ACIP charter requiring periodic re-review of policy. I don't believe that has a fixed timeline, but it is absolutely a policy that ACIP is to revisit policies and revise as necessary. Is that true?
Yes.
So in answer to your question, we don't have a fixed timeline, but we do have a policy in the charter that this shall be done. That's the best I can offer you, Dr. Moody.
Thank you. I appreciate it. Thank you.
I'm notified here that we need to hear from the Vaccines for Children colleagues prior to the public comments. So let's just knock that off. VFC, are you here, and do you have comments that you wish to share? Okay, so when you come back, just give me a heads up, and we'll continue with the comments from our liaisons. Next person on the list is Dr. Paulson, Grant Paulson.
Hi, thank you. Sorry, I had my hand up and down during the day. This is Grant Paulson. I represent the Pediatric Infectious Diseases Society, so a group that really spends all of our time focusing on treating and preventing infections solely in children. As Dr. Meisner said earlier, there's a lot to unpack, and so I'm going to try to keep this focused. I guess my questions for the work group, and I think Dr. Levy raised this earlier, is as the scientific liaison from one of the societies, our question is really why is there pressure today to change something that has been working? Is this due, as noted on the earlier work group side, due to safety concerns that may or may not be true, that may be more theoretical than real? With that said, the language itself is been well documented, not available to any of our groups yet, so it makes it hard to discuss too much. And a moment was made earlier about ad hoc statements. This feels like an ad hoc decision to put these votes together, with vote number 2 being inserted midway through. So I guess I'm just going to ask, why does it feel like this is necessary at this time? My other comments I will save for a later time, because I know we're tabling the vote for today. But big picture, it is not a perfect world. Vaccines do have side effects. Universal screening of pregnant women, just as Dr. Griffin said, has fallen off. Our goal is to provide the best care for all pediatric patients, to prevent them from developing this lifelong infection. And I will stop there and cede my time.
Bless your heart. Thank you, Dr. Paulson. I'm not sure who is best suited to answer your question. I know that the why question was explicitly addressed in earlier slide decks. Dr. Pebsworth, do you want to take a shot at answering his why?
Well, I think it was the periodic review time, plus we were aware that there was pressure coming from stakeholder groups wanting the policy to be revisited.
That's the best answer we have at this point. Wish we had. I guess that's just the way things are in an imperfect world, as you mentioned. Dr. Hutchins, do you have succinct comments for us?
Certainly. I do want to go back to a presentation earlier today when Nevison, I think it was Dr. Nevison, spoke about surveillance data versus the CDC modeling without a rationale for the need for modeling. And I think that's very important. Our surveillance system nationally, everyone knows, there's a lot of underdiagnosis and underreporting, and there's a need for the modeling that helps estimate what the actual impact of acute and chronic hepatitis is in the US. And I was just wondering, were those adjustments made in the CDC modeling so that we have a better idea of the actual impact in the population?
That was a statement. I got distracted and I missed the question.
So the question is, with the CDC modeling that was referred to, what was the rationale for the modeling? Were they adjusting for the underdiagnosis, underreporting that is well known in our surveillance systems?
I got
because
it.
They're not perfect systems.
Thank you for refreshing my distraction. So that seems to be a question for the CDC experts. On the table is the question of why were the modeling versus direct surveillance data initiated? Over.
Dr. Malone, would you like me to take that?
If you feel, go for it.
Yeah. So thank you very much for the question. It's a great question, and the reason why the modeling was done is exactly why the individual with the question asked, which is that we knew that the number of cases that were being reported was grossly underreported. First of all, just to make sure we're all on the same page, we're talking about acute hepatitis A. That's what what these numbers are for and what the model adjusts for. So hepatitis B. The acute hepatitis B is not always diagnosed. Sometimes it's a relatively mild illness. The patient does not seek care. Sometimes they do seek care. They're treated empirically, but they don't necessarily have the hepatitis B diagnosis made. Sometimes the diagnosis is made, but the provider, for whatever reason, forgets to report it to the health department. These are all steps in a very complex public health surveillance process where things can fall through the cracks. And so we've always known that the absolute number of cases that we get reported to us is not the true number. And in fact, most CDC surveillance programs, with a handful of exceptions, have some kind of modeling process that they go through where they look at the actual reported number of cases, and then they use other data to extrapolate that into a true burden estimate. And the reason why it's important to do that is exactly the discussion that we've been having here, where basically there's a misunderstanding and a misinterpretation and pointing to the raw surveillance numbers and saying there's very little hepatitis B burden, when in fact we know that there's considerable hepatitis B burden if you're looking at the correct set of numbers.
Can I interject? Am I hearing that part of a contributing factor to this discrepancy in data may be this fundamental bugaboo that we keep running into, which is the difference between incidence data and case data?
So this is unfortunately a situation where every disease program tends to use these terms a little bit differently. So incidence simply means that it is a recorded diagnosis of a newly reported case. So let's take HIV as an example. You have to be very careful with HIV to distinguish between incidence, it's a new diagnosis, a new reported diagnosis, versus prevalence, which is in individuals who were previously diagnosed and obviously they still have HIV because it's incurable. And so they're part of that prevalence.
I apologize. By incidence, I'm referring to if one was to survey a large population by, say, PCR, you would identify N number of individuals that had experienced an infection event, and cases being generally those that present to the medical system. Over?
Yes. So the way we think of it is we think of it as the difference between reported and actual. So the example you gave, if you actually did a population level survey, and we do this through the NHANES survey, you can get a prevalence number from that. We do that for chronic hepatitis B. In order to look at incidence, we have to start with the data that we can get, which is the reported data, and then we look at information that we have about what the degree of underreporting and underdiagnosis is, and we adjust the number upward.
So I'm sorry, I've taken you way down a rabbit hole. What I was trying to get to is that my sense is that part of the divergence between the case data and the modeled data may relate to these challenges in actually acquiring data and the difference between those that involve actual cases clinically of hepatitis B versus raw incidents of individuals that might be infected but might not develop sufficient symptoms to lead them to medical care. Over?
If I'm following what you're describing correctly, then yes, that would be one of the factors that would fall into the category of undiagnosed cases.
Thank you very much. Now, I'm directed that our Vaccines for Children colleagues are now ready to share information with us, and that it's necessary that I proceed to that before we go to additional liaison discussions. So please proceed.
All right. And I think you're pulling out Georgina's slides first, VFC implementation considerations. Okay, great. All right, I'm Georgina Peacock. I'm the Director for the Immunization Services Division, and just have a couple slides to share with you related to the Vaccines for Children implementation considerations. As a reminder, the Vaccines for Children program is a program that was started in 1994 to ensure that eligible children have access to vaccinations regardless of their parents' or guardians' ability to pay. VFC serves children ages 0 to 18 years who meet at least one of these criteria. So they're Medicaid eligible, uninsured, American Indian or Alaska Native, or uninsured. There have been some conversations about if someone can advance the slide, the remote is not working. There we one more. Okay, thank you. Just a little bit of information related to the Vaccines for Children program and shared clinical decision-making. Coverage under the VFC program is based upon the information included in the VFC resolution, which you're going to hear draft language from Dr. Santoli in a minute, that is then approved by ACIP. If language about shared clinical decision-making is included in the VFC resolution, then shared clinical decision-making is covered by the VFC program, and those vaccines are available for those eligible children that I talked about. So some examples of childhood vaccines with shared clinical decision-making recommendations in VFC currently are the following. So the meningococcal B or Men-B vaccination for adolescents and young adults aged 16 to 23 years, and the COVID-19 vaccine for children aged 6 months and older. And you'll see a link here at the bottom that provides a little bit more information on shared clinical decision-making as it relates to the VFC program and ACIP. And then finally, if we can advance the slide, right now, if we look at the availability of hepatitis B vaccine through the VFC program, it currently, a number of hepatitis B vaccines are currently available on existing VFC contracts and will continue to be available to our VFC providers through jurisdictional immunization programs. Most of those are state immunization programs, as well as some of our other jurisdictions. There's approximately 37,000 providers who are enrolled within the VFC program, and those include providers in different roles, so pediatricians, family physicians, sort of those in outpatient private practice, federally qualified health centers, hospitals, including birthing hospitals, pharmacies, and then public health clinics. So that's just a little bit of information about VFC implementation considerations, and so I'll hand it over to my colleague, Dr. Santoli, to present a VFC resolution update with some draft language. Thanks.
Hello. As they're getting my presentation queued up, I want to explain that. And first of all, thank the committee for their patience with our need to take a break and realign. The goal of the VFC resolution presentation is to really show you a resolution that aligns with the voting language that you are coalescing around. And I know we're still in that process. I know there's more discussion. So what I'm going to show you is, as best I could, aligned with the voting language that I think is now on the table, although I know it's postponed until tomorrow. So this could change, but this is how it would be reflected in a VFC resolution. So in the presentation, anything that is in red font shows you what has been updated, and everything else that's in black font is the way the resolution looks today. So the purpose of the resolution is to update the recommended vaccination schedule and intervals section of the resolution to reflect updated ACIP recommendations about the use of hepatitis B vaccine. The eligible groups are unchanged with this update to the resolution. Oh, that's okay, sorry. So this is the recommended vaccination schedule and intervals. It's made up of a series of tables. This first table is for infants who are born at greater than or equal to 2,000 grams. And you can see along the left, the mothers. Oh, I'm sorry. My apologies. So these, again, to restate, these are the children greater than or equal to 2,000 grams. You'll see along the left, there's the maternal status. The first set of columns are if the schedule is fulfilled with only single antigen vaccines. The second set of columns is if the schedule is fulfilled with a combination of single antigen and combination vaccines. So the only changes in this particular proposed draft of the resolution have to do with the infants whose mother has a status of hepatitis B surface antigen negative. So you can see no changes have been made where the mother's status is positive or unknown. And in the negative, there's the single antigen, the schedule is 2 months, and then 3 to 4 months, and then 6 to 18 months. And then where there is single antigen and combination vaccines, it's 2 months, 4 months, and 6 months. There is a footnote, we're going to look at that later, that talks a little bit about the shared clinical decision-making or individual-based decision-making. Okay. So this is now a table that looks identical, other than the fact that these are for infants who are born at less than 2,000 grams. And so you'll see the same changes have been made under the single antigen schedule and the single antigen and combination schedule for infants who are born to mothers whose status is negative. Next, I want to show you the table notes that go with this. It looked like two tables to you, but it's really one large table. So first, the first footnote is actually adjusted. Only a single antigen hepatitis B vaccine can be given at less than 6 weeks of age. Previously, this said at birth, and so it's been adjusted to reflect the discussions about a later start to vaccination. And then the fifth table note has been added, and this is for children whose mothers have a status of negative. Infants who are born to Hep B surface antigen negative mothers may receive a dose of hepatitis B vaccine before 2 months of age under individual-based decision-making, also referred to as shared clinical decision-making, including consideration of risks such as a household member who is hepatitis B surface antigen positive, or where there is frequent contact with persons who have emigrated from areas where hepatitis B is common. These specific examples were included because of some earlier voting language. If the committee does not want to include those, that's certainly an option, but that's where that came from. And then finally, infants vaccinated before 2 months of age under individual-based decision-making may receive up to 4 doses of hepatitis B vaccine, 1 dose of single antigen vaccine, followed by 3 doses of combination vaccine. I'm going to quickly walk through the rest of the resolution, but we have now covered the changed portions of the resolution. So, there is no change to the schedule for children and adolescents. No change to the table notes for that table. No change to recommendations around interrupted schedules and minimum dosing intervals. No change to the recommendations about revaccination after the full series has been completed. No change to revaccination recommendations. The recommended dosage is unchanged. Contraindications and precautions are unchanged. And then finally, this is a statement about incorporating future publications by reference. That is unchanged. And that concludes a run-through of the VFC resolution. Thank you.
Thank you. Well done, under challenging conditions. So now it's suggested that we give Andrew Johnson of CMS another shot at clarifying the CMS position.
Thank you, Dr. Malone. What I'll do here is I will cover information to show how ACIP recommendations at large, not just specific to hepatitis B, but ACIP recommendations in general apply to Medicaid, the Children's Health Insurance Program, as well as private and employer-sponsored health insurance plans. We could advance. So I'll largely read what you see on the screen. These materials are available in the meeting materials site as well. So with regard to Medicaid and the Children's Health Insurance Program, coverage of vaccines is anchored to the ACIP recommendations and the adult and pediatric vaccine schedules, which is based on those recommendations. State Medicaid and CHIP programs, as I'll refer to them from here on, are required to cover all vaccines recommended by the CDC and ACIP that are included on the adult and pediatric immunization schedules without cost sharing, so without out-of-pocket for the individual, for most beneficiaries, including children and adults. Recommendations included on the pediatric and adult immunization schedules that refer to shared clinical decision-making, much as you've heard with the VFC program, also known as individual-based decision-making in consultation with the healthcare provider, are mandatorily covered in both Medicaid and CHIP. The VFC program, as you've heard, and I'll skip this last bullet as we've just heard their briefing. We can advance. States have flexibility to determine Medicaid and CHIP coverage beyond mandatory coverage anchored to the ACIP and CDC recommendations and the pediatric and adult immunization schedules. Therefore, any recommendation that is not on the pediatric vaccine schedule or any recommendation that narrows the criteria will lead to variable coverage across state Medicaid and CHIP programs. In Medicaid, through EPSDT, or the Early Periodic Screening, Diagnosis, and Treatment requirements, coverage for individuals up to age 21 could include additional vaccinations beyond what is included in the vaccine schedule based on the state's medical necessity criteria. In CHIP, states have the flexibility to choose to cover vaccines beyond, not less, but beyond what is included in the immunization schedule. If states opt to provide expanded vaccine coverage, they will receive federal match from CMS for the full scope of coverage. States may not need approval from CMS to provide coverage beyond the ACIP recommendations, as that level of detail is not required in Medicaid and CHIP state plans. The next slide is just a graphic that shows kind of applicability for reference. We'll skip that slide, but it's available in the meeting materials. And lastly, we'll move to the next slide, which is in reference to non-grandfathered employer-sponsored plans and non-grandfathered group and individual health insurance coverage. They too are required to cover all ACIP recommended vaccines for routine use without cost sharing. This does include the recommended vaccines on the pediatric vaccine schedule. With respect to employer-sponsored and individual health insurance coverage, this is separate from self-insured employer-sponsored plans, also known as ERISA, which are governed by the Department of Labor. Those are not governed by CMS, so this is separate from ERISA, although there is alignment generally there. States may impose benefit mandates. They can include vaccination mandates that are more expansive than the federal requirements. Plans and issuers are required to continue to cover the vaccine in a manner that consistent with the current recommendation for the duration of a plan or policy year before the applicable plan or policy year of the new recommendation, unless doing so would impose a significant safety concern. So that being said, these are the guidelines resulting from the law and regulations for CMS that we look to and apply when we review the vote language that this committee has provided to ensure what the coverage implications are. Happy to take any questions.
So open mic now for questions from ACIP members. Cody, I see you think.
Yes, sir. Thank you. Thanks for both of those presentations. Two questions for Dr. Santoli. Item number one, you had added in red font less than 6 weeks. I didn't catch the number of the slide. It may have been your first slide. But I just worry if that will be misinterpreted that these monovalent vaccines cannot be used after 6 weeks, because certainly that's not the intention, I know.
Oh.
And then number two.
Okay, sorry.
Sorry.
Yeah.
Can we let her answer that one?
Yes.
Let me read the language to you. I don't know that I can quickly get my slide up, but it's very brief. So it says, only a single antigen hepatitis B vaccine, parentheses, Endrix B or Recombavax HB, parentheses, can be given at less than 6 weeks of age.
Yep. My worry is, might that be misinterpreted to think that you can't use them after 6 weeks? And that's not the intention, obviously. So one comment. The second comment is the combination vaccines can be used after 6 weeks of age, and we don't know whether or not they can be used for the initial immunization for hepatitis B. Isn't that correct? So that's going to be another question that we will have to think about. That is, if an infant doesn't get vaccinated until after 6 weeks of age, can that initial hepatitis B vaccine be a combination vaccine, or does it have to be a monovalent B vaccine? And I know we don't have I don't think we have an answer to that, but it will come up.
I would like to actually ask if the hepatitis B SME could speak to that, actually. Adam, are you available?
I'm sorry, Dr. Meisner, would you mind just restating your question?
Sure. Sorry if I didn't state it clearly. If a child does not get a dose of hepatitis B before 6 weeks of age, can the initial hepatitis B immunization for the series of 3 be a combination vaccine?
Yes, I can.
Do we have there are data?
In fact, we saw before. Sorry, this is relative. In fact, I think we saw at the end of the presentation, just before this session, we saw that 30% of the Medicaid babies are not receiving the birth dose. Many of them are getting it up to 2 years, and all of them are being vaccinated. So I think that this is actually being used in practice to a significant number of. I can kind of get the numbers very quickly here.
The question is, does it give an equivalent immune response, Retzef, to the monovalent vaccines?
Cody, I can also answer from the European perspective that there are a number of European countries that give the hexavalent combination vaccine as the initial vaccine between 2 to 3 months. I know for sure that Germany does that. Also Japan. I don't have the comparative data between the immunogenicity, but I know that that is done in practice in a number of European countries. So
Thank you. Thank you. That's helpful.
Tracy Beth, were there other topics since I'm being alerted that you had asked for the floor?
Yeah, I had some information about the sensitivity of the Hep B surface antigen testing. And from what I can find from the products available in the United States and in Europe, the sensitivity is consistently listed as 100%. So I don't think we're missing a lot with the testing.
We're not having, to restate that, we're not having false negatives.
Correct, yeah.
Of any appreciable number.
Exactly, not in practice, yeah.
So we're going to proceed. Thank you very much for that additional information and clarification. And we're going to proceed with the liaisons until 2:20. There's been another adjustment to the schedule. I'm saying this for those that are waiting online. People with lived experiences will speak at 2:20, and public comments will initiate at 2:30. So with that, Naima Joseph, are you there, and can you share your advice and perspective briefly? Okay, Naima, forgive me, I'm going to pass on to Robert Schechter. Robert, are you there?
Yes, thank you. Can you hear me?
Yes, sir.
Yes, as a pediatrician and public health vaccination program official, I wanted to make just a few points. One, echoing CDC, is on the limitations of our surveillance as a explanation for the discrepancy raised earlier between the modeling and the cases reported in surveillance. And I think a number of the challenges in our healthcare system that impede universal screening during pregnancy are also in play. There's a lot of hard work that public health programs and clinicians do to follow up infants potentially at risk. And unfortunately, despite all that hard work, surveillance and ascertainment is incomplete. So we have, the good news is that compared to 20 years ago, in California, we were seeing at least 20 infections in exposed infants a year, and that's down to 0 or 1 a year, 20 years later, under a universal recommendation. The bad news is that it's hard to know what we're missing, despite all this hard work that goes on and the limitations of our healthcare system. It was mentioned the high prevalence of asymptomatic or mildly symptomatic acute hepatitis B in especially in young children. And so I think that also addresses the limitations in trying to pin down horizontal transmission when children are not routinely screened for hepatitis B. I had two questions for CDC experts. I'm noting on the 2018 ACIP recommendations for hepatitis B that, quote, an anti-HBs level of greater than 10 micro IUs per ml is a serologic correlate of protection only when following a documented complete series. So my question for CDC experts is there any evidence for seropositivity as a correlate of protection in an incompletely immunized individual, young or old? And for instance, I can see a young infant who might have received immune globulin being seropositive transiently, but still being vulnerable once the immune globulin wears off. So concerned about the language in vote 2 around serological use of serological testing to perhaps falsely reassure parents of the protection of their kids. My final question is, what surveillance is in place to evaluate the effects of a vote to liberalize or relax or reduce the birth dose? How soon would we know the effects of that? And again, when many children, most young children will have asymptomatic, mildly symptomatic disease, what systems do we have in place to detect the consequences of the vote? Thank you.
Robert, can you restate question 1?
Question 1 is, do the CDC experts have any evidence for seropositivity, 10 micro IUs per ml?
Okay, I thought that was question 2.
Protection.
Got it. Okay, so to restate 2 questions. One is evidence of essentially effectiveness at the 10 unit level with less than 3 doses. And question 2 had to do with delta T on follow-up to detect a significant impact from the new recommendations. Did I get that right?
Yes, thank you.
Thank you, sir. Okay, so please educate us.
All right. Thank you for both of those questions. They're both great questions. With regard to the first one, the use of serology to look at vaccine efficacy has only been studied in the context of a complete vaccination series. We have no data at all to support or refute, for that matter, the use of serology for making a decision as to whether or not to do the next vaccine within that series. That series has been studied in clinical trials and found that it needs to be the full series, and there really is no reason not to give the full series. With regard to your second question, the thing that's really important to keep in mind, and I think this might have been what you were getting at with your question, is the most severe consequences of hepatitis B chronic infection don't show up right away. So it's very much possible that you could have a child that became infected with hepatitis B virus who did not show any symptoms or showed very mild nonspecific symptoms, and then years or even decades later, they develop severe irreversible liver disease, cirrhosis, liver cancer, end up on the transplant list, and probably don't live as long as they otherwise should have. So unfortunately, it's something where I wouldn't be confident that we knew what the impact of a change was for many years.
Robert, can I? So thanks for both the question and the answer. I just want to share a few observations. So I understand that there are some long-term, potential long-term consequences. I just want to kind of maybe highlight the potentially different approach that we apply to the safety versus the benefits. When it comes to the risk from the disease, if we don't see something and we cannot measure it. We are always worried. We model. We think that maybe it's more than what we think. Although, frankly speaking, I think that most of these, especially chronic illness, over 30 years, we should have seen already the impact of the universal dose, which again I don't think we see that. When it comes to safety, for some reason, only the risk from the disease can be long-term. For the risk from the vaccine cannot be long-term, and I find it a logical puzzle, because I think that the whole idea of vaccines is to change, hopefully positively, our immune system for the long run. But if you accept that principle, you have to also assume and consider at least that not all the changes might be positive. And so I just want to highlight the fact that, again, I think it's a good question to ask ourselves. Let's say we didn't have all of these policies in place. There would be new policy to consider. I think if we would look on the current evidence, if this was a new policy, if I listen to the recent FDA declared standard, I don't think that these vaccines would be authorized for the use. We would consider the evidence on safety, potentially efficacy, especially for the Hep B negative moms. We will consider them not passing even a minimal threshold. So respectfully, I would like to kind of to call out the fact that what we are doing here is trying to undo some really, really bad decision processes we had in the past. And we mentioned clinical trials and randomized control experiments. I actually think that in this particular case, when you think about the low risk for babies that are born to Hep B negative moms, you can actually run large clinical trials and long-term clinical trials to understand whether 1, 2, or 3 doses are sufficient, to understand different timings. This is something that there is no ethical reason whatsoever not to run those experiments. And I think that maybe we're not voting on this, but I think this should be a collective call for action for the regulatory agencies across the board to run those experiments, because we want to know the answer, because we want to be able to come to parents with far better information than what we are able to give them today. And I think that hanging into the really bad decision processes that we had in the past is not convincing to parents, or at least to many of them. And it's not convincing to the public. And I think that the recent, again, I'm going to talk about another vaccine, the recent discoveries that we had, that very confident promises about safety of vaccines turn out to not be true, to the extent that children with very, very low risk from SARS-CoV-2 were vaccinated and died. And that was denied, and I think that we really
Mr.
don't want to have many more cases
This
like
was supposed to be liaison time, respectfully. The ACIP members had their chance, and you said this was
I know you want to give
I
know you want to give another speech to tell us how good we are. But
respectfully,
with all due respect,
without
evidence,
just anecdotes.
Thank you, Dr. Goldman.
Liaison time.
Can we? I understand that there's tensions here, but I want to respect. Remember, this is primarily focused on the informing the ACIP committee. So I'm noticing that Dr. Hiblin has patiently awaited a opportunity. Joe, can you be concise, please, because we have 2 minutes until we close comments.
Yes, sir. This is regards to the question of whether we have evidence of efficacy, and I refer to Dr. Pebsworth and Nebison's charts regarding the decrease in illness from 1985 to 1991. Prior to 1991 and universal vaccination, it was attributed to both the increased use of the vaccines and public health measures, but we can compare that as a single variable change. When there's universal vaccination, the rates of cases went from 17,500 to 601. So when we consider universal vaccination as a single variable that changed, we have a decrease between 17,500 in 1991 to 601 in 2025. Thank you.
Interesting analysis. So we have barely time for Dr. Halbritter. Can you, are you there, Dr. Halbritter? Okay, noting Dr. Resnick, Barbara Resnick. Dr. Robinson, Candace Robinson. Dr. Carolyn Ha. Dr. Laura Morris.
Hi, can you hear me?
Yes, ma'am.
Hi, I suspect some of the other liaisons may have lost the ability to speak. I'm representing the American Academy of Family Physicians and a practicing family doc with full scope care, including prenatal care, practicing in a rural area. My concern and that of my colleagues is the shift from recommending, especially to a schedule that does not have any additional evidence to support moving, for example, to not give a dose prior to 2 months of age, and the impact of moving to shared decision making on the clinical implementation in primary care practices such as myself and for pediatricians and family physicians everywhere.
So, Dr. Morris, what would be that impact? Please educate us.
Sure. The recommendation itself and having a blanket recommendation for something that has evidence to support that there is benefit that outweighs the risk for the vast majority of patients, moving to shared clinical decision-making and then the required documentation of that, for example, in my area when the practice changed and the recommendation changed for COVID vaccine, for example, there now are multitudes of messages and prescriptions that are necessary to generate. Pharmacists in my state are tied to ACIP recommendations in such a way that they are required to also document and require prescriptions for many of the places that previously we were able to have standing orders and protocols that vaccinated patients where we know the benefit outweighs the risk for administering vaccines to those groups, for example. So that is one example, the vast amount of time and undoing a program that is successfully preventing chronic illness and serious ramifications and disease in patients, and undoing that and moving it back to something that requires more documentation and more administrative burden when there is not evidence sufficient of harms to undo the program, and there is not evidence to support the language in the votes that was concerning about moving to specific additional timeframes that have not been evidenced either. So taking something that is successfully preventing disease and moving to something with more administrative burden at a program that does not have evidence to support moving to that time interval or what the outcomes of that model would be is concerning.
I follow and very much appreciate your argument. Can you share, I'm sincerely interested in your perspective, I think we all are, as a frontline physician that is tasked with implementing these things. Can you comment on the implications or burden on an individual parent who wishes to have the latitude to make a go, no-go decision on receiving a product under informed consent versus the mandated environment that has been historic? Can you comment on the implications for the parent?
As speaking on behalf of those primary care physicians and on behalf of the parents and families we interact with right now, I provide, to the very best of my ability, informed consent for parents and families right now. So a recommendation that allows us to say, we strongly recommend this vaccine because we think that this is the best way to protect your baby. And a parent who says, I understand, I've been informed, I have a previous child, I've read, I've done my research, I trust your recommendation. And we can move forward with standing order protocols and other things that we know increase vaccine uptake and help protect our patients with the most streamlined and efficient workflow processes is extremely beneficial to the implementation side. When parents have questions and concerns and we provide written material, we provide counseling prior to the offer of the vaccines. I provide counseling for my prenatal patients as well about what to anticipate in the hospital. And as we've seen,
I appreciate what you're saying,
only
but it's
80% of parents actually were receiving that Hep B vaccine at the birth dose. It's not a mandate. It is already possible with the language and the recommendations.
I understand,
the way that we have standing for them to decline.
What I hear is you sharing with me the experience of the parent who endorses current policy. Do you have experience with those parents that are vaccine hesitant for whatever reason, or do not wish to accept the current schedule? Do you have experience with those, and how does this impact on them?
Yes, I absolutely have experience with those parents and those families. And the current recommendation and making a recommended dose at birth does not in any way impede those parents from being able to decline the vaccine at that point, or at any point, or to never vaccinate their child if that is their choice. They have that option with the recommendation the way that it currently stands. And I empathize with parents, and I attempt to answer their concerns and listen to where their concerns are and partner with them. And my recommendation to all my families is that we will absolutely honor your decision-making as a parent and bodily autonomy as patients to do what you wish. But this recommendation allows us to best serve the majority of our patients who do wish to vaccinate and understand that protecting their infant from the get-go means that there is very much less chance of even a low risk but catastrophic illness to happen.
Dr. Morris, I sincerely thank you for sharing your frontline experience and insight into these different examples of different categories of patients. I'm honestly grateful for that. But I'm now in the I'm in real time. I'm being updated about our timeline, and so this I have the opportunity to ask Judith Schley to share with us her point of view. Dr. Schley.
Hey, thank you very much. I've been waiting a long time to talk. So a couple of things I wanted to bring up. Number one is I wanted to bring up to the group a recent study that came out just the other day called the Economic Evaluation of Delaying the Infant Hepatitis B Vaccination Schedule by Eric Hall et al. And it looked at not just the economic implications, but also the number of infections that would occur by delaying the dose from birth to 2 months, being 238 additional doses in children. These are mothers who are hepatitis B surface antigen negative.
Did you just misspeak? Did you mean to say 238 additional cases?
Yes, yes. It's in the paper, and I think it should be looked at before we make a decision about changing the implications for the Hep B dose at birth. The second thing I wanted to bring up was that I think that while I agree with the obstetrician on the ACIP panel about changing clinical practices to have a hepatitis B surface antigen test at the time of delivery, I would say that we should not change the birth dose until we have implemented those clinical changes, because then we're sort of, because that will be delayed, and to change clinical practices take time. And the third thing I wanted to bring up was Dr. Nevison's discussion about risk factors and saying they had been decreased. If you look at current risks associated with syphilis, we have seen increases considerably over the last few years with congenital syphilis going up. So we know that risks are going up precipitously, and that we have to take those into consideration. And the last thing I want to bring up is any child who gets a hepatitis B infection because we change policy is one too many. And we really do need to think about that. I run an immunization program. I represent public health immunization programs throughout the state, the country. And I want us to make sure that we never have any child get hepatitis B infection. Thank you.
Robert, can I?
Yeah, I was waiting for.
Yeah, I just very quickly, three thoughts. First, I'm very glad that you mentioned that paper. I actually read it yesterday, and it's actually good that you mentioned the economics. In fact, I think that it's too bad that we never had an economics analysis of cost-benefit of this vaccine, because I think we would see, in all likelihood, that it's highly, highly non-economic in the sense that if we would take the same resources of millions of doses that we give to babies that are at extremely low risk and instead invest them in better screening, better going after the high-risk population, we're probably going to get much better outcomes overall. I also want to, again, reflect my experience as a parent. And again, I don't want to imply that the physician that we heard talking is part of that. I'm sure she's dedicated, and I've worked very closely with a lot of physicians who are just amazing for their patients. So I have tremendous appreciation to the hard work that they have to do every day, and how critical they are for, to ensure the health of families and children in particular. But unfortunately, I think that even the information that is being communicated to doctors, to medical professionals, and then they communicate that to patients, is not, more often than not, is not based on facts. We basically, since we vaccinate everybody today, or almost everybody, right, we don't really have a control group that we can actually look even retrospectively and trying to understand what are the long-term risks of this vaccine. So we used really outrageous clinical trials. We then decided to go and vaccinate basically every child. And now we are in a position where we tell parents very confidently, and also the doctors, but to medical professionals very confidently, that the vaccine is safe, then there are no problems whatsoever. And I don't think that that's a very, very reliable statement, if I may say.
Can I really quickly say, to your point, in medical school, you are taught this is the pediatric vaccine schedule, and we just memorize it. So you just dropped a truth bomb. There is a cognitive dissonance. I mean, we are given a schedule, and as medical students, you finally make it to medical school, and you do trust that this has been fully vetted to the nth degree. And I myself was shocked to look at, in September, we were presented a safety study from 1993 that had one sentence said, no adverse effects. And you look in the methodology, there was no description on how they had assessed for adverse effects. And these were the studies that were going in to assess safety. Anyway, so to your point, yes, there is a problem, systematic problem going back into our education. I fully believed that this was vetted very well. The safety studies are not that ironclad.
I did want to make a quick comment about the cost-benefit analysis, actually, because there was an extensive, over 100-page cost-benefit analysis published by the Danish government looking at whether or not it would make sense to introduce a recommendation for universal Hep B vaccination among children, and they found that it did not come close to making health economic sense. And that is actually that's the written reason for their justification for not recommending universal Hep B vaccination at birth or for children at all in Denmark, and identifying groups that they see as high risk and then making that shared clinical decision making, but also making it clear to the public which groups they would see as high risk that may warrant vaccination of children in Denmark. And I'm not trying to give away what I'm talking about tomorrow, but I am going to be talking about that study and that topic tomorrow, not just for the hepatitis B vaccine, but the vaccination recommendations in general in Denmark. So,
I have one quick comment.
No, can I quick, please.
Oh,
I was just, thank you, Dr. Morris, for giving us.
And they have similar hepatitis B, almost very similar hepatitis B prevalence in Denmark as the United States has of chronic hepatitis B and among surface antigen positive mothers. Just FYI. Sorry, I wanted to add that since I just mentioned
Hillary.
it. That was important.
Yeah, just quickly, thanks, Dr. Morris, for sharing your frontline experience and working with parents. I have heard from numerous parents that have been kicked out of pediatrician practices, and I do have concerns about that. So I know we don't have any data on what that looks like across the country, but definitely have some concerns about parents who want to take different approaches and then have no other options because they aren't given that option. So.
Okay, I'm next going to call again on Dr. Adam Langer of CDC to speak to the Qidong hepatitis B intervention study. Sir.
Yes, thank you so much. Just want to circle back to some comments that Dr. Hoag brought up, I think. I apologize if I'm misattributing. With regard to the issue of whether or not there have ever been any long-term clinical trials that look at what the outcomes and sequelae of hepatitis B vaccination are more than a few days or even a few months. And in fact, there is a trial that was published out of China that has looked at, that has basically what happened was there was a shortage of vaccine in the mid to late 1980s. And so the Chinese government had to make decisions about which children in the cohort were going to be given an early age dose and which ones were not. So obviously when there's a lot of vaccine available, you would never want to do that. But in the shortage situation, it made sense, and they sort of treated it as an opportunity to study this question. And then later on, the group that did not get the vaccination series in early childhood was offered the vaccination series in adolescence. So you end up with three arms that you're following through time. One is the group that got the vaccine series very early in life, the group that got it in adolescence, and then the group that never got it. And they actually have been following these individuals for, I think, 35 to 40 years now. And what they have determined, number one, is that they are, one of their main outcomes is they're looking at primary liver cancer caused by hepatitis B virus. And if you look in the two vaccinated arms, especially the arm vaccinated early on, you see that the incidence of primary liver cancer in those individuals is considerably lower than the incidence in the individuals that were never vaccinated. So this just gets to the question that was brought up about what is the true length of efficacy of the vaccine. And there were some observational studies that were presented back in September, but there was some discussion earlier today about, well, is there actually a randomized controlled trial? And the answer is actually yes. And we have sent over the PDF of that article for the committee members to peruse overnight if you would like. The other point with regard to that study, getting into the discussion that we had about, well, if we want to talk about long-term efficacy, and Dr. Levy, this is actually something where I think you and I agree, so perhaps we should note that for historical purposes. You also do need to look at the possibility of adverse events long-term. And so that while they haven't published it, the group that is following these individuals, these arms in this controlled trial, is observing for any evidence of a differential in adverse events occurring between the vaccinated group and the unvaccinated group. And based on the information that I have been given, they have not found any reason to believe that the vaccinated group has any higher incidence of a particular adverse event than the unvaccinated group. So the data are actually available. They're not US data, so it's not ideal, but it is from another very large industrialized country.
A brief follow-up with the negative group. So negative at initial vaccination and then negative in follow-up. Is there a possibility of a selection bias because they're essentially non-compliant with the availability of the vaccine when it became available? Over.
So my understanding of the study is that the assignments into the arms were made at the village level, and so because of the fact that this that each village was randomized into receiving the vaccine or their young child cohort receiving the vaccine or not receiving the vaccine, you would not expect to see any selection bias.
Roger, thank you. Next, I call people with lived experience. Are we going to proceed to that? So I apologize to our affiliates that I now, facing the timeline crunch, have to proceed with listening to those persons' perspective that have relevant lived experience. How do we kick that off? Shu Wang. Shu Wang, are you available?
Yes, hi.
Thank you. Please proceed.
Great. Thank you for the opportunity to speak today. My name is Dr. Sue Wang, and I'm a physician living with hepatitis B. Hepatitis B is often discussed in numbers, but let's remember the people behind those numbers. There are countless stories of families, mothers, children, and generations whose lives have been changed by a virus we now have the tools to prevent. Today, I want to share some of those stories, my own stories I hear from families across this country, and our collective story. My mom likes to tell the story of my birth. They had taken a nice walk on Pensacola Beach in Florida, my hometown, and later that night, her water broke, and they rushed to the hospital for an emergency C-section. Because of her recovery, my grandparents stayed to care for me for a month. Only not that long ago, I learned that both of my parents, one a dentist and one a midwife, had gotten hepatitis B at some point and did not know at that time. I likely acquired it from them during that first month. Maybe it was some caregiver moment, like a small cut while handling my rash, or through trimming my nails and there was microscopic blood on the clipper. If there had been a universal birth dose at that time, I would have been protected. Of note, neither my sister nor my parents got hepatitis B from me. Much later, they were tested, vaccinated, and protected. This underscores how uniquely vulnerable infants are. If infected, 90% develop lifelong infections like me, compared with 10% of infected older adults and kids. I see patients with hepatitis B every day, and I hear stories from around the country. Newly diagnosed young adults who feel hopeless. Adults with no risk factors who are born in the US, the families have been here for generations, and they carry shame about being infected and worrying about dying early. Children who have lost their parents in their 40s to liver cancer, wishing that their dads were around for them as they grew up. Mothers who feel guilt and worry about their children's futures. These stories have shaped our national response and the decades-long focus on preventing childhood infection. Globally, we're in a race to hepatitis B and C elimination. This is a goal we can reach by 2030 if we implement all the right tools which have been discussed. From my experience coordinating hepatitis B programs and as a mother, all these pieces, maternal testing, antivirals, identifying status at the hospital, giving vaccine, HBIG after birth, and then testing the baby after they finish the Hep B vaccines, they involve really complex logistics. As a patient, I often had to tell people what tests to order for me and to make sure nothing was missed. I tasked my husband with his one job at the hospital to make sure our babies got birth dose before 12 hours because I had seen it missed in other kids. The health department had to call my pediatrician to remind them to order my kids' antibody test after vaccine series. Yet in the US, only about half of at-risk infants get this test to confirm they are protected and not infected. You can imagine there are many misses in our healthcare system, and risk-based approaches will create even more gaps. Ascertaining family members' Hep B status and history is not easy. It has taken me literally decades to piece together my own history, and I only very recently found out that my grandfather actually died of liver cancer. We already have recommendations to test women with unknown status at delivery, but gaps remain, especially in precipitous deliveries like my own, where there wouldn't be time to wait for results. If we delay the birth dose for 2 months, estimates predict 1,400 new infections, 482 new deaths, and an extra $222 million in healthcare costs a year alone. Our country has been a leader in Hep B prevention. The birth dose is now adopted in over 116 countries and growing, and only 33 do selected vaccination. While Denmark has great stats, they are not us. They have a universal healthcare system and have less than 20 acute Hep B cases a year. The US is more than 50 times their size and population, much more diverse, and we have a complex, not coordinated healthcare system. We also have more than 14,000 acute Hep B cases a year compared to their less than 20. I myself am a big supporter of shared decision or individualized decision-making with my patients. It's really important when options are equally reasonable. But in preventing hepatitis B transmission for a lifelong disease, the evidence is clear. Timely birth dose is a best practice, and it should remain our recommendation. And as always, there is the choice to opt out. My 4 children all received their Hep B vaccine and are Hep B free, which I'm eternally grateful for. But they would have been covered by a targeted strategy anyway. I'm here to advocate for all children. We cannot predict a child's future risk. Like seatbelts, our overall risk of getting into an accident are low, but we universally wear them because we cannot control the world around us. So let's do the same and continue to universally give every infant a hepatitis B free future. Thank you.
With appreciation and respect, thank you for sharing that. Michael Belkin, are you there?
Yes, can you hear me?
Yes, sir.
Okay, my name is Michael Belkin. I'm a graduate of the UC Berkeley Haas School of Business. Dean Rich Lyons, who is the dean, made the status, he said, question the status quo is the founding principle of UC Berkeley Business School. By the way, Dean Rich Lyons is now the chancellor of UC Berkeley. I'm a guest speaker occasionally at the business school. I have a background in statistics. I advise financial institutions with my models that I developed. And I'm at the Pierre Hotel actually at an investment conference at the moment. If you hear background noise, I apologize for it. So my daughter, Lila Rose Belkin, died at the age of 5 weeks, about 15 hours after receiving her second hepatitis B vaccine booster shot. Lila was a lively, alert 5-week-old baby when I last held her in my arms. Little did I imagine as she gazed intently into my eyes with all the innocence and wonder of a newborn child that she would die that night. She was never ill before receiving the hepatitis B shot. At her final feeding that night, she was extremely agitated, noisy, and feisty, and then she fell asleep suddenly and stopped breathing. The autopsy ruled out choking. The New York medical examiner ruled her death sudden infant death syndrome, SIDS. But the New York medical examiner, Dr. Persicino, neglected to mention Lila's swollen brain or the hepatitis B vaccine in the autopsy report. It was ignored. The coroner spoke to my wife and our pediatrician, and notes of the conversation were brain swollen, not sure cause yet, could not see how recombinant vaccine could cause problems. SIDS is a diagnosis of exclusion. It wasn't this, it wasn't that. Everything has been ruled out and we don't know what it is. In other words, they don't know. A swollen brain is not SIDS. Therefore, we had a falsified pathology report. Through conversations with other experienced pathologists, I subsequently discovered that brain inflammation is a classic adverse reaction to vaccination. Look it up in the Merck manual. It's the definition of a vaccine reaction. I set out to do an investigation of the Hep B vaccine and attended a workshop at the National Advisory Committee on Immunization Practices, February meeting, and a debate in New Hampshire. I also obtained the entire vaccine adverse events reporting system, VAERS, database on hepatitis B vaccine reactions, and have investigated thoroughly. These are my conclusions, supported by the following pages of text and analysis that's in my testimony, written testimony, which I submitted. 1, newborn babies are not at risk of contracting the hepatitis B disease unless their mother is infected. Hepatitis B is primarily a disease of junkies, gays, and promiscuous heterosexuals. The vaccine is given to babies because health authorities couldn't get those risk groups to take the vaccine. Adverse reactions outnumber cases of the disease in government statistics. Nothing is being done to investigate those adverse reactions. And I stand here testifying on behalf of all the others who have had the same problem. Those adverse reactions include numerous deaths, convulsions, and arthritic conditions that occur within days after hepatitis B vaccination. The CDC is misrepresenting hypothetical estimated disease statistics as real cases of the disease. The ACIP recommended new vaccines for premature infants without having scientific studies proving it is safe. I submitted a FOIA, Freedom of Information request, to the CDC along with the Association of American Physicians and Surgeons, Jane Orient, who was the head of it. They never responded. They never gave us the data saying that there were studies proving this was safe to give to newborns. The US vaccination recommendation process is hopelessly compromised by conflicts of interest with vaccine manufacturers who make huge profits, and the American Academy of Pediatrics and the CDC. Conclusion: if, as with the original rotavirus vaccine, which was pulled after a handful of adverse reactions, hepatitis B vaccine was recommended originally without scientific proof that it was safe in a broad sample of racially and genetically diverse babies less than 48 hours old before they established that recommendation, then the CDC has been experimenting on babies like guinea pigs. And this committee should suspend that universal at-birth immunization policy. Thank you.
My heart goes out to you. I hear the pain in your voice, and thank you for your diligence and your well-structured comments. With that, we need to proceed to the public comments period. Again, my apologies for our affiliates that we've not been able to get to all of you. The first, and these are timed, by the way. We have the clock timer, okay. So Miss Kayla, and I can't pronounce your last name. Kayla, are you there?
Yes, sorry, I'm here.
Thank you. Please proceed.
Yeah. Yes, thank you. Good afternoon. My name is Kayla and the Bandit, and I'm
in West Africa in 2014 through 2016. Through a concerted effort at CDC to support the Ministry of Health, the Ebola outbreak in DRC has been controlled, and the outbreak was declared over on November 30th, with 64 cases and 45 deaths. We are now supporting a 90-day enhanced surveillance period and an Ebola survivor program to monitor possible persistent asymptomatic infections. Unfortunately, there is a new outbreak of another viral hemorrhagic fever, Marburg disease, in Ethiopia, which was reported by the Ethiopian Ministry of Health on November 14th. As of December 2nd, there have been 13 confirmed cases, including 8 deaths. CDC staff from headquarters and CDC's Ethiopia country office are supporting the Ethiopia's efforts to respond to their first outbreak of Marburg. CDC deployers are supporting epidemiology and laboratory activities in the outbreak area, as well as response coordination and providing guidance on border health measures. The risk of this outbreak poses to the U.S. is low, and CDC is ready if viral hemorrhagic fevers like Marburg were to reach the U.S. On the domestic side, CDC is partnering with state public health officials, the California Department of Public Health Infant Botulism Treatment and Prevention Program, and the U.S. Food and Drug Administration to investigate a multi-state outbreak of infant botulism linked to infant formula. This is the first outbreak of infant botulism due to contaminated commercial infant formula reported to CDC. Infant botulism happens when a baby swallows Clostridium botulinum spores that grow in the gut and produce toxin. Infant botulism starts with constipation, but is usually first noticed as difficulty feeding, a weak and altered cry, and lack of head control. As of November 26, CDC and its partners have now identified 37 cases, all hospitalized, across 17 states. There have been no deaths to date. CDC's investigative team is working to collect additional information for infant botulism cases reported before August 2025, when the current outbreak was first identified. The most up-to-date information of this ongoing investigation is available on our website. That concludes my update. Thank you.
Thank you very much. Follow-up question regarding the Ebola outbreak. Are we still seeing good match between the recently licensed vaccine strains and the circulating Ebola virus, or are we having drift issues or other mismatch issues? Over.
Yeah, and this is a good question, and one something that we continuously monitor for, and there has not been a mismatch to date. You may also know that there's an investigative vaccine for the Marburg virus, and we are looking for the same thing, but also have not seen any mismatch to the vaccine for Marburg.
You're referring to the, I think it's the Serum Institute adenovector product, right, which is still, as you correctly point out, experimental. Thank you very much.
Robert, can I ask a question?
Please, Cody.
Yes. Thanks. It's a little hard being remote. I have a question for Dr. Limbago. On her, I believe you said there has been no person-to-person transmission of H5. And I think you're referring to the United States. Is that correct? Because there has been transmission elsewhere in the world. Am I correct?
Yes, I was. My entire presentation was in reference to the situation in the U.S.
Thank you.
Cody, are you good now?
Yes, sir.
Thank you, sir. Next we will hear from our colleagues at CMS in the land of Dr. Oz.
So he told me that he didn't have any updates.
No updates. Okay. But we've benefited from his advice and counsel a couple times already. And there's not much happening at the Food and Drug Administration, is there? You wish to share any recent events?
Nothing dramatic or salacious or anything has been happening at the FDA. No, it's just some minor things from CBER. I don't know. They're not minor related to vaccines. So we are revising our framework for safety surveillance of vaccines right now in CBER, so that we will be able to, so that we're going to be looking for more potential safety issues with vaccines. So basically widening the net of, potential outcomes that we're looking at, and looking at different methodologies. So we're less likely to miss potential safety issues with vaccines. So that's in the works right now. And actually currently we're already starting to use some different methodologies than we've used in the past. So that's exciting. And then there was a memo that many people know about that described COVID-19 vaccine deaths that did appear to be linked to the vaccine that were reported to VAERS. There was a full investigation that was done, 4 years ago, 4 years ago, a number of years ago, that wasn't, the results of which were not reported to the public. And so now it seems like some of those are going to be, sounds like they're going to be released to the public. The latest memo and look at these data were done by CBER staff. And so that should be coming imminently soon, more information on that. And it does highlight, the need to be more, so that we we actually use the information that we're gathering so that we're more transparent to the public with things like the VERIS database when we have information and explain sort of how we're using it and our, sense of the likelihood that deaths or injuries may be due to the vaccine or any vaccine and what we're seeing. And then there are going to be some changes that have been outlined to require better evidence for expanding indications of vaccines to populations such as pregnant women, younger children. So when you have an already approved vaccine, but you want to expand the population and indication, that it will also be requiring randomized control trial data so that we're more certain about the safety of these products in the different populations that they're used in. So I think I'll end with that.
Thank you, Dr. Hogue. I'm inferring that some of the more advanced, recently developed data analysis tools and capabilities are now going to be applied to the various existing databases, such as my old colleagues at the Office of the Commissioner and Chief Scientist had advocated a few years ago, is what I'm hearing. Are we here at ACIP, focusing on ourselves, are we, is it, in your opinion, is there going to be a need to consider how these policy changes will be impacting on our obligation to periodically reevaluate positions on existing products? I'm trying to ask the question, do we need to, is it the advice from our valued liaison at FDA that there's merit to ACIP focusing on the potential impact of some of these policy changes? Over.
Well, I mean, I think it would be good for the ACIP members to, be aware of what's happening with the FDA, and it may result in more frequent label changes and updates. And I would just say, hopefully the level of evidence that we're going to be generating in terms of both safety and efficacy will be better and more informative. And so I'm not exactly sure how it would, affect the ACIP other than to say it may lead to more rapid changes in recommendations, coming from ACIP and CDC.
Okay, so what I hear from that is that we should stay tuned and look and watch for specific modifications in current and future recommendations, but there's no reason for us to act proactively in any way to do threat assessment or mitigation as it relates to these changes. And if you'll permit me one small follow-up. The proposed changes, I infer, are likely to require modifications of the guidance to industry. Is that true? And if so, what kind of timeline might we expect for that?
So yeah, that would be true, that would typically involve, guidance to the industry. And I guess I don't necessarily want to speak on timeline if I'm not certain exactly what the timeline would be.
Okay, so to be determined, look forward to future briefings. You'll bring us up to speed on that. Is that fair?
Yes, and one more thought while I have the microphone. I just want to say that in relation to the reports in the VERIS database, and that I appreciate the fact that Retzef Levy gave the talk at the last meeting showing that deaths attributed to the COVID vaccine have been already acknowledged in multiple countries, in multiple peer-reviewed studies where it felt it was highly likely due to the vaccine, or autopsy, suggested with high certainty that it was. So it wasn't that it was unexpected that there would be deaths that are likely attributable to the COVID vaccine in the VERIS database. It was more a question of, when the information would come out. So I just wanted to make that clear.
Roger that. So now we turn to HRSA.
This is Reed Grimes with the Health Resources and Services Administration. No updates to share at this time. Thank you.
Thank you, sir. IHS.
Good afternoon. I'm Dr. Matthew Clark, representing IHS. The Indian Health Service continues to work closely with our federal, tribal, and urban Indian organization partners to mitigate the risk of vaccine-preventable illness in our vulnerable service population. IHS remains committed to raising health status and improving health outcomes in American Indian and Alaska Native tribal communities across a wide spectrum, from the promotion of healthy lifestyles to screening and prevention, supporting traditional culture and healing, and effective management of both acute and chronic diseases. As a comprehensive healthcare system for over 2 million American Indian and Alaska Native beneficiaries, vaccination is a key component to this broader strategy. We're working to advance this strategy across the age spectrum through proactive education, access, and respect for patient, family, and community values and priorities. Tribal communities face many unique challenges that impact access to effective preventive, clinical, and public health interventions. IHS seeks to collaborate with our tribal and tribal health partners to identify vaccine prevention priorities and to promote immunization best practices that meet the current needs in Indian country. Thank you, Mr. Chair, and I'll turn it back over to you.
Thank you very much. Follow-up question. Can you comment on availability of hepatitis B hepatitis B surface antigen testing in Indian health communities, since that's such a topic right now in today's meeting?
So testing is widely available, but I will admit that the turnaround time for results is limited, given the rural and remote location for many of our sites.
So I'm hearing that turnaround time may be days in many cases. Is that accurate?
It may be for our ambulatory care sites, not for our hospital sites.
So the hospital sites, am I understanding from that comment that at the hospital sites, you're likely to have near real-time testing available for expectant mothers?
Yes.
That's super news. Thank you for sharing that intelligence. The next is our colleagues at the National Institutes of Health. Do we have an NIH representative? I know he was on earlier today that can speak to us now.
Can you hear me?
Dr. Kurilla, I'm
yes.
glad to hear from you. Thank you. Please proceed.
Okay, sorry. Yes, no relevant updates from NIH at this time.
Thank you, sir. So with that, we have concluded agency updates. We've concluded updates on work groups, and we are now going to reopen discussion with our liaison members. Is that fair? And we had originally scheduled for adjournment at 3:45. Do you have any thoughts representing the CDC on how late we shall go today?
Robert, can I ask a question again? I'm sorry.
Oh, Cody, of course.
Yes. If Matthew Clark is still there, can you comment on the uptake of the monoclonal antibodies for RSV, clesrovimab, and nirsevimab for newborns in the Indian and Alaska areas?
Yes, sir. Dr. Meisner, I appreciate the question. So IHS has taken a very proactive approach to promoting monoclonal antibody immunization in our extremely vulnerable service population. As you know, the ACIP has recommended monoclonal antibodies for RSV, not only in the first season for newborn infants, but also universally among American Indian Alaska Native children up to 19 months of age in their second season. This is, as with all things Indian country, there are challenges when it comes to the logistics of of administering vaccines out in rural and remote locations. But you are probably aware of the fact that YKHC, Yukon-Kuskokwim Health Corporation, in the first season reported not only an effective vaccination strategy where literally they flew bush plane flights out to remote village locations on the YK Delta, but also a tremendous amount of vaccine or immunization effectiveness in preventing hospitalization in what is considered to be, if not the highest risk location in the world, at least the second highest risk location in the world for serious RSV disease. The overall implementation of RSV immunizations in Indian country varies by location, but I can tell you that working with our CDC colleagues, we've taken a very proactive approach to messaging. And generally speaking, we've had a good response from tribal communities.
And there are adequate supplies?
Yes, sir. So you may be aware that in the first season, especially and to some extent in the second season, there were limitations to the availability of nirsevimab. Incidentally, IHS has taken the position of promoting nirsevimab over clesrovimab because of the real-world efficacy data in tribal communities such as the one that I just referenced. But all American Indian and Alaska Native children up to their 19th birthday are eligible for vaccines for children. And we've been working very proactively with the VFC program and with our CDC partners to ensure access to all of the ACIP recommended vaccines and immunizations in Indian country.
That's wonderful news. Thank you.
Yes, sir.
Cody, you good?
Yes, sir.
Okay, so the advice from our CDC liaison is that we provide an additional half an hour for our liaison colleagues to share their perspectives on the current topics at hand, beginning with Flor Munoz. Flor, are you there still? She talked already? Okay, so Amy Middleman. Amy, are you there?
Hi, thanks so much.
Yeah, thank you.
Yep, I'm here. Thanks so much. Can you hear me?
Yes, ma'am.
Oh, good. Okay. So I want to just make two quick comments. The first one sort of leads into the second one, but I just want to make sure there have been a couple of people who have been noting that the vaccination, after the universal vaccinations for, I'm just trying to find the, give me 1 second, I'm just trying to find the graph that was being discussed. But there was a graph shown, and a couple of people have mentioned that after the universal birth dose, they've mentioned that the fact that in later adolescence and young adults, the fact that the rates have gone down somehow takes away from the efficacy of the universal birth dose. But this is where sort of historical vaccine policy knowledge is really important, because in the 1990s, of course, at the same time as the universal birth dose, there was also a recommendation, a risk-based recommendation for adolescents to be vaccinated against hepatitis B that also indicated and sort of showed us through experience that targeted recommendations did not work. So adolescent universal recommendations were promulgated in 1995 with catch-up for anyone up to age 18 in 1997. So I just want to make sure people understand that historically it's really important to understand the vaccination policy as we look through these data. Again, historically, I think that's why we've seen that ACIP, from the time that you all have, the committee had sort of pointed out that the original recommendation did not go through GRADE or ETR. It wasn't being done at the time. So I think that because we have evolved and learned over the last 20 years that this type of rigorous exploration of all of the data it is critically important before making a policy decision that affects millions of people. There's been a lot of data and some misinformation presented today and it becomes overwhelming and disorganized. It would be really helpful to see a comprehensive, organized presentation pertaining to these votes that really explore the risks and benefits of vaccination and any vaccination policy, any actual public health problem with the current practice that's being addressed, feasibility of the change, values, acceptability, resources. These decisions really affect a lot of people's lives, and we really are obligated to our countrymen to make sure that we do this in an organized process. We can't just dump a pile of unfolded laundry on the floor and then try to determine from that whether or not we need more t-shirts or more pants. We can't look at the pros and cons, the risks and benefits.
Amy, I appreciate this, but we are under tight timelines.
Can I respond to that?
Yes, you can.
Is there an urgency with the vote? I didn't understand. Is there an urgency that we're addressing with the
urgency,
problem of Hep B?
the urgency is that we have a number of other colleagues of yours that would also like to comment.
Great.
Retzef.
I'm done. Thanks so much.
Yeah, so
Thank you so much.
So thanks for the last comment. I actually think it's a great comment. I just want to build on that. So first, let me just clarify. The slide you pointed to is CDC data. It's not misinformation, just to make sure that everybody understands what data we're looking at. And this is a data that is used to make the assertion that the universal dose of Hep B that was instituted first in 1991 and was fully enforced in 2005 is responsible for the major decrease that we see in the overall number of acute cases in the US. This statement is factually not correct. And the way to see that is not correct is to notice which one of the colors are going down. And the colors that are going down are of ages that at the time, at the years that we are looking at, the babies that were vaccinated after 1991 were not on those age groups. These are older people. Now, you mentioned correctly that there were other interventions that were applied to the high-risk populations. And you're just reinforcing the sentiment of this of the proposed vote, which is to focus on the high-risk population, because that's what drives the reduction in cases. So we are in violent agreement, other than the fact that...
I'm sorry. I have to interrupt. We're not in agreement. The risk-based strategy to address adolescence was not successful, and that is why there was a universal recommendation in 1995. I'm only referring to the fact that you cannot use the fact that the rates went down in later teens and younger 20s as any example that the universal immunization recommendation for the birth dose was ineffective. That's my point.
I appreciate...
There were multiple issues, and they were all successful.
Yeah, can I may say that I appreciate your beliefs and feelings about this, but these beliefs and feelings are not supported by the data that was presented in front of us by the CDC. Anybody that would look on the graph that was provided by the CDC has to conclude that the reduction in cases is coming from age groups that were not relevant to the universal dose at the time when the decrease is observed. And that the only conclusion is that there are other interventions that I think were well targeted at the high-risk populations that caused that reduction. And very good that these policies were implemented. The inpatient that people had at the time in 1991, 5 years after they started these high-risk focus policies, and I think I also heard from some of your colleagues that we need to be patient with public health policies. I think we just showed impatience, and we rushed to essentially vaccinate every single baby in this country, something that other countries considered and concluded based on similar data that is highly not cost effective and potentially also carries serious risk of harm. So I appreciate beliefs and feelings, but the data presented to us by the CDC, not misinformation, is telling a different story than what you believe in.
This is not beliefs and feelings. This is looking at the data. And I will also, I'm sorry, my phone keeps going off.
Can agree to disagree on that and move on to
well, my main point is that if we could see all of these data organized in a reasonable fashion, in an evidence to recommendation fashion, where we could look at all of the data rather than cherry pick one or two studies, it's critically important for us to make a decision of this import to have all of the data laid out in front of us in an organized way that assesses all of the risks and benefits based on evidence and not anecdotes.
Thank you, Dr. Middleman.
I have a critical question here, and that is, Dr. Middleman said that risk-based administration did not work for adolescents, and that is a critical question before this committee for these considerations, because we're talking about moving to risk-based evidence. So please clarify for us what you mean by saying risk-based administration did not work. Please elaborate for us and help us understand that.
Are you talking to me?
Yes, please.
Amy, well, so it's been a long time. I don't have all of the specific studies at hand, but what I can tell you is that the recommendation was made in the early 1990s to try and immunize adolescents who were at risk, which meant that they were either in underserved areas or that they were engaging in high-risk behaviors. That failed to increase immunization rates because, for equity reasons, obviously those are the exact people who have less access to the provider, less access to doctors, and are not going to go specifically and answer those questions. So when the recommendation was changed, it was changed to a universal recommendation so that we could eliminate disparities and inequities and vaccinate everyone so that everyone remains safe. When we vaccinate the most vulnerable in our population, we have a much greater chance of eliminating the transmission of disease by this most vulnerable population. This has been shown in other, I defer to the CDC subject matter experts. Perhaps they'd like to join in on some of the additional data that's available that shows that risk-based recommendations do not usually work.
Appreciate that, Dr. Middleman. Appreciate the discussion, both of you. But right now, we're in a session where we're focusing on the liaisons, and we don't have a whole lot of time left. So in the interest of allowing your other liaison members to share their opinions, I ask that we please curtail this discussion now, which in my opinion seems to be going around and around and ending up that there's a broad disagreement on the interpretation of key data. So with that, we're now at Sandra Freihofer. Dr. Freihofer?
Thank you, Dr. Malone. I'm Sandra Freihofer, AMA liaison, and I'm speaking on behalf of the American Medical Association. A dose of hepatitis B vaccine at birth is crucial for protecting infants from perinatal and early postnatal transmission. Maternal infant transmission of hepatitis B virus results in chronic infection for 90% of infected infants, which can lead to liver disease, cirrhosis, liver cancer, and death. The birth dose of hepatitis B vaccine helps ensure universal protection for all newborns, even those with incomplete prenatal records, or even for those whose mothers may have missed maternal screening. The birth dose of hepatitis B vaccine has prevented more than 6 million hepatitis B virus infections and nearly 1 million hospitalizations for HPV-related diseases. The American Medical Association strongly urges ACIP to maintain its recommendations for a birth dose of hepatitis B vaccine. And on a personal note, I'm a mother and a grandmother. My boy-girl twins both had little babies right before Thanksgiving. Both moms were vaccinated against COVID, flu, and RSV during their pregnancy, and both of my new little grandsons got a birth dose of hepatitis B vaccine. So what I'm telling you is what I believe from my family. Thank you, Dr. Malone.
Thank you, Dr. Freihofer. Can you elaborate on the origin of the infections saved data that you're referring to? Are those data or are those the results of modeling studies?
Those are data that are from the American Medical Association, and I think we need to move on to our next liaison to give other people time to speak up.
I see. The next is Carol Hayes.
Yes, this is Carol Hayes with the American College of Nurse Midwives. I would just like to say that we, ACNM, completely supports what Dr. Freihofer just said, and the birth dose of hepatitis B is critically important for the newborns of this country. I also want to say that I've been a nurse midwife for almost 39 years, and I remember before these vaccines were around. I conducted a study in 1987 on pregnant women's assessment of their own risk for getting HIV, and you can probably guess what my data showed. We also have found that the resurgence of congenital syphilis is a good example of why risk-based approach is flawed. It is not in the best interest of most pregnant women and their newborns. I also want to say that I have seen clinicians and office staff in the clinic not differentiate between antibodies and antigens. And I know that to this group, that probably seems incredibly infantile, but I have seen it many times. Thank you for the opportunity to make a comment.
Roger that. Thank you. Ashley Halbritter.
Can I make one sentence comment?
Okay, fire away.
Sorry. I think one of the important points to remember is that hepatitis B is from a chronically infected mother is transmitted almost entirely at the time of birth. That is, only 1 or 2% of the cases are acquired in utero. It's during the birth process. So administration of intervention very soon after birth is really very, very critical.
And just to recap, I think there's broad consensus that that's the case. I don't think that's something that's a subject of disagreement on, that the HBs antigen positive mother there is a recommendation on administration of both immunoglobulin and vaccination at the time of delivery. I think that's a broad consensus that is not, I'm not aware of that being a subject of discussion.
But my point, the reason I say it is because there is a brief window of opportunity to prevent transmission from the mother to her baby.
But this is not a area of any disagreement. There's no disagreement on that point.
The baby is healthy, and if you treat it right away, you can make it. It's unlike CMV.
Once again, Cody, there is no disagreement on this point.
Okay, okay.
Fair enough. So Ashley Halbritter. Ashley, are you there? Okay, I apologize, Ashley, that we have outlived your patience. Barbara Resnick. Barbara, are you there?
Yes, no additional comments at this time.
Oh, bless your heart. Carolyn Ha. I'm hearing Carolyn a little bit, is that right? Carolyn, are you there? I guess not. Christine Hahn.
Yeah, hi, I'm a liaison from CSTE, but I did not raise my hand to speak.
Okay, I apologize. Judith.
It's okay.
Judith Schley.
Yeah, hi, I have a couple more comments that I wanted to make. I'm from NACHO, representing as a liaison to NACHO. One of the things that Dr. Nevison talked about older people having higher rates of hepatitis B in the data she was showing. And think of that as those are people now that maybe their grandparents that are coming over and that risk of horizontal transmission for a baby that did not get the hepatitis B birth dose. The second thing I wanted to bring up is I'm also a practicing physician, and we always, and I run immunization programs, we always do informed consent, even on vaccines that are recommended by the CDC, irrespective, as Dr. Morris spoke earlier. And the last thing I wanted to bring up was the health outcomes of the United States compared to other developed nations. We spend the most on healthcare costs, and our outcomes are the worst compared to other developed nations. So here we have a program that works quite well. Vaccines are very cost effective, and we can reduce any harm and protect the entire population. Thank you for your time.
Dr. Schley, I applaud your commitment to informed consent. It's something that we share. Did I understand you in your first comment that your interpretation of the paradoxical increase in hepatitis B infection and disease in the elderly is being driven by an immigrant population? Did I understand that correctly?
I didn't say that. I just said from the note, what Dr. Nevison said was it's going up in the older populations. And I just, then those people are at risk for transmission to others, including newborn babies, because, grandparents come over and see the kids, right? And
oh, that's what you meant by,
I
misunderstood. When you said come over, I was inferring that you were referring to immigrants, and in fact, you were referring to grandparents visiting their kids, something that's near and dear to my heart.
Well, that's a good, and it's sort of like the Tdap cocooning that we work on to cocoon the baby. So our mothers who are pregnant get vaccinated with Tdap, but we want to also have the whole family who's going to see that baby get vaccinated, so we don't give that child whooping cough before they can be protected. This is the same type of thing that if we're seeing it higher in older people, then they could transmit unknowingly to their
I appreciate the clarification and suggests that this issue of cocooning and vaccine recommendations for adults and elderly having to do with risk of transmission to neonates is a topic that ACIP should consider at some point, because it seems like there needs to be a recommendation there, in my opinion. Phyllis Arthur, you represent a fairly large constituency. What do you have to share with us?
Hi, Dr. Malone. Thank you so much for calling on me. Actually, unrelated to the discussion that's happening now, I was actually raised my hand to comment on your very nice discussion of the working groups that are going to be formed and the TORs that we should be expecting. And so I actually wanted to make a request and make sure this fits the FACA guidelines as have been discussed. In the past, as you said, the content of the discussions was not talked about at committee except for to drive recommendations. But the working group members on those working groups were posted on the CDC website. We saw the slide that you showed earlier. I would like to request that as the TORs are finalized for all working groups, that the names of the working group members again be posted on the website, just so we understand who is part of those closed door discussions. We'd also like to ask that the working groups potentially go back to having industry present in those closed work groups, so that you can ask some questions of each individual company that may be proprietary in nature. So those are just two requests with regard to process moving forward. Thank you.
Duly noted. And I have been educated today by our CDC liaison that the FAR does allow for discretion about disclosure of working group members. So we're going to have to put a process in place, I infer, in which we get authorization from working group members to have their names disclosed. But I very much appreciate your comments, Ms. Arthur. Now, we have Mike Ibarra. Up next, Mike, are you there?
Yes, thanks, Dr. Malone. Thanks for the opportunity to participate and for calling on me. My name is Michael Ibarra. I'm the Chief Medical Officer at Pharma, and I'm also an emergency physician. I practice clinically at a liver transplant center. So I just want to align with the comments made by the other liaison reps that were physicians that made comments about how the public may not realize how significant advanced liver disease and patients that come to the emergency department with complications often are among the sickest that we care for in the emergency department in the hospital. So this is a very serious conversation. I echo the comments made by my other liaison reps, including Ms. Arthur from Bio. We submitted formal comments to the docket that I just want to build on the point that Phyllis made in terms of appreciate sharing the committee's decision to update us on the composition of the work groups. We just encourage exploring ways to broaden the expertise and stakeholder participation in future work group conversations. So thanks for the opportunity to participate.
Thank you for your kind and well-reasoned use of language regarding this. I personally think that we're much better served if we approach these challenging issues as colleagues rather than in confrontation, which sometimes seems to be the case. I think unnecessary, in my opinion. I'm just editorializing. With that now, who are we missing? Sandra Freihofer, are you, have you been heard or is there additional information that you wish to share? Okay, then with that, our colleague,
Dr. Malone.
Yes, I'm just getting there, Jason. Patience is a virtue. Jason Goldman, please. I look forward to your additional comments.
Thank you, sir. Well, first, let me applaud you for your graciousness in allowing us to speak at the end of the meeting, given the time constraints. Not only am I president of the American College of Physicians, representing over 160,000 internal medicine specialists throughout the world, I am also a primary care physician in general internal medicine practice in my own office who vaccinates patients and deals with informed consent for every single thing we do that is part and parcel of primary care and internal medicine. So I have a few questions that I'd appreciate if the committee would consider in the upcoming vote. Given that your first vote speaks to the problem of a process based on anecdotes of patients not having informed consent, how does changing the recommendations and going against decades of data and safety and efficacy correct the problem of process of not having informed consent? That's question one. Number two, what analysis do you have on the projected outcomes that a change to the recommendations will have in terms of disease burden, financial cost, access to health care, health equity, recurrence of disease? Number three, the committee has made comments about the change being necessary because several stakeholders actually want this vote changed. Who are those stakeholders? How were they surveyed? Where is the data that shows they want it changed? What is the conflicts of interest? Also, number four, where are the liaisons on the work groups? Why have they been removed? So in other words, for the majority of these questions, they can be answered by the evidence to recommend framework, which looks at all of these issues as to why we should have a change and how we have that intervention and what are the downstream effects of everything we do. As has been echoed, primum non nocere, first do no harm. We need to make sure that we are acting in the best interest of our patients. So I appreciate the work to look at this, but can we please go back to a good, solid evidence to recommend framework where we answer all these questions and look at the potential outcomes so that we don't unnecessarily harm patients, given that the hepatitis B birth dose has been such a great success in reducing liver disease throughout the country. Thank you for your time.
Thank you, Jason.
Robert,
If I may take the privilege of the chair to answer the few of those questions that I think I have information on. Regarding the liaisons participating in work groups, I may be wrong in this, but my understanding is that the charter coming to us from the Federal Advisory Committee Act, Congressional Act, indicates that work group members may represent themselves, but they shall not represent, for instance, a interest group such as a physicians organization. So my understanding that was, and I'm glad that we have an opportunity to talk about this, because it's been widely the actions of the secretary have been widely misrepresented in various outlets. My understanding is that a lot of this was driven by FACA rules, and that individuals with expertise relevant to the topic of the working group that represent themselves it is allowed, this is my understanding of the FACA guidance, and we have had training in this, but that individuals representing the interests of some group, including an industry group, such as the various physicians organizations, is not consistent with the FACA guidelines. Do I understand that correctly? Yes, I get confirmation that in fact I'm not being stupid, and I did remember my training on the FACA rules. Let's see now, Retzef, I think you have some comments.
Yeah, so first, I think if you listened carefully to the presentation, there was actually clear discussion of surveys of patients that were unsatisfied with the current policy. We also talked with the fact that some people cannot send their children to daycare or cannot get clinical care. So maybe this is not the stakeholders that you are prioritizing, and I respect that. That's fair. That's why we have a discussion. But I don't think it's honest to say that these were not discussed. And the other thing that I would like to say is
drill down, sir.
Let me please finish. You usually speak quite a lot for a long time, and please let me finish, because it takes time also to address back your questions. You ask a few questions, I want to answer them. So we are using the ETR and the grade as some magic words. But I just want to share two observations about the ETR and the grade. The first of which is that the ETR and the grade were used to support, approve, push, and recommend these vaccines to highly low-risk, healthy children against SARS-CoV-2. Something that I think is one of the most outrageous decisions historically. So I'm not sure I buy the concept that ETR and grade guarantees cannot be abused to actually justify using very low quality data to justify whatever recommendation you want. We don't have ETR like we assume in advance what we are going to recommend. I think that this work group, like the other work groups, considered many opinions, had a diverse set of perspectives, considered all the data that was provided by the CDC, went well beyond that, and did work that I don't think has been done in any of the recent votes that we've seen in the prior ACIP groups, and definitely not the decisions of ACIP that instituted many of the policies that we currently discuss. So with all due respect, it will be much better to argue about what facts and what assumptions you disagree with than to keep coming back and suggest that the people in front of you are not doing serious work. I reject that. With all due respect, I reject that assertion.
You need to be honest and truthful.
We are honest and truthful just as you are, sir.
We're talking about hepatitis B, not COVID. We're talking about a framework that is applied to all decisions.
But
why are you bringing
if I may interject, Dr. Goldman, we have all the members here. You are not privileged to the fact that we have had specific training in grade from specialists. And one of the observations is that that system is very dependent on the integrity of the data available to and the breadth of the data available to address the question. And I'm sure you're very familiar with that because you're very experienced, and you know that to be frank, it's a problem well known in the information technology space that if we have low quality data, we get low quality decisions. There's a acronym GIGO that is less pleasant in making that point. I wish to, I've been updated regarding the liaison removal question. And I want to share this because we're on the public record and we have various colleagues here from the press. In 2010, the CDC began implementing the removal of all liaisons from FACA committees within the CDC. So this was not a new initiative with the last election. This has been ongoing since 2010. ACIP was one of the few that didn't remove liaison members from the working groups. So that was in contrast to the vast majority of the FACA committees that exist within the CDC, of which this is just one. In June 2025, there was a decision to correct that and to ensure that the ACIP was in alignment with the policies and procedures of the Federal Advisory Committee Act. And I can attest that we have had specific training and commentary from the CDC's FACA expert that has guided these changes and our implementation. So this is not, it's not random, it's not arbitrary, it's not capricious. It's a part of an attempt by the CDC begun in 2010 to bring all of the CDC advisory committees, of which ACIP is only one, in compliance that were previously not in compliance with the Federal Advisory Committee Act, the FACA. And so, again, there's no discrimination here against the various, I'm trying to choose my words, the various medical practitioner specialty organizations and boarding organizations, but rather a systematic attempt to methodically bring Advisory Committee on Immunization Practices in alignment with both CDC policy and congressional FACA policy, which is what impanels the ACIP and the other FACA committees. So with that diatribe, forgive me, but I appreciate the opportunity to share that information. We will adjourn for today.
That was excellent. I need to jump in on the evidence to recommendations question, as it is fundamental and critical to our process. For many weeks now, I have been advocating in our committee that we have a scientific framework for making our decisions, because if we don't have a scientific framework, they are susceptible to
and we have heard your comments, so, and please understand that there is a process in place.
Please do not interrupt me. Please do not interrupt me. Yes, it is the critical issue for us has been, should there be a scientific framework or should there be no scientific framework? As we discussed a scientific framework, I opened the question as to whether or not there is a better scientific framework than GRADE or ETR. No valid scientific frameworks were proposed. We have subsequently been trained in both the GRADE and ETR processes, and I hope that we should use them to formulate our questions so that we don't have any more grand confusions about what the critical questions are that we're doing. So we are moving towards using the ETR process. The training came a little bit late for this meeting, but we hope to be using that. Retzef is right. Anything can be abused. Anything can be distorted, but it is better than having no scientific framework whatsoever.
Thank you for sharing your perspective. With that, we're adjourned for the day, and we convene tomorrow at what time, Mina? 8:30. So for those interested, I look forward to seeing you tomorrow at 8:30.